Anemia in the Elderly: Diagnosing, Managing, and Improving Quality of Life for Seniors, written by Julie Hord, narrated by Graziella Newson. Chapter 1: Understanding Anemia in the Elderly. Anemia in older adults is a complex and often overlooked health condition that can significantly affect quality of life. As people age, changes in the body can alter the way blood is produced and maintained, making seniors more susceptible to developing anemia. It is not just a standalone issue. Rather, it is often a reflection of underlying health concerns such as chronic diseases, nutritional deficiencies, or diminished bone marrow function. In simple terms, anemia occurs when there is a decrease in the number of red blood cells or the amount of hemoglobin in the blood. Hemoglobin is the protein responsible for carrying oxygen to tissues, and when its levels are low, the body's organs and muscles may not get the oxygen they need to function properly. This lack of oxygen can result in fatigue, weakness, and reduced stamina, symptoms that can easily be mistaken for normal signs of aging. However, the consequences of anemia in seniors can extend beyond tiredness. It can lead to cognitive impairment, decreased physical performance, a higher risk of falls and fractures, and increased dependency in daily activities. In more severe cases, anemia has been associated with higher hospitalization rates and mortality. One of the challenges in addressing anemia in the elderly is that its symptoms are often subtle or masked by other age-related conditions. For instance, a senior who is experiencing confusion or lethargy might be evaluated for neurological issues, while anemia could be the underlying cause. That's why routine blood testing and a keen awareness of the signs are essential in older populations. Understanding anemia in the elderly involves not only recognizing what it is, but also appreciating the unique way it presents in this age group. It requires healthcare providers and caregivers to look beyond the surface and consider how even mild anemia might be affecting a senior's overall health. With proper attention and care, many cases of anemia in older adults can be effectively managed, leading to improved well-being and a better quality of life. What is anemia? Anemia is a condition marked by a decrease in the number of red blood cells or the amount of hemoglobin in the blood, which impairs the blood's ability to carry oxygen throughout the body. This reduction in oxygen transport can lead to fatigue, weakness, and a variety of other symptoms that may significantly affect daily functioning, especially in older adults. In the elderly population, anemia is particularly common and often goes underdiagnosed because its symptoms can be subtle or mistaken for normal signs of aging. Shortness of breath, pale skin, dizziness, and cognitive difficulties are some of the signs that may suggest anemia, but are frequently attributed to other health issues or simply to getting older. However, untreated anemia in seniors can lead to a decline in physical performance, increased risk of falls, hospitalizations, and even mortality. There are many underlying causes of anemia, and identifying the root cause is essential to providing effective treatment. In seniors, common causes include chronic diseases, nutritional deficiencies such as iron, vitamin B12, or folate, and bone marrow disorders. Sometimes, anemia may even signal the presence of more serious conditions like gastrointestinal bleeding or cancer. Diagnosis typically involves a complete blood count, CBC, to measure hemoglobin levels, along with additional tests to pinpoint the specific cause. Once identified, treatment varies based on the underlying condition. It may include dietary changes, supplements, medications, or managing chronic diseases more effectively. Understanding anemia and recognizing its potential impact on older adults is the first step toward improving their health outcomes. Through early detection and targeted care, seniors can maintain better energy levels, cognitive function, and quality of life. The aging body and blood health. As the body ages, nearly every system undergoes physiological changes, and the hematologic system is no exception. Blood health, which includes the production, function, and lifespan of blood cells, is crucial for overall vitality. In elderly individuals, these processes can become less efficient, contributing to the development of anemia and other blood related conditions. One of the most significant age related changes in the body is a gradual decline in bone marrow function. Bone marrow is the primary site of red blood cell production. With age, the marrow becomes less cellular and more fatty, reducing its capacity to produce adequate amounts of red blood cells. This diminished output doesn't always lead directly to anemia, but it can make the body less resilient when other stressors, like illness or nutrient deficiencies, arise. Another factor affecting blood health in older adults is a decrease in the body's ability to absorb and utilize essential nutrients. For example, vitamin B12 absorption declines due to changes in stomach acid production and gastrointestinal function. Folate and iron levels may also be affected by dietary habits, chronic illnesses, or medications common in older populations. These nutrient deficiencies can impair the body's ability to produce healthy red blood cells, gradually leading to anemia. The circulatory system also undergoes changes with age. Blood vessels may become less flexible, and the heart's efficiency in pumping blood can decrease. While these changes are more closely related to cardiovascular health, they interact with blood quality and oxygen delivery, compounding the effects of low red blood cell counts when anemia is present. Chronic low-level inflammation, often seen in the elderly, also affects blood health. Inflammatory cytokines can interfere with iron metabolism and reduce the responsiveness of the bone marrow to erythropoietin, the hormone that stimulates red blood cell production. This condition, known as anemia of chronic disease, is one of the most common types of anemia found in older adults. Understanding how aging impacts the blood helps to clarify why anemia is so prevalent among seniors and why it can be more difficult to treat. It's not always about a single cause, but often a combination of physiological decline, nutritional issues, and underlying medical conditions. Supporting blood health in the aging body requires a proactive approach, monitoring nutrient levels, managing chronic diseases, and staying alert to even mild changes in energy or cognitive function. With early detection and appropriate care, many of the complications associated with aging and blood health can be minimized. Prevalence and an impact in older adults. Anemia is a common but frequently underrecognized condition in the elderly, with its prevalence increasing significantly with age. Studies estimate that up to 10% of community-dwelling adults over the age of 65 are anemic, while the numbers rise to as much as 50% in hospitalized or institutionalized elderly individuals. Despite its frequency, anemia in older adults is often mistaken for a natural part of aging or overshadowed by other chronic conditions, leading to delays in diagnosis and treatment. The impact of anemia on older adults is both broad and profound. Physically, anemia contributes to fatigue, weakness, and decreased exercise tolerance, all of which can severely affect mobility and independence. Tasks that were once routine, walking, climbing stairs, even standing for prolonged periods, may become increasingly difficult. This loss of function not only reduces quality of life, but also increases the risk of falls, injuries, and subsequent hospitalizations. Cognitively, anemia has been linked to impairments in attention, memory, and executive function. Seniors with anemia are more likely to experience confusion, slower processing speeds, and even symptoms resembling dementia. These cognitive changes can interfere with self-care, medication management, and decision-making, further complicating the management of other medical conditions. Emotionally, the chronic fatigue and limitations caused by anemia can lead to depression, social withdrawal, and feelings of helplessness. For many seniors, these emotional impacts are just as significant as the physical symptoms. Living with untreated anemia may result in a gradual withdrawal from activities they once enjoyed, which can, in turn, accelerate physical and cognitive decline. From a healthcare perspective, the presence of anemia in older adults is associated with increased rates of hospitalization, longer recovery times, and higher overall healthcare costs. Anemic seniors are also at greater risk of complications during surgeries and are more vulnerable to infections and other acute illnesses. Importantly, anemia is often a signal that something else is wrong. Whether it's a sign of nutritional deficiency, chronic inflammation, kidney disease, or even cancer, identifying and addressing the underlying cause is critical. Recognizing the prevalence and wide-reaching impact of anemia in older adults emphasizes the need for routine screening and proactive management. Early detection, combined with targeted treatment and a multidisciplinary care approach, can significantly improve outcomes and help seniors maintain a higher quality of life. Chapter 2: Causes and Types of Anemia in Seniors. Anemia in seniors is often multifactorial, stemming from a variety of underlying conditions and age-related changes in the body. Unlike in younger individuals, where a single cause is often identifiable, anemia in the elderly frequently results from a combination of nutritional deficiencies, chronic diseases, and diminished bone marrow responsiveness. Understanding these causes and the specific types of anemia they lead to is essential for accurate diagnosis and effective treatment. One of the most common causes is iron deficiency anemia, which occurs when the body lacks enough iron to produce adequate hemoglobin. In older adults, this deficiency may be due to poor dietary intake, chronic blood loss, often from gastrointestinal bleeding, or impaired iron absorption. Conditions such as ulcers, diverticulosis, or colon cancer can contribute to ongoing unnoticed blood loss, making regular screening crucial. Another major category is anemia of chronic disease, also known as anemia of inflammation. This type is often seen in elderly individuals with long-term health conditions such as kidney disease, diabetes, rheumatoid arthritis, or cancer. Chronic inflammation affects the body's ability to use iron effectively and suppresses red blood cell production in the bone marrow. While iron levels may appear normal or slightly low, the body is unable to mobilize these stores for effective red blood cell formation. Vitamin B12 and folate deficiency anemia is also common in seniors due to both dietary limitations and decreased absorption. Aging can reduce stomach acid production, impairing the release of vitamin B12 from food. In some cases, pernicious anemia, a condition in which the body lacks intrinsic factor needed to absorb B12, can develop. Folate deficiency is often related to malnutrition or chronic alcohol use and can lead to similar symptoms, including fatigue, weakness, and neurological changes. In some cases, anemia may result from bone marrow disorders such as myelodysplastic syndromes, in which the bone marrow produces blood cells abnormally. These conditions are more prevalent in the elderly and often require specialized evaluation and treatment. Medications can also contribute to anemia in seniors, particularly those that affect the gastrointestinal system or bone marrow function. Additionally, unexplained anemia, a diagnosis given when no clear cause is found despite thorough investigation, is relatively common in older adults and may reflect subtle age-related changes in hematopoiesis. Recognizing the diverse causes and types of anemia in seniors is vital for creating a tailored treatment plan. Because anemia often signals an underlying problem, identifying the specific type helps guide further testing, management, and long-term care planning. Iron deficiency anemia. Iron deficiency anemia is one of the most frequently encountered types of anemia in older adults. It occurs when the body lacks sufficient iron to produce adequate amounts of hemoglobin, the protein in red blood cells responsible for carrying oxygen. Without enough hemoglobin, tissues and organs don't receive the oxygen they need, resulting in symptoms such as fatigue, weakness, shortness of breath, and pale skin. In seniors, the causes of iron deficiency anemia often differ from those seen in younger individuals. While poor dietary intake of iron may play a role, it is usually not the primary factor. More commonly, chronic blood loss, especially from the gastrointestinal tract, is responsible. Conditions like peptic ulcers, gastritis, diverticulosis, or colorectal cancer can lead to slow, persistent blood loss that depletes the body's iron stores over time. In many cases, this bleeding goes unnoticed until anemia becomes severe enough to cause symptoms or is identified through routine blood tests. Another contributor is reduced iron absorption. As people age, the stomach produces less acid, which is necessary for iron absorption. Certain medications, including proton pump inhibitors and antacids, can further impair this process. Additionally, some chronic diseases and inflammatory conditions can alter the way the body processes and uses iron, compounding the deficiency. Diagnosing iron deficiency anemia in the elderly requires a comprehensive approach. A complete blood count, CBC, will typically show low hemoglobin and hematocrit levels, along with smaller than normal red blood cells, microcytosis. Iron studies measuring serum ferritin, serum iron, total iron binding capacity, and transferring saturation are essential to confirm the deficiency and rule out other causes. Treatment focuses on correcting the iron deficiency and addressing the underlying cause of blood loss or poor absorption. Oral iron supplements are often the first line of treatment, but they can cause gastrointestinal side effects like constipation, nausea, and abdominal discomfort, which may be more difficult for older adults to tolerate. In such cases, intravenous iron therapy may be considered. Dietary adjustments to include iron-rich foods, such as red meat, leafy greens, beans, and fortified cereals, can also support recovery. Ultimately, managing iron deficiency anemia in seniors requires ongoing monitoring. Even after levels are corrected, the underlying cause must be resolved to prevent recurrence. Regular follow-up, and when necessary, referrals for gastrointestinal evaluation can ensure that more serious conditions are not overlooked. With appropriate treatment, most seniors can experience a significant improvement in their symptoms and overall energy levels. Anemia of chronic disease. Anemia of chronic disease, also known as anemia of inflammation, is the second most common type of anemia in the elderly. It occurs not because of a lack of nutrients, but due to the body's response to long-standing medical conditions, such as chronic infections, autoimmune disorders, cancer, or kidney disease. In these cases, the body alters iron metabolism and suppresses red blood cell production as part of an inflammatory response. In older adults, many of the conditions that become more prevalent with age, like rheumatoid arthritis, congestive heart failure, diabetes, and chronic kidney disease, can contribute to this type of anemia. These illnesses trigger the immune system to release inflammatory cytokines, which in turn interfere with erythropoiesis, the process by which red blood cells are produced in the bone marrow. At the same time, iron becomes sequestered in storage sites and is less available for making hemoglobin, despite iron levels in the body often being normal or even elevated. One of the hallmark features of anemia of chronic disease is its subtle presentation. Hemoglobin levels are usually mildly to moderately low, and symptoms may develop gradually. Fatigue, decreased exercise tolerance, and general weakness are common complaints, but these can easily be mistaken for the effects of aging or the underlying illness itself. For this reason, anemia of chronic disease often remains undiagnosed until routine lab work reveals it. Laboratory findings in this type of anemia typically show low hemoglobin and hematocrit, normal or increased ferritin levels, an indicator of iron stores, and low serum iron with low transferrin saturation. This pattern helps distinguish it from iron deficiency anemia, which shows low ferritin and a true lack of stored iron. Treating anemia of chronic disease can be challenging because the focus must be on managing the underlying condition. In many cases, treating the chronic illness helps improve the anemia. When that's not possible or when symptoms are particularly troublesome, treatment options may include erythropoiesis-stimulating agents, ESAs, especially in patients with chronic kidney disease. These medications stimulate the bone marrow to produce more red blood cells, but must be used carefully due to potential side effects, including increased risk of blood clots. Addressing nutritional status and ensuring adequate levels of iron, B12, and folate remains important, even if they are not the primary cause. A comprehensive approach, including close coordination between primary care and specialists, can help improve energy levels, reduce complications, and enhance the quality of life in seniors living with anemia of chronic disease. Vitamin B12 and folate deficiency. Vitamin B12 and folate deficiency are important and often overlooked causes of anemia in older adults. These two nutrients are essential for DNA synthesis and red blood cell production. When either is deficient, the bone marrow cannot produce healthy red blood cells, leading to a condition known as megaloblastic anemia. This form of anemia is characterized by the production of abnormally large and immature red blood cells, which function poorly and have a shortened lifespan. In the elderly, vitamin B12 deficiency is especially common due to age-related changes in digestion. As people age, the stomach produces less acid, which is necessary to release vitamin B12 from food. Additionally, conditions such as atrophic gastritis or the use of acid-reducing medications can further impair B12 absorption. Another significant cause is pernicious anemia, an autoimmune condition that prevents the absorption of B12 in the small intestine due to a lack of intrinsic factor, a protein produced in the stomach. Folate deficiency, while less common than B12 deficiency, can still occur in seniors due to poor dietary intake, alcohol use, or malabsorption syndromes. Certain medications, including anticonvulsants and chemotherapy drugs, may also interfere with folate metabolism. Symptoms of vitamin B12 and folate deficiency anemia may develop slowly and often overlap with other health issues. Common signs include fatigue, weakness, shortness of breath, and pale skin. However, vitamin B12 deficiency is also associated with neurological symptoms that can be mistaken for age-related cognitive decline. These may include numbness or tingling in the hands and feet, balance problems, memory loss, and even mood changes like depression or irritability. Diagnosis involves measuring serum levels of vitamin B12 and folate, along with a complete blood count that typically shows enlarged red blood cells, macrocytosis. In some cases, additional tests like methylmalonic acid, MMA, or homocysteine levels may be ordered to confirm a subtle deficiency. Treatment is straightforward once the deficiency is identified. Vitamin B12 can be administered through oral supplements or intramuscular injections, depending on the severity and cause of the deficiency. Folate is usually replenished with oral supplements and dietary improvements. It's important to treat both appropriately, as giving folate alone in a B12 deficient patient can improve anemia while allowing neurological damage to progress. Early recognition and correction of vitamin B12 and folate deficiencies can reverse anemia, improve energy levels, and prevent long-term neurological complications. For older adults, routine monitoring of these nutrients is a simple but powerful step in maintaining both physical and cognitive health. Chapter 3: Signs and Symptoms of Anemia in Older Adults. Anemia in older adults can present with a wide range of signs and symptoms, many of which are subtle and easily mistaken for normal aging or existing health conditions. Because of this, anemia often goes unrecognized in seniors until it becomes more severe. Understanding the specific ways anemia manifests in this population is crucial for timely diagnosis and effective management. One of the most common symptoms of anemia is fatigue. Seniors may report feeling unusually tired or lacking the energy to carry out daily activities. This fatigue is due to the decreased oxygen carrying capacity of the blood, which leaves muscles and organs deprived of the oxygen they need. As a result, even light exertion can lead to exhaustion, and rest may not fully relieve the sense of tiredness. Weakness and reduced physical endurance often accompany fatigue. Older adults with anemia may find it difficult to walk long distances, climb stairs, or even perform basic self-care tasks. Muscle weakness and poor coordination can increase the risk of falls, which is especially concerning in a population already vulnerable to fractures and mobility issues. Shortness of breath is another key symptom, particularly during physical activity. Because the blood is not transporting enough oxygen, the heart and lungs work harder to compensate, leading to feelings of breathlessness. This can occur even with minimal effort and may contribute to anxiety or reluctance to engage in exercise. Pale or sallow skin, especially noticeable in the face, lips, and nail beds, is a classic sign of anemia. In some cases, the skin may appear cool or clammy. A rapid or irregular heartbeat may also be present, as the heart tries to pump more blood to make up for the reduced oxygen content. Over time, this increased cardiac workload can contribute to or worsen heart disease. Cognitive changes are a lesser known but significant manifestation of anemia in older adults. These can include confusion, difficulty concentrating, memory lapses, and general mental sluggishness. Such symptoms are often attributed to dementia or age-related decline, but anemia should be considered, especially if they appear suddenly or worsen rapidly. Other signs may include dizziness, headaches, cold hands and feet, and chest pain, particularly in individuals with existing cardiovascular conditions. Recognizing these symptoms early and relating them to possible anemia rather than aging alone can lead to earlier interventions, improved quality of life, and better overall outcomes for seniors. Physical and cognitive manifestations. Anemia in older adults not only impacts their physical health, but also has notable effects on cognitive function. These manifestations can significantly alter an individual's quality of life and may be mistaken for typical signs of aging or other medical conditions, making early recognition critical for effective treatment. Physically, one of the most prominent signs of anemia is fatigue. Due to reduced oxygen carrying capacity in the blood, individuals with anemia often experience an overwhelming sense of tiredness, even after minimal physical exertion. This fatigue can prevent seniors from engaging in daily activities they once found easy, such as walking, climbing stairs, or performing household chores. The resulting decrease in activity levels can further contribute to muscle weakness and diminished physical stamina, setting off a cycle that worsens their overall health and mobility. Weakness is another significant physical manifestation of anemia. Without enough red blood cells to deliver oxygen to muscles, seniors may feel a sense of heaviness in their limbs or may struggle to maintain normal strength. This can lead to difficulty with balance and coordination, increasing the risk of falls and fractures, particularly in frail elderly individuals. Furthermore, shortness of breath often accompanies anemia, especially with physical exertion. The heart and lungs must work harder to compensate for the lack of oxygen, which can leave a senior feeling winded or unable to engage in activities that once seemed easy. Cognitive symptoms of anemia are perhaps less obvious, but can be just as debilitating. Seniors with anemia often experience difficulty concentrating, memory lapses, and slower thinking. These cognitive effects occur because the brain, like the muscles and organs, is deprived of oxygen, which is necessary for proper function. In some cases, seniors may experience confusion or mild cognitive impairment, which can be mistaken for early signs of dementia or Alzheimer's disease. However, cognitive dysfunction caused by anemia tends to improve when the underlying condition is treated, unlike the progressive decline associated with neurodegenerative diseases. In addition to memory and concentration issues, seniors with anemia may also exhibit changes in mood, such as increased irritability or feelings of depression. The constant fatigue and physical limitations, combined with the strain on cognitive function, can lead to emotional distress. This emotional toll can contribute to social withdrawal, further diminishing the individual's quality of life. Both physical and cognitive manifestations of anemia can severely affect an older adult's independence and overall well-being. Recognizing these signs early and seeking appropriate treatment can make a significant difference in maintaining a senior's physical health, cognitive function, and emotional stability. Overlapping symptoms with other conditions. One of the challenges in diagnosing anemia in older adults is that its symptoms often overlap with those of other common age-related conditions. Fatigue, weakness, shortness of breath, and cognitive difficulties are not unique to anemia. They can also be indicative of other health problems that are prevalent in the elderly. This overlap makes it crucial for healthcare providers to carefully consider all potential diagnoses and conduct thorough evaluations to differentiate between anemia and other conditions. Fatigue, for example, is one of the most common and nonspecific symptoms in seniors. It can be caused by anemia, but it is also a hallmark of many chronic diseases such as heart failure, diabetes, chronic kidney disease, and depression. In some cases, fatigue may be related to medication side effects or sleep disturbances. For instance, older adults often take medications that can cause drowsiness or interfere with sleep patterns, which can contribute to tiredness that may be mistaken for anemia. Additionally, heart disease can lead to feelings of fatigue and weakness due to decreased cardiac output, which mimics the symptoms of anemia. Cognitive decline, including memory problems, difficulty concentrating, and confusion, is another symptom that is often shared between anemia and other conditions. While anemia can impair brain function due to reduced oxygen delivery, these same cognitive issues are characteristic of dementia, Alzheimer's disease, and other neurodegenerative conditions. Cognitive changes related to anemia typically improve with treatment, whereas those related to dementia tend to worsen over time. However, distinguishing between the two can be challenging, especially in seniors who have multiple health conditions. Shortness of breath is another symptom that may be associated with both anemia and other cardiovascular or pulmonary diseases. For example, heart disease and chronic obstructive pulmonary disease, COPD, can also cause a reduction in oxygen supply to tissues, leading to breathlessness. Anemia exacerbates these symptoms by compounding the body's inability to deliver sufficient oxygen, making it harder for healthcare providers to discern whether the shortness of breath is due to anemia alone or is the result of an underlying heart or lung issue. Furthermore, the presence of chronic inflammation due to conditions like rheumatoid arthritis or infections can lead to anemia of chronic disease, where anemia is secondary to another health problem. In such cases, the symptoms of anemia are often overshadowed by the primary condition, further complicating the diagnosis. Given the complex nature of aging and the range of overlapping symptoms, a comprehensive evaluation is critical for properly diagnosing anemia and distinguishing it from other potential health concerns. Early detection and targeted treatment can improve outcomes and help seniors regain their vitality and independence. Recognizing subtle or atypical presentations. Anemia in older adults often presents in subtle or atypical ways that can be easily overlooked or misattributed to the normal aging process. Unlike in younger individuals, where anemia is frequently characterized by clear and pronounced symptoms like fatigue or pallor, older adults may experience more gradual, subtle changes that are not immediately recognized as related to anemia. These atypical presentations make it crucial for healthcare providers to maintain a high level of suspicion, especially when managing seniors with multiple comorbidities. One of the challenges in recognizing anemia in older adults is that its symptoms may develop slowly and gradually, which often leads to patients simply adapting to their reduced energy levels. Seniors may not complain of fatigue or weakness outright, but instead may demonstrate a decrease in activity levels or report that they are slowing down as they age. This can be mistakenly attributed to the natural process of aging rather than an underlying medical condition. Additionally, anemia-related fatigue may not always present as overwhelming exhaustion, but as a more insidious, persistent lack of vitality that gradually worsens over time. Cognitive changes are another subtle manifestation of anemia that can be misinterpreted as part of the normal aging process or early dementia. Seniors with anemia may exhibit poor concentration, forgetfulness, and difficulty processing information, which are commonly seen in dementia or other cognitive disorders. However, unlike in dementia, cognitive dysfunction caused by anemia tends to improve once the anemia is treated. In some cases, seniors may not even be aware that their thinking and memory are affected, which can delay diagnosis and treatment. In other cases, anemia may present with nonspecific symptoms such as irritability, mood swings, or depression. The emotional toll of living with untreated anemia, including physical discomfort and reduced independence, can lead to feelings of frustration and sadness. This emotional strain can be mistakenly viewed as a standalone mental health issue rather than a symptom of anemia. Furthermore, anemia may also contribute to sleep disturbances, leading to complaints of insomnia or restless nights, which can further complicate diagnosis. Atypical presentations can also involve physical signs such as subtle changes in skin tone or a mild, unremarkable heart murmur. Pale or yellowish skin may go unnoticed in older adults, especially if they have fair complexions or existing skin conditions. Similarly, a mild increase in heart rate or slight breathlessness may be dismissed as signs of aging or physical deconditioning, rather than recognizing them as symptoms of anemia. To effectively recognize anemia in older adults, healthcare providers must maintain a high index of suspicion and consider anemia as a potential cause for any new or unexplained physical or cognitive decline. Routine screenings and a comprehensive assessment of symptoms, including those that may seem unrelated, are vital for early diagnosis and treatment, ultimately improving the quality of life for seniors. Chapter 4: Diagnostic Approaches and Challenges. Diagnosing anemia in older adults presents unique challenges due to the subtleties and variability of symptoms, as well as the presence of multiple comorbid conditions that may mask or complicate the diagnosis. Accurate and timely diagnosis is crucial for effective treatment, as anemia can significantly impact the quality of life in seniors and may be indicative of underlying health issues. To ensure that anemia is identified early and appropriately managed, healthcare providers must employ a thorough, multifaceted diagnostic approach. The first step in diagnosing anemia is to conduct a comprehensive clinical assessment. Healthcare providers must carefully evaluate the patient's medical history, including the presence of chronic conditions such as kidney disease, diabetes, cardiovascular disease, gastrointestinal disorders, or autoimmune diseases. Additionally, a detailed review of the patient's medications is essential, as certain drugs can interfere with red blood cell production or iron absorption, potentially contributing to anemia. A history of gastrointestinal bleeding, which is common in older adults, should also be considered, as it may indicate conditions like ulcers or colorectal cancer, which can lead to iron deficiency anemia. Once a clinical history is gathered, a complete blood count, CBC, is typically ordered. The CBC is a crucial initial test as it provides valuable information on hemoglobin and hematocrit levels, red blood cell count, and the mean corpuscular volume, MCV, of red blood cells. Anemia is generally diagnosed when hemoglobin levels fall below the normal range, but the type and cause of anemia often require further testing. For example, microcytic anemia, low MCV, may indicate iron deficiency, whereas macrocytic anemia, high MCV, could point to vitamin B12 or folate deficiency, or other underlying causes such as liver disease or hypothyroidism. Further diagnostic tests such as serum ferritin, serum iron, total iron binding capacity, TIBC, and transferrin saturation are essential in distinguishing between different types of anemia. For example, iron deficiency anemia is typically characterized by low ferritin and low serum iron levels, while anemia of chronic disease may present with normal or elevated ferritin levels but low serum iron. Additionally, vitamin B12 and folate levels are measured when megaloblastic anemia is suspected. If the cause of anemia remains unclear after these initial tests, more specialized investigations, such as bone marrow biopsy or stool occult blood testing, may be necessary. However, diagnosing anemia in older adults is not without challenges. The presence of multiple chronic conditions can complicate the picture, as anemia may be a secondary issue related to conditions such as chronic kidney disease, heart failure, or cancer. Additionally, anemia in older adults may be less obvious, with symptoms like fatigue, weakness, or cognitive decline being mistakenly attributed to aging or other conditions. Furthermore, some lab values may be influenced by age-related changes, such as lower levels of iron absorption and alterations in red blood cell production, which can complicate the interpretation of test results. Overall, diagnosing anemia in older adults requires a comprehensive approach that combines clinical evaluation with a variety of diagnostic tests. Because anemia can be both a primary condition and a secondary manifestation of other diseases, it is essential to consider all possible underlying causes in order to ensure appropriate treatment and improve patient outcomes. Laboratory tests and interpretation. Laboratory tests play a pivotal role in diagnosing and differentiating the various types of anemia in older adults. These tests provide essential information about the underlying cause of anemia and guide healthcare providers in selecting the most appropriate treatment. Given the complexity of anemia in the elderly, understanding how to interpret these laboratory results is crucial for accurate diagnosis and management. The first and most common test used to diagnose anemia is the complete blood count, CBC, which measures several key parameters including hemoglobin, HB concentration, hematocrit, HCT, red blood cell, RBC count, and mean corpuscular volume, MCV. A low hemoglobin level, generally defined as less than 12 corbetapur for women and 13 for men, indicates anemia. However, to determine the specific type of anemia, the MCV, the average size of red blood cells, must be evaluated. Microcytic anemia, low MCV, typically suggests iron deficiency anemia or anemia of chronic disease, while macrocytic anemia, high MCV, is often indicative of vitamin B12 or folate deficiency. Normocytic anemia, normal MCV, can be seen in conditions like anemia of chronic disease or renal failure. In addition to the CBC, a range of follow-up tests are essential for a more detailed evaluation. Serum ferritin, serum iron, total iron binding capacity, TIBC, and transferrin saturation are commonly used to assess iron status. Ferritin is a protein that stores iron, and low ferritin levels generally point to iron deficiency anemia. However, in anemia of chronic disease, ferritin levels may be normal or elevated due to inflammation, which complicates the interpretation. Serum iron levels are typically low in iron deficiency anemia, but may be elevated in conditions like anemia of chronic disease or iron overload disorders. Transferrin saturation, which measures the proportion of transferrin, the protein responsible for iron transport, bound to iron, is often low in iron deficiency anemia. When there is suspicion of vitamin B12 or folate deficiency, additional tests are necessary. Serum vitamin B12 and folate levels are measured, with deficiencies leading to elevated mean corpuscular volume, MCV, and the presence of macrocytic red blood cells. In cases of vitamin B12 deficiency, methylmalonic acid, MMA, and homocysteine levels may also be elevated, helping to distinguish between vitamin B12 and folate deficiencies. If the cause of anemia remains unclear after these initial tests, more specialized testing may be required. Bone marrow biopsy can be performed to examine red blood cell production and identify any abnormalities. Stool occult blood testing may be used to screen for gastrointestinal bleeding, particularly in seniors who may not show obvious signs of bleeding, such as those with colon cancer or ulcers. Interpreting these laboratory results in the context of an older adult's overall health and medical history is essential for accurate diagnosis. Anemia in older adults is often multifactorial, and the results of these tests must be considered alongside clinical symptoms and other diagnostic findings to determine the most appropriate treatment approach. Differential diagnosis in the elderly. Diagnosing anemia in older adults requires careful consideration of the broader clinical picture, as many conditions can mimic or contribute to the symptoms of anemia. A differential diagnosis is essential to accurately identify the underlying cause, especially since older adults often present with multiple chronic conditions, which can complicate the diagnosis. Distinguishing between various potential causes of anemia is crucial, as the treatment approaches for different types of anemia can vary significantly. One of the first considerations in the differential diagnosis of anemia in older adults is whether the anemia is primary due to a direct hematologic disorder or secondary as a result of another underlying condition. The most common causes of secondary anemia in older adults are chronic diseases such as chronic kidney disease, CKD, heart failure, diabetes, and cancer. Anemia of chronic disease, ACD, often seen in these conditions, is characterized by normocytic or microcytic red blood cells and low serum iron, with normal or elevated ferritin levels. It is important to differentiate ACD from iron deficiency anemia, as the treatment strategies for these conditions differ. In ACD, iron supplementation is usually ineffective, whereas in iron deficiency anemia, iron supplementation is the cornerstone of treatment. Another important consideration is anemia resulting from nutritional deficiencies, particularly iron, vitamin B12, and folate. In older adults, a lack of these essential nutrients can lead to specific types of anemia. Iron deficiency anemia typically presents with microcytic red blood cells and low ferritin, while vitamin B12 or folate deficiency results in macrocytic anemia with elevated mean corpuscular volume, MCV. These deficiencies may be caused by poor dietary intake, malabsorption, or medication side effects. For instance, medications like proton pump inhibitors, PPIs, or metformin can interfere with the absorption of vitamin B12, while alcohol consumption can contribute to folate deficiency. It is essential to differentiate these deficiencies from anemia of chronic disease, as the treatment involves specific supplementation of the deficient nutrient. Gastrointestinal bleeding is another critical consideration in the differential diagnosis of anemia in older adults. Seniors are at higher risk for conditions such as peptic ulcers, colorectal cancer, or diverticulosis, all of which can lead to slow, chronic blood loss and result in iron deficiency anemia. In these cases, stool occult blood testing or endoscopic evaluation may be necessary to detect hidden bleeding. Additionally, anticoagulant therapy, commonly prescribed in the elderly for conditions like atrial fibrillation, can increase the risk of gastrointestinal bleeding, further complicating the diagnosis. Renal insufficiency is another potential cause of anemia in the elderly. Chronic kidney disease, CKD, leads to decreased erythropoietin production, which in turn reduces red blood cell production in the bone marrow. This type of anemia is typically normocytic and may require treatment with erythropoiesis-stimulating agents, ESAs. Differentiating this from other types of anemia involves assessing kidney function through serum creatinine and glomerular filtration rate, GFR. In addition to these common causes, anemia in older adults can also be a result of bone marrow disorders, such as myelodysplastic syndromes or leukemia, which can lead to impaired red blood cell production. These conditions are rarer but must be considered in patients with unexplained or persistent anemia, especially when associated with other hematologic abnormalities. Ultimately, a thorough clinical evaluation, including a detailed medical history, physical examination, laboratory tests, and when necessary, imaging or biopsy, is crucial to determine the correct diagnosis. Accurate diagnosis enables appropriate treatment, whether it involves iron supplementation, vitamin therapy, management of chronic disease, or more specialized interventions like erythropoiesis-stimulating agents or treatment for gastrointestinal bleeding. Role of comprehensive geriatric assessment. A comprehensive geriatric assessment, CGA, is an essential tool in the management of older adults, particularly when diagnosing complex conditions like anemia. The CGA is a multidimensional, interdisciplinary diagnostic process that evaluates not only the physical health of older patients, but also their functional, mental, and social well-being. This thorough assessment provides valuable insight into how anemia and its underlying causes affects an older adult's overall quality of life, which is crucial for determining the most appropriate treatment and interventions. In the context of anemia, a CGA is particularly useful because it allows healthcare providers to assess the patient's overall health status and identify potential comorbidities or complications that may contribute to or result from anemia. For instance, anemia in older adults is often not an isolated issue, but is linked to chronic diseases such as heart failure, kidney disease, diabetes, or cancer. By conducting a CGA, clinicians can determine whether anemia is secondary to these conditions, which may require specific interventions beyond treating the anemia itself. The CGA involves multiple components, starting with a detailed medical history that includes not only the current symptoms related to anemia, but also any past medical conditions, medications, and family history that could be relevant. This history can help identify conditions such as chronic kidney disease, gastrointestinal bleeding, or malabsorption syndromes, which are common causes of anemia in older adults. Additionally, reviewing medications is crucial, as many drugs, including those used for cardiovascular diseases, diabetes, or osteoporosis, can interfere with nutrient absorption or cause side effects that lead to anemia. Functional assessment is another key aspect of the CGA, as anemia can significantly impact an older adult's ability to perform daily activities. A physical examination helps identify signs of anemia, such as pallor or a rapid heart rate, and assess the patient's overall physical health. In particular, assessing for signs of fatigue or weakness can help gauge the severity of anemia's impact on the patient's independence and mobility. Furthermore, understanding how anemia affects an individual's ability to carry out everyday tasks can inform decisions about the need for rehabilitation, physical therapy, or caregiver support. The mental health component of the CGA is equally important, as anemia can affect cognitive function and emotional well-being in older adults. Many seniors with anemia may experience cognitive impairment, depression, or anxiety, which can exacerbate the challenges they face in managing their health. Evaluating cognitive function and emotional status provides valuable information for creating a holistic care plan that addresses both the physical and psychological impacts of anemia. Finally, the social assessment in the CGA helps identify the support systems and resources available to the patient, which is essential for ensuring adherence to treatment plans and improving long-term outcomes. Seniors who live alone, lack family support, or have limited access to health care may require additional interventions to ensure they receive the care and support they need. Overall, the comprehensive geriatric assessment provides a complete picture of an older adult's health, enabling healthcare providers to develop a personalized and effective treatment plan for managing anemia. By addressing the physical, functional, cognitive, and social aspects of the patient's health, the CGA plays a critical role in optimizing care and improving the overall well-being of seniors with anemia. Chapter 5: Managing Nutritional Deficiencies. Nutritional deficiencies are a significant contributor to anemia in older adults, and effectively managing these deficiencies is essential for improving both the symptoms of anemia and the overall health of the patient. The most common nutritional deficiencies leading to anemia in the elderly are iron, vitamin B12, and folate deficiencies. Identifying and treating these deficiencies appropriately can often reverse anemia and restore energy, cognitive function, and overall well-being. Iron deficiency anemia is one of the most prevalent forms of anemia in older adults and is primarily caused by inadequate dietary intake, poor absorption, or chronic blood loss. In the elderly, gastrointestinal bleeding from ulcers, hemorrhoids, or conditions such as diverticulosis is a common cause of chronic blood loss, which depletes iron stores. Additionally, poor dietary intake of iron, particularly in individuals with limited access to food or those on restrictive diets, can lead to iron deficiency. Management of iron deficiency typically involves oral iron supplementation, although intravenous iron may be necessary in cases where absorption is impaired, such as in patients with gastrointestinal disorders like celiac disease or Crohn's disease. In addition to supplementation, dietary adjustments, such as increasing the intake of iron-rich foods like red meat, leafy green vegetables, and fortified cereals, are important for long-term management. Vitamin B12 and folate deficiencies are other common causes of anemia in older adults. Vitamin B12 deficiency is often the result of reduced gastric acid production, which impairs the absorption of B12 in the gut. Conditions such as pernicious anemia, atrophic gastritis, or the use of medications like proton pump inhibitors, PPIs, can exacerbate B12 deficiency. Folate deficiency is frequently caused by poor dietary intake or malabsorption due to gastrointestinal disorders. Vitamin B12 deficiency is typically managed through oral supplementation or, in more severe cases, intramuscular injections of B12. Folate deficiency, on the other hand, is treated with oral folic acid supplementation. Both vitamin B12 and folate deficiencies may also require dietary changes, such as increasing the intake of foods rich in these nutrients, such as fortified cereals, eggs, dairy products, and leafy greens. In managing nutritional deficiencies, it is also important to address any underlying conditions that may contribute to poor nutrient absorption or utilization. For instance, patients with chronic kidney disease, CKD, or those on dialysis often require specific interventions to address nutrient deficiencies, as these conditions can affect vitamin and mineral metabolism. Similarly, older adults who experience decreased appetite due to depression, dementia, or other health conditions may require additional support, such as meal planning or the use of nutritional supplements. Moreover, the role of a dietitian or nutritionist in managing nutritional deficiencies cannot be overstated. These professionals can assist in creating personalized dietary plans that ensure adequate nutrient intake, taking into account the patient's individual preferences, health conditions, and potential food interactions with medications. Regular monitoring of nutritional status through blood tests and clinical assessments is also essential to ensure that deficiencies are corrected and maintained over time. In conclusion, managing nutritional deficiencies in older adults with anemia requires a comprehensive approach that includes appropriate supplementation, dietary modifications, and the treatment of any underlying conditions contributing to nutrient deficiencies. With careful management, many older adults can experience significant improvements in their anemia-related symptoms and overall health. Dietary interventions and supplements. Dietary interventions and supplements are fundamental components of managing anemia in older adults, particularly when deficiencies in essential nutrients such as iron, vitamin B12, and folate are the underlying causes. Given the important role nutrition plays in the health and well-being of seniors, it is essential to focus on both dietary changes and supplementation to effectively treat anemia and prevent its recurrence. For iron deficiency anemia, dietary interventions should focus on increasing the intake of iron-rich foods. Iron is found in two forms: heme iron, which is more readily absorbed and is found in animal products such as red meat, poultry, and fish, and non-heme iron, which is found in plant-based sources like legumes, tofu, and fortified cereals. To enhance the absorption of non-heme iron, it is recommended to consume these foods with vitamin C-rich items such as citrus fruits, tomatoes, or bell peppers, as vitamin C increases the absorption of non-heme iron. On the other hand, substances like calcium, coffee, and tea can inhibit iron absorption, so it is advisable to avoid consuming them with iron-rich meals. In cases where dietary adjustments are not sufficient or when absorption issues exist, iron supplements may be required. Oral iron supplements, such as ferrous sulfate, are commonly prescribed, although they can cause gastrointestinal side effects like constipation or nausea. In cases where oral iron is not tolerated, or when a more rapid replenishment of iron stores is needed, intravenous iron may be an option. It is important for healthcare providers to monitor the patient's response to iron supplementation and adjust the dosage or form of iron as needed to ensure effectiveness and minimize side effects. For vitamin B12 deficiency anemia, dietary interventions focus on increasing B12-rich foods, such as meat, poultry, eggs, and dairy products. However, because older adults may have decreased stomach acid production, which impairs vitamin B12 absorption, dietary changes alone may not be sufficient. Vitamin B12 supplementation is often necessary, typically in the form of oral supplements, or in more severe cases, Intramuscular injections. Oral B12 supplements are generally well tolerated and effective, but for individuals with absorption issues, injectable forms may be more appropriate. Similarly, folate deficiency can be addressed by consuming folate-rich foods such as leafy green vegetables, beans, and fortified cereals. However, like vitamin B12, folate absorption may be impaired in the elderly, especially in those with gastrointestinal issues or those on certain medications. Folate supplementation in the form of oral folic acid is often necessary to correct deficiencies. For both vitamin B12 and folate deficiencies, it is important to monitor the patient's progress through blood tests to ensure that supplementation is effective and that levels are normalized. In addition to these specific interventions, a balanced diet rich in vitamins and minerals is critical for overall health. Seniors should aim to consume a variety of foods to support their general nutritional needs, as deficiencies in other nutrients, such as vitamin D or calcium, can also contribute to health problems in the elderly. For those with difficulty eating enough whole foods due to reduced appetite or chewing difficulties, meal replacements or fortified nutritional drinks may be recommended. Ultimately, dietary interventions and supplements are integral to the management of anemia in older adults. By addressing nutritional deficiencies through a combination of dietary changes and appropriate supplementation, healthcare providers can help seniors regain their vitality, improve quality of life, and reduce the risk of complications associated with anemia. Addressing malabsorption issues. Malabsorption is a key factor in many cases of anemia in older adults, often leading to deficiencies in essential nutrients like iron, vitamin B12, and folate. Malabsorption occurs when the body cannot properly absorb nutrients from food, leading to inadequate levels of these vital substances, which are critical for the production of healthy red blood cells. Addressing malabsorption issues is crucial for treating anemia and preventing its recurrence. Several conditions in older adults can lead to malabsorption. One of the most common is atrophic gastritis, where the stomach lining becomes thinner with age, reducing stomach acid production. This decreases the absorption of vitamin B12 and other nutrients that require an acidic environment to be absorbed properly. Additionally, gastrointestinal disorders such as celiac disease, Crohn's disease, or irritable bowel syndrome, IBS, can impair the small intestine's ability to absorb essential nutrients. In these cases, inflammation or damage to the intestinal lining hinders the absorption of iron, folate, and B12, leading to deficiencies and anemia. Another factor contributing to malabsorption is the use of certain medications. Drugs like proton pump inhibitors, PPIs, and H2 blockers, which are often prescribed for conditions like gastroesophageal reflux disease, GERD, reduce stomach acid production, and can interfere with the absorption of vitamin B12 and iron. Similarly, metformin, a common medication used to manage diabetes, can lead to vitamin B12 deficiency over time. When these medications are necessary, healthcare providers may recommend periodic screening for deficiencies and supplementation as needed. To address malabsorption, it is important to first identify and treat the underlying condition. In the case of atrophic gastritis or other gastrointestinal disorders, medications like acid-reducing agents should be carefully monitored, and patients may benefit from vitamin B12 injections or high-dose oral supplements to bypass absorption issues. For those with celiac disease or other malabsorption syndromes, a gluten-free diet or other specialized dietary changes may be required to restore normal nutrient absorption. In addition to treating the underlying cause, healthcare providers may recommend dietary modifications to improve nutrient absorption. For example, patients with iron deficiency due to malabsorption should focus on consuming iron-rich foods along with vitamin C-rich foods to enhance absorption. For vitamin B12, oral supplements or injections are often necessary, and in some cases, high-dose folic acid may be prescribed to help mitigate anemia caused by folate deficiency. In severe cases where malabsorption cannot be corrected through dietary changes or medication adjustments, Nutritional support through enteral feeding or parenteral nutrition may be considered. These interventions ensure that the patient receives adequate nutrients, bypassing the digestive system when necessary. In conclusion, addressing malabsorption issues is critical in managing anemia in older adults. By identifying the underlying causes, adjusting medications, and making appropriate dietary changes, healthcare providers can help improve nutrient absorption, treat deficiencies, and significantly improve the quality of life for elderly patients. Regular monitoring and personalized treatment plans are key to effectively managing anemia associated with malabsorption. Monitoring and adjusting treatment. Monitoring and adjusting treatment for anemia in older adults is a vital component of ensuring effective care and improving patient outcomes. Given that anemia can be caused by a variety of factors, including nutritional deficiencies, chronic diseases, or malabsorption issues, treatment plans must be tailored to address the underlying causes. Regular monitoring helps healthcare providers assess the efficacy of interventions, detect potential complications, and make timely adjustments to the treatment regimen. The first step in monitoring treatment is regular blood tests to track changes in key hematologic markers, including hemoglobin levels, hematocrit, and red blood cell count. These tests are essential for evaluating the response to therapy, whether the treatment involves iron supplementation, vitamin B12 injections, or erythropoiesis-stimulating agents. For example, in cases of iron deficiency anemia, serum ferritin levels, transferrin saturation, and serum iron are commonly assessed to determine the effectiveness of iron therapy. If these levels do not improve, it may indicate the need for higher doses of iron, a different formulation, or intravenous iron if oral supplements are ineffective. For anemia caused by vitamin B12 or folate deficiencies, monitoring involves checking levels of these vitamins, along with assessing mean corpuscular volume, MCV, to track improvement in red blood cell size. If levels remain low despite supplementation, it may suggest that absorption issues persist, requiring a change in the form of supplementation, such as switching from oral supplements to intramuscular injections for B12. In cases where anemia is secondary to chronic disease, such as chronic kidney disease, CKD, or heart failure, the treatment strategy may involve erythropoiesis-stimulating agents, ESAs, to boost red blood cell production. Monitoring for side effects, such as hypertension or thrombosis, is essential when using ESAs, as these agents can carry significant risks if not properly managed. Adjusting the dose or changing the treatment approach based on these findings is important to ensure patient safety and optimal therapeutic outcomes. Additionally, adjusting treatment for anemia in older adults often involves addressing underlying health conditions. For instance, managing gastrointestinal bleeding or controlling chronic inflammation from conditions like rheumatoid arthritis may help resolve anemia of chronic disease. Medications that interfere with nutrient absorption, such as proton pump inhibitors or metformin, may need to be reviewed and adjusted to reduce the impact on nutrient levels. Finally, healthcare providers should consider the patient's overall well-being when monitoring and adjusting treatment. Anemia can have significant effects on physical function and cognitive health, particularly in the elderly. Regular assessments of fatigue, strength, and mental status, along with laboratory results, can help guide treatment adjustments to improve the patient's quality of life. The goal is not only to normalize hemoglobin levels, but also to enhance the patient's overall functional status and prevent long-term complications. In conclusion, effective management of anemia in older adults requires continuous monitoring and timely adjustments to treatment. By regularly assessing lab results, evaluating response to interventions, and addressing any underlying health conditions, healthcare providers can optimize care and improve outcomes for elderly patients dealing with anemia. Chapter 6: Medical Treatments and Therapies. The management of anemia in older adults often requires medical treatments and therapies that address both the underlying causes and the symptoms of the condition. These treatments can vary depending on the type of anemia, the severity of the condition, and the patient's overall health. A comprehensive approach that includes pharmacological treatments, blood transfusions, and emerging therapies can significantly improve the quality of life for seniors suffering from anemia. For anemia caused by iron deficiency, the primary treatment involves iron supplementation. Oral iron supplements, such as ferrous sulfate, are typically the first-line treatment. These supplements are designed to replenish iron stores in the body and stimulate red blood cell production. However, oral iron can cause gastrointestinal side effects like constipation, nausea, and stomach upset, which may lead some patients to discontinue treatment. In such cases, intravenous IV iron may be recommended, especially in individuals with malabsorption issues or those who do not tolerate oral iron. IV iron is delivered directly into the bloodstream, bypassing the digestive system, and can quickly restore iron levels. Vitamin B12 and folate deficiencies, which also lead to anemia, are treated with vitamin supplements. Vitamin B12 deficiency is often managed with either high-dose oral B12 supplements or, in more severe cases, intramuscular B12 injections. The injectable form of B12 is particularly useful for patients with absorption issues, such as those with pernicious anemia or those who have had certain gastrointestinal surgeries. Folate deficiency is treated with oral folic acid supplements, and dietary changes to include more folate-rich foods, like leafy greens and fortified cereals, are encouraged as well. For anemia caused by chronic disease, such as chronic kidney disease, CKD, or heart failure, erythropoiesis-stimulating agents, ESAs, are often used. These medications stimulate the bone marrow to produce more red blood cells. However, the use of ESAs requires careful monitoring, as they can increase the risk of hypertension, blood clots, and stroke if not managed properly. In some cases, ESAs may be combined with iron supplementation to improve their effectiveness. In certain severe cases of anemia, especially when the patient's hemoglobin levels are dangerously low, blood transfusions may be necessary. Blood transfusions provide a rapid increase in red blood cell count, improving oxygen delivery to tissues, and alleviating symptoms such as fatigue, weakness, and shortness of breath. However, due to the risks associated with transfusions, such as immune reactions and iron overload, they are typically reserved for more critical situations. Emerging therapies for anemia include the use of new pharmacological agents aimed at stimulating red blood cell production or addressing the specific pathophysiological mechanisms of anemia in chronic disease. These therapies are still being researched, but offer potential for more targeted treatments in the future. In conclusion, medical treatments and therapies for anemia in older adults are diverse and depend on the specific cause and severity of the condition. By utilizing a combination of iron supplements, vitamin therapy, erythropoiesis-stimulating agents, and blood transfusions, healthcare providers can effectively manage anemia and improve the overall health and well-being of older patients. Iron therapy and blood transfusions. Iron therapy and blood transfusions are essential medical interventions for treating anemia in older adults, particularly when anemia is caused by iron deficiency or when severe anemia presents life-threatening symptoms. Both treatments aim to address the underlying deficiency of red blood cells, improve oxygen delivery to tissues, and enhance the overall quality of life for seniors suffering from this condition. Iron therapy is the first-line treatment for iron deficiency anemia, which is the most common form of anemia in older adults. The goal of iron therapy is to replenish the body's iron stores, enabling it to produce an adequate number of red blood cells. Oral iron supplements, such as ferrous sulfate, are typically prescribed and are effective in most cases. These supplements are absorbed through the gastrointestinal tract, where they restore iron levels in the body. However, iron supplements can cause gastrointestinal side effects, including constipation, nausea, and stomach discomfort. In such cases, doctors may adjust the dose, recommend different formulations, or switch to intravenous IV iron therapy. Intravenous iron therapy is often preferred for older adults who have difficulty absorbing iron from the gastrointestinal tract due to conditions like celiac disease, inflammatory bowel disease, or previous gastrointestinal surgeries. IV iron can deliver a higher dose of iron more rapidly, bypassing the digestive system and providing quicker relief. It is especially beneficial in severe cases of iron deficiency or when rapid correction of anemia is needed. Although IV iron therapy is effective, it carries a risk of allergic reactions, so careful monitoring is necessary. In some cases, when iron therapy alone is insufficient or when anemia is severe, blood transfusions may be required. Blood transfusions provide a direct infusion of red blood cells, rapidly increasing the oxygen carrying capacity of the blood. This can significantly improve symptoms of anemia, such as fatigue, weakness, and shortness of breath. Transfusions are often necessary in emergencies or when anemia is so severe that it poses immediate health risks. However, blood transfusions come with risks, including allergic reactions, iron overload, and infections, especially in elderly individuals who may have comorbidities. While blood transfusions are a valuable tool in managing severe anemia, they are generally used as a last resort due to these risks. Blood transfusions are typically reserved for situations where other treatments, such as iron therapy, have failed or when anemia is life-threatening. The decision to administer a transfusion is made based on factors such as the patient's overall health, the severity of anemia, and the presence of other medical conditions. In conclusion, iron therapy and blood transfusions play vital roles in the management of anemia in older adults. While iron supplements are the primary treatment for iron deficiency anemia, intravenous iron and blood transfusions are necessary in more severe or complex cases. By carefully monitoring and adjusting treatment plans, healthcare providers can help older adults achieve improved health outcomes and better quality of life. Erythropoiesis-stimulating agents. Erythropoiesis-stimulating agents, ESAs, are a class of medications used to stimulate the production of red blood cells in the bone marrow. These agents are particularly useful in the treatment of anemia related to chronic diseases, such as chronic kidney disease, CKD, cancer treatments, especially chemotherapy, and anemia of chronic inflammation. ESAs help increase hemoglobin levels, reduce the need for blood transfusions, and improve overall quality of life for patients suffering from these conditions. The primary mechanism of ESAs involves mimicking the action of erythropoietin, a hormone naturally produced by the kidneys that stimulates red blood cell production. In patients with CKD or other conditions that impair erythropoietin production, ESAs provide a synthetic version of this hormone, promoting the growth and maturation of red blood cells in the bone marrow. This is especially important in elderly patients with reduced kidney function, as their ability to produce erythropoietin may be compromised, leading to anemia. ESAs, such as EPIN alpha, Epogen, Procrit, and darbepoetin alpha, Aranesp, are commonly administered via injection, either subcutaneously or intravenously. The dosage and frequency of administration are tailored to the patient's hemoglobin levels and overall response to treatment. While these medications are highly effective, they must be carefully monitored to ensure that they are producing the desired effects without causing adverse outcomes. One of the primary concerns when using ESAs is the risk of overcorrection, where the hemoglobin level rises too quickly or reaches excessively high levels. This can increase the risk of serious complications, such as hypertension, blood clots, stroke, and heart attack. As a result, healthcare providers closely monitor hemoglobin levels during ESA treatment, adjusting the dosage as needed to maintain optimal levels that are not too high or too low. Additionally, ESAs are not without side effects. Some patients may experience injection site reactions, headaches, or joint pain. There is also a potential risk of tumor progression in certain cancer patients, as the increased production of red blood cells could inadvertently support the growth of cancerous cells. For this reason, ESAs are typically used with caution in cancer patients, particularly those with active tumors. In conclusion, erythropoiesis stimulating agents play a critical role in the management of anemia, particularly in patients with chronic diseases like CKD or cancer. When used appropriately and monitored carefully, ESAs can significantly improve patient outcomes by stimulating red blood cell production, reducing the need for transfusions, and enhancing quality of life. However, like any treatment, their use requires careful consideration of risks and benefits to ensure safe and effective care. Managing underlying chronic conditions. Anemia in older adults is often not an isolated condition, but rather a complication arising from various chronic diseases. Managing the underlying chronic conditions that contribute to anemia is crucial for effectively treating the condition and improving the overall health of seniors. Chronic diseases such as chronic kidney disease, CKD, heart failure, diabetes, and inflammatory conditions like rheumatoid arthritis are frequently associated with anemia. Addressing these conditions directly is vital in reducing the impact of anemia and preventing its recurrence. Chronic kidney disease, CKD, is one of the most common causes of anemia in older adults. The kidneys are responsible for producing erythropoietin, a hormone that stimulates red blood cell production. As kidney function declines in CKD, erythropoietin production decreases, leading to anemia. In these cases, managing CKD through medications, dietary changes, and possibly dialysis can help improve kidney function and alleviate anemia. The use of erythropoiesis-stimulating agents, ESAs, may also be necessary to stimulate red blood cell production in patients with CKD. Heart failure is another chronic condition that often results in anemia, typically due to a combination of decreased red blood cell production and increased destruction of red blood cells. The anemia of heart failure can worsen the symptoms of the disease, such as fatigue and shortness of breath. Proper management of heart failure, including the use of medications like ACE inhibitors, diuretics, and beta blockers, can help reduce the severity of anemia. In some cases, iron supplementation or the use of ESAs may be required to address the anemia associated with heart failure. Diabetes, particularly when poorly controlled, can contribute to anemia through various mechanisms, including kidney damage, inflammation, and changes in blood cell production. Optimizing blood glucose control and managing diabetic nephropathy are essential steps in reducing the risk of anemia in diabetic patients. In some cases, iron supplementation or the use of ESAs may be indicated for patients with diabetes-related anemia. Inflammatory conditions, such as rheumatoid arthritis, can also lead to anemia of chronic disease. Chronic inflammation disrupts iron metabolism, impairing the body's ability to use stored iron for red blood cell production. Effective management of the underlying inflammatory condition, often with medications such as disease-modifying anti-rheumatic drugs, DMARDs, or biologics, can help control inflammation and improve anemia. In conclusion, managing underlying chronic conditions is a critical component of treating anemia in older adults. By addressing the root causes of anemia, such as CKD, heart failure, diabetes, and inflammatory diseases, healthcare providers can improve the effectiveness of treatment and enhance the patient's quality of life. Integrating the management of chronic conditions with anemia treatment ensures a more comprehensive and successful approach to care. Chapter 7, Anemia and Quality of Life. Anemia can significantly affect the quality of life for older adults, often leading to a cascade of physical, emotional, and cognitive challenges. The reduced oxygen-carrying capacity of the blood due to anemia results in fatigue, weakness, and shortness of breath, all of which can interfere with daily activities and overall well-being. In seniors, these symptoms may not only exacerbate existing health problems, but also diminish their ability to maintain independence and engage in social and physical activities, contributing to a decline in their quality of life. The most immediate and noticeable impact of anemia is fatigue, which is often described as feeling overwhelmingly tired or drained, even after adequate rest. This persistent fatigue can limit a senior's ability to participate in regular activities such as walking, household chores, or engaging in hobbies. Over time, the chronic tiredness can lead to reduced physical function and a lack of motivation to stay active, which in turn can contribute to further deconditioning and frailty. As a result, seniors may become more reliant on caregivers or family members for assistance with basic tasks, leading to a diminished sense of autonomy and self-worth. In addition to physical limitations, anemia can also affect cognitive function. Research has shown that anemia is associated with a higher risk of cognitive impairment, including difficulties with concentration, memory, and problem solving. These cognitive challenges can make it harder for older adults to manage their medications, appointments, and daily responsibilities. Moreover, the mental fatigue caused by anemia may further affect mood, leading to feelings of frustration, anxiety, or depression. Social withdrawal is another common issue, as individuals with anemia may avoid social interactions due to their fatigue or feelings of embarrassment about their symptoms. This isolation can create a cycle of mental and emotional distress that worsens the overall quality of life. Addressing anemia and improving quality of life involves not only medical interventions to correct the underlying causes of anemia, but also a focus on enhancing physical and emotional well-being. Treatment strategies such as iron supplementation, erythropoiesis-stimulating agents, and addressing chronic conditions can help improve energy levels and alleviate symptoms. Additionally, promoting physical activity and social engagement, as well as providing emotional support, can play a crucial role in improving the mental health and overall quality of life for seniors with anemia. In conclusion, anemia can profoundly affect the quality of life for older adults, causing physical, cognitive, and emotional challenges that interfere with daily functioning and overall well-being. By managing the underlying causes of anemia and focusing on holistic approaches to care, healthcare providers can help improve the health, independence, and overall life satisfaction of older patients. Impact on physical function and independence. Anemia in older adults can have a profound impact on physical function and independence. The primary symptoms of anemia, such as fatigue, weakness, and shortness of breath, can severely limit an individual's ability to perform everyday activities. For seniors, this can translate into increased difficulty with tasks that were once routine, like walking, climbing stairs, dressing, or preparing meals. Over time, the cumulative effect of these limitations can significantly reduce an older adult's level of independence and quality of life. Fatigue, which is one of the hallmark symptoms of anemia, can make it challenging for individuals to maintain their usual level of activity. Even simple activities like grocery shopping or taking a walk can become exhausting, leading to a reduced desire to engage in physical exercise. This lack of activity can contribute to a vicious cycle of deconditioning, where muscles weaken from lack of use, further impairing mobility and increasing the risk of falls. The decreased physical stamina can also lead to a greater reliance on others for help with daily tasks, as seniors may struggle to manage chores, errands, or personal care on their own. The impact of anemia on physical function extends to balance and coordination. In some cases, seniors with anemia may experience dizziness or lightheadedness due to insufficient oxygen delivery to tissues, increasing the risk of falls. Falls in older adults can result in serious injuries, such as fractures or head trauma, which can further compromise physical function and independence. Even without falls, the constant feeling of fatigue and weakness may discourage seniors from engaging in the physical activity necessary to maintain strength and mobility. Furthermore, anemia can exacerbate the effects of pre-existing conditions, such as osteoarthritis or cardiovascular disease, making it even more difficult for older adults to manage their health. For example, a person with heart failure who also suffers from anemia may experience worsening shortness of breath and reduced exercise tolerance, which further limits their physical capacity. As a result, the individual may find it harder to manage their chronic conditions, leading to a decline in overall health. In conclusion, anemia in older adults can significantly impair physical function and reduce independence. The fatigue, weakness, and associated risks of falls create barriers to daily activities, social engagement, and self-care, often leading to increased dependence on caregivers. Addressing anemia through medical treatment and encouraging physical activity can help mitigate these effects, enabling seniors to maintain a higher level of independence and improve their overall physical health. Cognitive health and emotional well-being. Anemia in older adults does not only affect physical health, it also has significant implications for cognitive function and emotional well-being. The lack of oxygen delivered to the brain due to reduced red blood cells can contribute to cognitive decline, affecting memory, concentration, and overall mental clarity. In seniors, the impact on cognitive health can be subtle but progressive, potentially leading to difficulties in managing daily tasks, making decisions, or remembering important details. These cognitive challenges often go unnoticed or are attributed to the normal aging process, but anemia can exacerbate them, making them more pronounced. Fatigue, one of the most common symptoms of anemia, plays a crucial role in cognitive dysfunction. When the body is deprived of adequate oxygen, mental fatigue sets in, making it harder for individuals to focus, process information, or engage in complex tasks. This mental exhaustion can impair a senior's ability to manage their affairs, remember appointments, or participate in conversations, further diminishing their cognitive capacity. Additionally, the prolonged fatigue caused by anemia can contribute to feelings of frustration and a diminished sense of self-worth, which can lead to a negative impact on emotional well-being. Emotionally, anemia can cause feelings of sadness, anxiety, and depression. The constant physical discomfort, paired with cognitive challenges, can make older adults feel overwhelmed and hopeless. For many, the inability to engage in social activities or enjoy hobbies due to fatigue and weakness can lead to isolation. Social withdrawal is a key factor in the development of depression, and older adults with anemia may become more withdrawn either due to their physical limitations or the emotional burden of living with chronic fatigue. Furthermore, the overlap between anemia and pre-existing mental health conditions can worsen emotional well-being. Seniors who are already dealing with depression or anxiety may find that their symptoms are exacerbated by the additional challenges posed by anemia. The cycle of fatigue and cognitive difficulty, coupled with emotional distress, can make it harder for individuals to seek help or engage in treatment. In conclusion, anemia has a profound effect on both cognitive health and emotional well-being in older adults. The physical symptoms of anemia, such as fatigue and weakness, contribute to cognitive decline and can lead to emotional challenges like depression and anxiety. Recognizing and addressing these effects is essential in managing anemia in seniors, as treating the underlying condition can help improve both cognitive function and emotional health, enhancing overall quality of life. Reducing hospitalizations and complications. Anemia in older adults can lead to a range of complications that increase the risk of hospitalizations and negatively impact overall health. When left untreated or inadequately managed, anemia can exacerbate pre-existing conditions, contribute to further deterioration of physical and cognitive function, and lead to more frequent hospital admissions. Addressing anemia effectively can help reduce these risks, ultimately improving the quality of life and reducing the need for hospital care. One of the most significant ways anemia contributes to hospitalizations is through its impact on the cardiovascular system. In older adults, anemia can strain the heart, as the body compensates for the lack of oxygen-carrying red blood cells by increasing heart rate and cardiac output. This can worsen existing heart conditions, such as heart failure, and lead to increased hospitalizations for acute heart-related events. By treating the underlying anemia, whether through iron supplements, erythropoiesis-stimulating agents, or addressing the root causes, such as chronic kidney disease, the strain on the heart can be reduced, lowering the likelihood of heart failure exacerbations and hospital admissions. Additionally, anemia often results in falls and fractures due to weakness and dizziness, especially in seniors who are already at higher risk for falls. The fatigue and reduced stamina associated with anemia can impair balance and coordination, increasing the likelihood of accidents. Hospitalizations for falls and subsequent fractures can be frequent and serious, leading to long recovery periods, further disability, and even death in some cases. By treating anemia, these risks can be minimized, as improvements in energy levels and strength help maintain physical function and stability. Infections and other complications also become more common in anemic patients, particularly those with underlying chronic diseases. Anemia can impair the immune system's ability to function properly, making it harder for the body to fight off infections. For older adults with diabetes, chronic kidney disease, or other conditions, this can result in frequent hospitalizations due to infections or other secondary complications. Proper management of anemia can help improve immune function, decreasing the incidence of infections and reducing hospital stays. In conclusion, reducing hospitalizations and complications in older adults with anemia requires comprehensive management of the condition. Treating anemia not only addresses its direct symptoms, but also helps prevent the exacerbation of cardiovascular issues, reduces the risk of falls, and strengthens the immune system. By addressing anemia early and effectively, healthcare providers can help reduce hospital admissions, improve outcomes, and enhance the overall well-being of seniors. Chapter 8: Multidisciplinary and Long-Term Care Strategies. Managing anemia in older adults requires a comprehensive approach, often involving a multidisciplinary team of healthcare providers to address the complex needs of this population. Given the multifactorial nature of anemia in seniors, effective care strategies must integrate medical, nutritional, and psychosocial interventions. These strategies aim not only to treat the anemia, but also to enhance overall health, improve quality of life, and prevent long-term complications. A key component of multidisciplinary care for anemia in older adults is collaboration between various specialists, including primary care physicians, hematologists, dietitians, nurses, and social workers. The primary care physician typically serves as the central point of contact, coordinating care and ensuring that the underlying causes of anemia are addressed. In cases where specific treatment for anemia is needed, referrals to specialists such as hematologists may be necessary for more targeted therapies, such as iron infusions, erythropoiesis-stimulating agents, or blood transfusions. This team-based approach ensures that the complex needs of older adults with anemia are met with expertise in various areas of healthcare. Nutritional interventions are crucial in managing anemia, particularly in addressing deficiencies in iron, vitamin B12, and folate, which are common causes of anemia in seniors. A registered dietitian can help develop a tailored nutrition plan that includes foods rich in these nutrients and may recommend supplements as needed. For seniors with malabsorption issues or dietary restrictions, such as those with chronic kidney disease or gastrointestinal conditions, alternative supplementation strategies may be necessary to ensure adequate nutrient intake. A dietitian can also work with the multidisciplinary team to monitor progress and adjust dietary plans accordingly. Long-term care strategies are also essential in managing anemia in older adults, especially those with chronic conditions. For individuals who live in long-term care facilities or have home health care needs, a comprehensive care plan should include regular monitoring of hemoglobin levels, assessment of nutritional status, and routine evaluations of physical and cognitive function. Caregivers, including nurses and social workers, play a vital role in ensuring that seniors receive the necessary support for daily activities, emotional well-being, and adherence to medical treatment. Educating caregivers about the symptoms of anemia and the importance of ongoing care can help reduce complications and prevent hospitalizations. In conclusion, managing anemia in older adults requires a multidisciplinary approach that integrates medical, nutritional, and psychosocial care strategies. A team of healthcare providers can collaborate to identify the root causes of anemia, provide appropriate treatments, and address the needs of the whole person. Long-term care strategies ensure that seniors receive continuous support to manage their condition and maintain a good quality of life. This comprehensive approach is essential for improving health outcomes and minimizing the risks of complications associated with anemia. Role of primary care and specialists. In managing anemia in older adults, both primary care providers and specialists play essential and complementary roles. Effective treatment and care require a collaborative approach, with each professional bringing unique expertise to the table. While primary care providers offer holistic and ongoing management, specialists focus on specific aspects of anemia that may require advanced interventions or complex care. Primary care physicians, PCPs, are typically the first point of contact for older adults seeking help for symptoms like fatigue, weakness, or shortness of breath. They are well positioned to perform an initial evaluation considering the patient's complete medical history, medications, and lifestyle. A thorough assessment allows primary care providers to identify potential causes of anemia, ranging from nutritional deficiencies to chronic diseases, and develop a treatment plan tailored to the individual's needs. Additionally, PCPs are crucial in managing comorbid conditions such as cardiovascular disease, diabetes, or kidney disease, which can either cause or be exacerbated by anemia. They can coordinate regular monitoring of hemoglobin levels, evaluate treatment responses, and adjust care plans as needed. Primary care providers are also instrumental in offering preventive care. They can provide education about diet, exercise, and lifestyle changes that may reduce the risk of developing anemia in the future. Moreover, they help navigate routine screenings and vaccinations, promoting overall health and well-being for older adults. By managing chronic conditions and addressing anemia early on, primary care physicians play a pivotal role in preventing complications and reducing hospitalizations. While primary care physicians are central to managing the overall health of an older adult with anemia, specialists often become involved when more targeted interventions are necessary. For example, a hematologist may be called upon if the anemia is complex or requires more advanced treatments, such as blood transfusions, iron infusions, or the use of erythropoiesis-stimulating agents. Specialists also provide expertise in identifying rare or difficult-to-diagnose causes of anemia, such as bone marrow disorders or certain cancers, and offer more precise diagnostic testing. Additionally, other specialists may play a role in managing the underlying causes of anemia. For instance, a nephrologist might be involved in cases where chronic kidney disease contributes to anemia, while a gastroenterologist can help manage anemia caused by gastrointestinal malabsorption issues. Collaborative care between specialists ensures a comprehensive approach that addresses both the symptoms of anemia and its root causes. In conclusion, the role of primary care providers and specialists in managing anemia in older adults is critical. Primary care physicians provide ongoing, holistic care and coordinate treatment for comorbid conditions, while specialists offer targeted expertise for more complex cases. Working together, these healthcare professionals ensure that older adults receive the best possible care to manage anemia and improve their overall health. Coordinating care in nursing homes and at home. Coordinating care for older adults with anemia, whether in nursing homes or at home, requires a comprehensive and organized approach that ensures the patient receives the necessary medical, nutritional, and social support. Anemia in seniors is often associated with complex health issues and multiple comorbidities, making careful coordination essential for effective management. Whether in a long-term care facility or living independently at home, the goal is to provide consistent, high-quality care that improves the patient's overall well-being while addressing their specific needs. In nursing homes, the coordination of care typically involves a team of healthcare professionals working together to manage the patient's condition. Nurses, physicians, dietitians, Physical therapists and social workers all play vital roles in managing anemia and its related effects. Nursing home staff are responsible for monitoring vital signs, administering medications, and observing changes in the patient's health. Regular checkups and lab tests ensure that anemia is being adequately treated and necessary adjustments are made to the care plan. Caregivers also assist with daily activities, from meal preparation to mobility support, helping to alleviate the physical limitations caused by anemia. The role of the dietitian is particularly important in nursing homes, as many older adults with anemia may suffer from malnutrition or have difficulty eating sufficient amounts of iron, vitamin B12, or folate. Tailored meal plans and nutritional supplements are often recommended to ensure that residents receive the nutrients they need to manage their anemia. Furthermore, social workers and mental health professionals can address emotional issues, such as depression or isolation, that may arise due to the challenges of living with anemia and its physical limitations. For older adults living at home, coordinating care often involves a combination of family caregivers, healthcare providers, and home health aides. Primary care physicians are key in diagnosing and treating anemia, but caregivers may need to step in to help with day-to-day management, such as ensuring medications are taken correctly or helping with meal planning. Home health aides can provide additional support for personal care tasks, mobility assistance, and monitoring the senior's health. In many cases, a visiting nurse or therapist might also be involved to assist with physical therapy or to track the progress of anemia treatments. In both settings, communication and collaboration are critical to effective care. The coordination of care should involve regular updates and meetings among all parties, ensuring that everyone involved in the care process is informed and working toward the same goals. When all team members, from nursing home staff to family caregivers, are on the same page, it increases the likelihood of successful anemia management, reduces complications, and improves the senior's overall quality of life. In conclusion, coordinating care for older adults with anemia, whether in nursing homes or at home, is essential for optimal health outcomes. By ensuring that healthcare providers, caregivers, and support staff work collaboratively, it is possible to manage anemia effectively and improve the senior's physical and emotional well-being. Patient education and family involvement. Patient education and family involvement are crucial components of managing anemia in older adults, as they empower both the patient and their loved ones to participate actively in the treatment process. Anemia, particularly in seniors, can be a complex and multifaceted condition that requires a coordinated approach to care. Ensuring that patients and their families understand the condition, its symptoms, potential complications, and treatment options helps improve adherence to therapy, reduce hospitalizations, and enhance overall quality of life. Effective patient education starts with clear and accessible information. Healthcare providers should explain the causes and symptoms of anemia in terms that are easy to understand, considering the patient's cognitive status and preferred communication style. It is essential for patients to understand how anemia can affect their energy levels, cognition, and physical health, as well as the importance of treatment in managing these symptoms. Providers should also discuss the potential side effects of medications and therapies, such as iron supplements or erythropoiesis-stimulating agents, so patients are well informed and can make decisions about their care. Educating patients about lifestyle changes, such as dietary modifications to increase iron or vitamin B12 intake, is also key to managing anemia effectively. Family members play an important role in supporting the patient's understanding and management of anemia. They are often the primary caregivers, responsible for ensuring that the patient adheres to prescribed treatments, attends medical appointments, and maintains a proper diet. Involving family members in educational sessions or discussions with healthcare providers ensures they have the tools and knowledge to assist in managing the condition. Additionally, family members can provide emotional support, helping the patient cope with feelings of fatigue, frustration, or isolation that may accompany anemia. When families are involved, patients tend to feel more supported, which can reduce stress and improve their overall outlook. Family members also help with logistical aspects of care. For example, they may assist with medication management, arrange transportation for doctor visits, or help monitor the patient's physical and emotional well-being. This support system is vital in preventing complications and ensuring that the patient receives consistent care at home or in a long-term care setting. Family involvement can also provide a valuable perspective on the patient's daily functioning and any changes in symptoms, which can be crucial for healthcare providers to adjust treatment plans accordingly. In conclusion, patient education and family involvement are critical to the effective management of anemia in older adults. By providing clear, understandable information and involving family members in the care process, healthcare providers can enhance treatment adherence, improve health outcomes, and ensure that both patients and families feel empowered and supported throughout the care journey. Conclusion: anemia in the elderly is a multifactorial condition that can significantly impact an individual's health and quality of life. Understanding the underlying causes of anemia, its signs and symptoms, and the various treatment options available is essential for providing comprehensive care to older adults. With the aging population increasing globally, anemia in seniors has become a prevalent concern that requires careful attention from healthcare providers, caregivers, and families alike. The causes of anemia in older adults can range from nutritional deficiencies, such as iron, vitamin B12, and folate, to chronic diseases, including kidney disease, heart failure, and cancer. Identifying the specific type and cause of anemia is crucial for determining the most appropriate treatment. Without proper management, anemia can exacerbate other health issues, impair physical function, and contribute to cognitive decline. The consequences of untreated anemia are severe, leading to reduced independence, increased hospitalization rates, and a decline in overall health status. Effective management of anemia in seniors involves a multidisciplinary approach, integrating the expertise of primary care providers, specialists, dietitians, and other healthcare professionals. Primary care physicians are typically the first point of contact and play an essential role in diagnosis, ongoing care, and coordinating treatment. When necessary, specialists such as hematologists, cardiologists, or nephrologists provide targeted interventions for complex or severe cases. Nutritional interventions are also pivotal in managing anemia, particularly when dietary deficiencies are identified as contributing factors. Patient education and family involvement are integral to successful anemia management, ensuring that both patients and their families understand the condition, its impact, and the importance of treatment can improve adherence to therapy and reduce the risk of complications. By providing clear, accessible information and supporting families in their caregiving roles, healthcare providers can enhance outcomes and empower individuals to take an active role in their care. Ultimately, the management of anemia in older adults requires a personalized, holistic approach. By addressing the physical, emotional, and nutritional needs of seniors with anemia, healthcare providers can improve their quality of life and reduce the burden of hospitalization and complications. With early detection, appropriate interventions, and ongoing support, anemia can be effectively managed, allowing seniors to maintain their independence and enjoy a better quality of life. Anemia in Women, Breaking the Cycle, written by Julie Hord, narrated by Graziella Newson. Chapter 1, Understanding Anemia. Anemia is a condition that occurs when the body doesn't have enough healthy red blood cells or hemoglobin to carry adequate oxygen to the tissues. This seemingly simple deficiency can lead to complex and far-reaching consequences, particularly for women. Understanding what anemia is, how it develops, and why it disproportionately affects women is the first step toward addressing a public health issue that has remained in the shadows for far too long. At its core, anemia is not a disease, but a symptom of an underlying issue. There are various types of anemia, each with its own cause and implications. The most common form is iron deficiency anemia, which occurs when the body lacks sufficient iron to produce hemoglobin. Other types include vitamin B12 deficiency anemia, folate deficiency anemia, and anemia of chronic disease. Women are especially vulnerable due to biological factors such as menstruation, pregnancy, and childbirth, which increase the body's demand for iron and other nutrients. In many parts of the world, these biological demands are not met with adequate nutrition or medical care, leading to widespread cases of undiagnosed and untreated anemia. Globally, anemia affects an estimated 1 in 3 women, with the highest rates occurring in low and middle-income countries. However, it is a mistake to think of anemia as a problem confined to poorer regions. Even in high-income nations, women face unique challenges that contribute to the development and persistence of anemia. From heavy menstrual bleeding to restrictive diets and chronic health conditions, the risk factors are varied and complex. Cultural stigmas around menstruation and health taboos further prevent many women from seeking timely diagnosis and treatment. Understanding anemia also means recognizing the ripple effects it has on a woman's life. It can lead to persistent fatigue, weakness, poor concentration, and reduced productivity. For pregnant women, anemia increases the risk of complications such as preterm delivery and low birth weight. In adolescence, it can impair growth and cognitive development, setting the stage for lifelong disadvantages. These consequences highlight the urgent need for greater awareness, early detection, and comprehensive care. This chapter lays the groundwork for a deeper exploration of anemia throughout this book. By grasping the basics, what anemia is, its types, and how it uniquely affects women, we begin to see the outlines of a problem that is not just medical, but also social and economic. The chapters that follow will delve into these dimensions, offering insight into how we can collectively break the cycle of anemia in women. What is anemia? Anemia is a condition that arises when the number of healthy red blood cells in the body, or the amount of hemoglobin within those cells, falls below normal levels. Hemoglobin is the protein in red blood cells responsible for carrying oxygen from the lungs to tissues throughout the body. When hemoglobin levels are low, the body's organs and tissues receive less oxygen than they need to function optimally, leading to a wide range of symptoms that can affect physical, emotional, and cognitive well-being. The onset of anemia is often gradual, and in its early stages, it may go unnoticed. As the condition progresses, however, individuals may begin to feel persistent fatigue, weakness, dizziness, or shortness of breath. Some people also experience headaches, pale skin, irregular heartbeat, or cold hands and feet. These symptoms are the body's way of signaling that it is not getting enough oxygen, and while they may be dismissed as everyday tiredness or stress, they often point to a more serious underlying issue. There are many types of anemia, each classified by its cause. Iron deficiency anemia, the most common form, results from a lack of iron, which is essential for producing hemoglobin. Other types include vitamin deficiency anemia, which occurs when the body lacks nutrients like vitamin B12 or folate, and anemia of chronic disease, which is linked to long-term medical conditions such as kidney disease, cancer, or autoimmune disorders. Some forms of anemia are inherited, such as sickle cell anemia and thalassemia, which affect how red blood cells are formed and function. Women are particularly vulnerable to anemia due to the unique demands placed on their bodies throughout life. Menstruation, especially when heavy or prolonged, can lead to significant iron loss. Pregnancy increases the body's need for iron and other nutrients to support both mother and baby. Without adequate intake or supplementation, women can quickly become anemic, often without realizing it, until the symptoms interfere with daily life. In some regions, poverty, gender inequality, and limited access to healthcare further compound the risk. Understanding what anemia is and recognizing that it is more than just feeling tired is crucial for early intervention and effective treatment. It is not merely a medical condition, but often a reflection of broader health and social disparities. With proper awareness, testing, and care, anemia can be managed and even prevented, significantly improving quality of life, especially for women across different life stages. Types of anemia in women. Anemia is not a single disease, but a broad term that encompasses several distinct conditions, each with its own causes, symptoms, and implications. In women, certain types of anemia are more prevalent due to biological, nutritional, and health-related factors that affect their red blood cell production and maintenance. Understanding these types is essential for accurate diagnosis and effective treatment. The most common type of anemia in women is iron deficiency anemia. This occurs when the body does not have enough iron to produce adequate amounts of hemoglobin, the protein that enables red blood cells to carry oxygen. Women are especially prone to this type because of monthly menstrual blood loss, pregnancy-related demands, and dietary insufficiencies. Heavy or prolonged menstrual periods can lead to a chronic state of iron depletion if not addressed through proper nutrition or supplementation. During pregnancy, the body requires significantly more iron to support fetal development and increase blood volume, and without careful management, pregnant women are at high risk of becoming anemic. Another type frequently seen in women is vitamin deficiency anemia, particularly due to low levels of vitamin B12 or folate. These vitamins are crucial for red blood cell production, and a lack of them can result in the production of abnormally large or dysfunctional red blood cells. Folate deficiency is especially common during pregnancy when the body's need for this nutrient increases. Inadequate intake, absorption issues, or restrictive diets can all contribute to this form of anemia. Anemia of chronic disease is another important category. This type often develops as a secondary condition to long-term illnesses, such as autoimmune diseases, infections, kidney disease, or cancer. In these cases, inflammation or organ dysfunction interferes with the body's ability to use iron properly or produce enough red blood cells, even when iron stores appear adequate. Women dealing with chronic conditions often face this hidden form of anemia, which can be difficult to detect without targeted medical evaluation. Less commonly, inherited forms of anemia, such as sickle cell anemia and thalassemia, affect some women. These genetic disorders alter the shape or structure of red blood cells, impairing their function and reducing their lifespan. While these conditions are less widespread, they are more common in certain ethnic groups and require specialized care and lifelong management. Each type of anemia carries its own set of challenges, and for women, the causes are often multifactorial. Recognizing the specific form of anemia is critical not only for treatment, but also for prevention and long-term health. A deeper understanding of these types can empower women to advocate for better care and address the root causes of their symptoms. Global and local prevalence. Anemia is one of the most widespread public health concerns in the world, affecting an estimated 1.6 billion people globally. Among them, women, especially those of reproductive age, bear a disproportionate burden. According to the World Health Organization, WHO, nearly 1 in 3 women worldwide is anemic. This statistic alone underscores the urgent need to recognize anemia not just as an individual health issue, but as a global crisis with profound social and economic implications. The prevalence of anemia varies widely between regions, largely depending on socioeconomic conditions, access to health care, dietary patterns, and public health infrastructure. In low and middle-income countries, particularly in parts of sub-Saharan Africa, South Asia, and Latin America, anemia rates among women often exceed 40%. These high rates are linked to a combination of nutritional deficiencies, high rates of infectious diseases, limited prenatal care, and poor menstrual health management. Women in these regions often face systemic barriers to accessing iron-rich foods, supplements, and timely medical attention. Even in high-income countries, anemia remains a concern, though the numbers are generally lower. Factors such as dietary choices, menstrual health disorders, chronic illnesses, and the increasing popularity of restrictive diets contribute to persistent cases. For example, in North America and Western Europe, anemia affects around 10 to 15% of women, with higher rates seen among low-income populations, immigrants, and women with limited access to health services. Urban environments can mask these statistics, making anemia an overlooked condition in otherwise well-resourced healthcare systems. At the local level, the prevalence of anemia can often reveal hidden patterns of inequality and neglect. In rural and underserved communities, limited availability of nutritious food, poor sanitation, and lack of health education contribute significantly to the persistence of anemia in women. Additionally, cultural norms and gender-based disparities in food distribution and healthcare access further increase women's vulnerability. Local health data often show that adolescent girls and pregnant women are among the most affected groups, a fact that calls for targeted interventions tailored to these specific life stages. Understanding the global and local prevalence of anemia in women is vital for shaping effective strategies to combat it. It is not just about statistics, but about acknowledging the lived realities of millions of women whose health, productivity, and well-being are compromised by a preventable and treatable condition. With the right policies, community involvement, and healthcare efforts, these numbers can be reduced, and the cycle of anemia can be broken, both globally and locally. Chapter 2: Causes and Risk Factors. Anemia in women is rarely caused by a single factor. Instead, it often arises from a combination of biological, nutritional, medical, and social influences. Understanding the root causes and risk factors is crucial for developing effective strategies to prevent and treat the condition. While many people associate anemia with poor diet alone, the reality is far more complex, especially for women who face unique physiological demands and health challenges throughout their lives. One of the leading causes of anemia in women is nutritional deficiency, particularly a lack of iron, vitamin B12, and folate. Iron deficiency anemia is the most prevalent form, often resulting from diets low in iron-rich foods or impaired absorption of iron in the digestive tract. Women who follow restrictive diets, whether for health, cultural, or economic reasons, are at a higher risk. During pregnancy, the body's need for iron and other nutrients increases dramatically, and without proper supplementation, many women become anemic. Similarly, vegetarian or vegan diets, if not properly managed, can lead to deficiencies in vitamin B12, which is primarily found in animal products. Reproductive health plays a significant role in anemia risk. Regular menstrual blood loss, particularly when it is heavy or prolonged, can deplete iron stores over time. Women with conditions like fibroids or endometriosis may experience especially heavy periods, further increasing their vulnerability. Pregnancy and childbirth also contribute significantly, as the body must supply enough oxygen to support the growing fetus, often draining the mother's reserves. Postpartum recovery can be prolonged if iron levels are not restored, leading to chronic fatigue and other complications. Chronic illnesses and genetic disorders are also significant contributors. Conditions such as kidney disease, inflammatory disorders, and cancer can interfere with red blood cell production or iron metabolism. Autoimmune diseases like lupus or rheumatoid arthritis often lead to what's known as anemia of chronic disease. Additionally, inherited conditions such as sickle cell anemia and thalassemia affect the structure and function of red blood cells and are more common in certain ethnic groups. These types of anemia require specialized management and lifelong monitoring. Socioeconomic and environmental factors can't be ignored. Women living in poverty, with limited access to health care and nutritious food, face higher risks. Cultural practices and gender norms often result in women eating last or least in the household, depriving them of essential nutrients. Poor sanitation and exposure to infections like hookworm or malaria also contribute to higher anemia rates in some regions. By identifying and understanding the varied causes and risk factors of anemia in women, we can move toward targeted interventions and policies that address the condition at its root rather than just managing its symptoms. Nutritional deficiencies. Nutritional deficiencies are one of the most significant and preventable causes of anemia in women. Iron, vitamin B12, and folate are essential nutrients required for the production of healthy red blood cells, and a lack of any of these can lead to a form of anemia that affects energy levels, cognitive function, and overall well-being. Unfortunately, due to a range of dietary, cultural, and economic reasons, many women around the world fail to get enough of these vital nutrients in their daily diet. Iron deficiency anemia is by far the most common type linked to nutritional gaps. Iron is a critical component of hemoglobin, the protein that allows red blood cells to carry oxygen throughout the body. When iron intake is insufficient, or when the body struggles to absorb it effectively, hemoglobin production falls, leading to symptoms such as fatigue, weakness, dizziness, and shortness of breath. Common dietary sources of iron include red meat, poultry, fish, legumes, and leafy green vegetables. However, in many parts of the world, these foods may be scarce, too expensive, or avoided due to dietary restrictions. Moreover, plant-based sources of iron are less easily absorbed by the body compared to animal-based sources, making it even more challenging for women relying on vegetarian or vegan diets. Vitamin B12 deficiency is another nutritional cause of anemia, particularly in populations where animal products are not regularly consumed. B12 is essential for red blood cell formation and neurological function. Its deficiency can lead not only to anemia, but also to nerve damage and cognitive difficulties if left untreated. Older adults, people with digestive disorders, and those following plant-based diets are particularly at risk. Unlike iron, vitamin B12 is not found in plant foods, which makes supplementation or fortified foods important for those at risk. Folate, or vitamin B9, is vital for DNA synthesis and cell division, both of which are necessary for producing red blood cells. During periods of rapid growth or increased demand, such as pregnancy, folate needs rise significantly. Without adequate intake, women may develop folate deficiency anemia, which can result in fatigue and increase the risk of birth defects if it occurs during early pregnancy. Foods rich in folate include dark leafy greens, beans, peas, and citrus fruits. Yet these are not always accessible or prioritized in all diets. Addressing nutritional deficiencies involves more than simply recommending supplements. It requires education, access to diverse and affordable food options, and sometimes changes in cultural perceptions of diet and health. By acknowledging the central role that nutrition plays in women's health, especially in preventing anemia, communities can begin to make informed choices that lead to stronger, healthier lives. Menstrual and reproductive health. Menstrual and reproductive health are central to understanding why women are disproportionately affected by anemia. The biological processes unique to women, particularly menstruation, pregnancy, and childbirth, place recurring demands on the body that significantly influence iron levels and red blood cell production. When these natural processes are not adequately supported through proper health care, nutrition, and education, they can become major contributors to the development of anemia. Menstruation, while a normal part of life for most women, can be a consistent source of iron loss. On average, women lose about 30 to 40 milliliters of blood during a typical menstrual cycle. However, women with heavy menstrual bleeding, known as menorrhagia, can lose significantly more. This excessive blood loss can deplete iron stores over time, especially if the woman's diet is not rich in iron or if she has difficulty absorbing it. Conditions such as fibroids, polycystic ovary syndrome, PCOS, or hormonal imbalances can worsen menstrual blood loss, increasing the risk of iron deficiency anemia. Pregnancy introduces another layer of vulnerability. During this time, a woman's blood volume increases to support the growing fetus, which creates a greater need for iron, folate, and vitamin B12. The developing baby draws these nutrients from the mother's body, and if her dietary intake or supplementation is insufficient, she may become anemic. Anemia during pregnancy not only affects the mother, leading to fatigue, increased risk of infection, and difficulty during labor, but also has serious implications for the baby, including low birth weight, premature delivery, and developmental delays. Postpartum recovery is another critical period. After childbirth, women often experience blood loss that, when combined with the nutritional depletion from pregnancy, can lead to prolonged anemia. If not properly treated, this can interfere with a mother's ability to care for her newborn, increase the risk of postpartum depression, and delay full physical recovery. Reproductive health issues are frequently underdiagnosed and undertreated, particularly in communities where discussing menstruation and women's health is taboo. Many women normalize heavy periods or dismiss fatigue and weakness as part of everyday life, unaware that these symptoms may point to a deeper issue. Education about menstrual and reproductive health, access to menstrual hygiene products, regular checkups, and an appropriate prenatal and postnatal care are essential steps in preventing and managing anemia. By recognizing the link between menstrual and reproductive health and anemia, we can take a more comprehensive and compassionate approach to women's health, one that supports them through every stage of life, from adolescence to motherhood and beyond. Chronic illness and genetic factors. Chronic illnesses and genetic conditions play a significant role in the development and persistence of anemia in women. While dietary and reproductive causes are often more visible, underlying health conditions can silently impact the body's ability to produce or maintain healthy red blood cells. In many cases, these types of anemia are more complex to diagnose and manage, as they are deeply tied to long-term medical conditions or inherited blood disorders. Anemia of chronic disease is one of the most common forms associated with long-standing health conditions. It occurs when chronic inflammation interferes with the body's ability to use iron or hinders red blood cell production in the bone marrow. Diseases such as rheumatoid arthritis, lupus, chronic kidney disease, diabetes, cancer, and HIV/AIDS can all contribute to this form of anemia. In these cases, even if iron levels are adequate, the body is unable to utilize them effectively due to ongoing inflammation or organ dysfunction. For example, in chronic kidney disease, the kidneys produce less erythropoietin, a hormone that stimulates red blood cell production, leading to a slow but steady decline in hemoglobin levels. For women living with chronic illnesses, the symptoms of anemia, fatigue, weakness, shortness of breath, can blend in with the symptoms of their underlying condition, making it difficult to recognize or treat. Anemia can exacerbate the fatigue and physical limitations already caused by chronic disease, reducing quality of life and complicating treatment. Regular blood tests and proactive medical care are essential to managing anemia in this context. Yet many women face barriers to consistent care due to financial, geographic, or systemic healthcare challenges. Genetic factors also contribute to specific forms of anemia, particularly inherited blood disorders such as sickle cell anemia and thalassemia. Sickle cell anemia affects the shape of red blood cells, causing them to become rigid and sickle-shaped, which impairs their ability to move through blood vessels and carry oxygen effectively. Thalassemia, on the other hand, involves mutations that reduce the production of hemoglobin. These conditions are more prevalent in certain ethnic populations and can range from mild to severe, requiring regular medical intervention, blood transfusions, or even bone marrow transplants in severe cases. Women with genetic anemias often face unique challenges in managing their condition, especially during pregnancy or illness when their oxygen needs are increased. Comprehensive care, genetic counseling, and early screening are vital in helping women with inherited forms of anemia live healthier lives. Recognizing the impact of chronic illness and genetic conditions on anemia helps shift the focus from temporary fixes to long-term, individualized care. These factors remind us that anemia is not always a simple nutritional issue. It is often a complex, multifaceted condition that demands a holistic approach to women's health. Chapter 3: Recognizing the Symptoms. Anemia often develops gradually, and its symptoms can be subtle at first, making it easy to overlook. Many women live with anemia for months or even years without realizing the root cause of their discomfort. Fatigue, one of the most common symptoms, is frequently dismissed as a natural consequence of a busy lifestyle, especially for women juggling work, family, and personal responsibilities. However, recognizing the signs of anemia early on is essential for timely diagnosis and treatment. One of the earliest and most persistent symptoms of anemia is a constant feeling of tiredness or lack of energy. This fatigue stems from the reduced oxygen supply to the body's tissues and organs, as fewer red blood cells are available to carry oxygen efficiently. Unlike ordinary tiredness that improves with rest, anemia-related fatigue tends to be more profound and long-lasting, often interfering with daily activities and overall quality of life. Another common symptom is shortness of breath, especially during physical activity. Women may find themselves becoming winded after climbing stairs or walking short distances, activities they once handled with ease. This happens because the body is working harder to deliver oxygen, compensating for the reduced efficiency of the blood. Alongside breathlessness, many women also report heart palpitations or a noticeably rapid heartbeat as the heart attempts to pump more blood to meet the body's oxygen demands. Pale or sallow skin, particularly noticeable on the face, inner eyelids, or nails, is another physical indicator of anemia. This pallor results from a reduced number of red blood cells and decreased blood flow to the skin. In some cases, the skin may also appear dry or feel cooler to the touch. Dizziness or lightheadedness is another symptom, especially when standing up quickly, which may signal low oxygen levels in the brain. Other less obvious symptoms include headaches, brittle nails, hair thinning, and a restless or irritable mood. Some women experience unusual cravings for non-nutritive substances like ice, dirt, or starch, a condition known as pica, which is strongly associated with iron deficiency anemia. In more severe cases, cognitive symptoms such as difficulty concentrating or memory problems may emerge, further affecting work and personal life. Because anemia shares symptoms with many other conditions, it can be misdiagnosed or minimized. That's why it's important for women to listen to their bodies and advocate for proper testing when symptoms persist. A simple blood test can provide crucial answers, but awareness of the symptoms is the first step toward seeking help and reclaiming health. Physical signs of anemia. Anemia is often characterized by a range of physical signs that can be both subtle and striking, depending on the severity of the condition. While symptoms like fatigue and weakness are the most commonly recognized, there are several other physical manifestations that can help identify the presence of anemia. Understanding these signs can help women detect the condition early, seek medical advice, and begin treatment before the condition worsens. One of the most noticeable physical signs of anemia is pallor, particularly a pale complexion. This occurs due to the reduced number of red blood cells, which are responsible for giving skin its healthy color. The paleness is often most visible in the face, but it can also appear on the inner eyelids or under the nails. In some cases, the skin may take on a yellowish or sallow tint, which is another indication of anemia, especially in more severe cases. Another physical sign is the appearance of brittle nails. Nails may become thin, cracked, or brittle and break easily. This happens because the body's limited supply of oxygen and nutrients is prioritized for vital organs, and the extremities, like nails, often suffer as a result. Hair thinning or hair loss can also occur due to the body's reduced ability to deliver necessary nutrients to hair follicles. This can be particularly distressing for women, as hair loss is often a visible and emotional sign of health decline. Cold hands and feet are a common and often overlooked physical sign of anemia. Because anemia reduces the efficiency of the circulatory system, the body has to work harder to maintain temperature regulation, leading to feelings of coldness in the extremities. This can result in hands and feet that feel unusually cold to the touch, even in warm environments. In more severe cases, numbness or tingling sensations in the hands and feet may occur, a result of decreased blood flow. Breathlessness and rapid heartbeat, especially during physical exertion, are also key physical signs of anemia. As the body struggles to supply adequate oxygen to the muscles and tissues, women may find themselves easily winded after activities they once did without difficulty. Additionally, the heart may begin to beat faster or more forcefully in an attempt to compensate for the lower oxygen levels in the blood, leading to a sensation of palpitations. A less obvious but equally important physical sign is the presence of cracks or sores in the corners of the mouth, a condition known as angular cheilitis. This can occur due to iron or vitamin deficiencies and is a telltale sign that anemia might be at play. Similarly, a swollen or sore tongue, known as glossitis, is often associated with vitamin B12 or iron deficiency. Recognizing these physical signs of anemia is vital for seeking timely medical care. Women experiencing one or more of these symptoms should not dismiss them as normal fatigue or aging, but rather as potential indicators of an underlying health issue that requires attention and treatment. Early detection can prevent more severe complications and improve overall health and quality of life. Emotional and cognitive impact. Anemia's effects extend beyond physical symptoms, significantly impacting emotional and cognitive well-being. As the body struggles with reduced oxygen levels, the mind and emotions also feel the strain. Women with anemia often report feeling mentally foggy, emotionally drained, and less able to manage the demands of daily life. These emotional and cognitive changes are not just a result of the condition's physical toll, but also the result of how the body's decreased red blood cell count and oxygen supply affect brain function and mood regulation. Cognitively, one of the most common complaints among women with anemia is brain fog, a state of confusion, forgetfulness, and an inability to concentrate. This can make tasks such as work, studying, or even social interactions more difficult. The brain relies heavily on oxygen to function optimally, and when the body is deprived of sufficient oxygen due to anemia, cognitive processes become impaired. This can result in difficulties with decision-making, focusing, and remembering details. Women often report a sense of mental exhaustion that is not relieved by sleep, compounding feelings of frustration and helplessness. The emotional impact of anemia can be equally profound. Many women with anemia experience feelings of irritability, sadness, or even depression. Chronic fatigue and the constant struggle to get through everyday tasks can lead to a sense of helplessness or hopelessness. As anemia progresses, these emotional shifts may intensify. Low energy levels and physical limitations make it more challenging for women to engage in social activities, exercise, or even maintain relationships, leading to feelings of isolation or disconnection. Additionally, anemia can contribute to anxiety. The constant physical discomfort and inability to perform at one's usual capacity may create stress and worry about one's health or ability to meet life's demands. This combination of physical fatigue and emotional stress can leave women feeling overwhelmed, which in turn can exacerbate the symptoms of anemia, creating a cycle that is difficult to break. Moreover, the emotional and cognitive impacts of anemia are often underappreciated in the broader conversation about the condition. Society may focus more on physical symptoms like fatigue and pallor, while overlooking how anemia can affect mental clarity, emotional stability, and overall quality of life. As a result, women may feel misunderstood or unsupported when they seek help for their symptoms. Addressing the emotional and cognitive impacts of anemia is essential for holistic treatment. Women struggling with these aspects should not only seek medical solutions for their physical symptoms, but also access mental health support. Recognizing the full scope of anemia's effects can help women better manage their health and find a balanced approach to treatment, leading to an improved quality of life overall. When to seek medical help. Recognizing when to seek medical help for anemia is crucial for managing the condition effectively and preventing complications. While mild anemia may cause only slight discomfort, untreated or severe anemia can lead to serious health issues, including organ damage, heart problems, and impaired immune function. Women experiencing any signs or symptoms of anemia should be proactive about seeking medical advice, especially if the symptoms persist, worsen, or interfere with daily life. One of the first signs that may warrant a visit to a healthcare provider is persistent fatigue that doesn't improve with rest. If you find that you are feeling overwhelmingly tired, even after a good night's sleep or a weekend of relaxation, anemia could be the underlying cause. Fatigue that limits your ability to perform everyday tasks, such as work, childcare, or exercise, should not be ignored. Additionally, if this fatigue is accompanied by other symptoms like dizziness, shortness of breath, or difficulty concentrating, it's important to seek medical attention to rule out anemia and other possible health conditions. Unexplained or unusually heavy menstrual bleeding is another sign that warrants medical attention. If you have consistently heavy periods that result in excessive blood loss, you may be at risk for iron deficiency anemia. Similarly, if you experience irregular cycles, prolonged bleeding, or spotting between periods, it's important to consult a healthcare professional for a thorough evaluation. In some cases, conditions like fibroids or endometriosis can contribute to anemia and require specialized care. Shortness of breath or an increased heart rate, particularly when performing routine activities such as walking or climbing stairs, is also a signal that it's time to consult a doctor. Anemia reduces the amount of oxygen available to the body, which can make even mild physical exertion feel overwhelming. If you experience palpitations or a racing heart along with these symptoms, it's crucial to seek medical help promptly, as these symptoms can indicate a more severe form of anemia or other underlying health conditions. For pregnant women, seeking medical help is particularly important if symptoms of anemia develop. Pregnancy increases the body's demand for nutrients like iron and folate, and without proper supplementation, anemia can lead to complications such as premature birth, low birth weight, and developmental issues for the baby. Regular prenatal checkups and blood tests are vital to ensure both the mother and baby are healthy. Finally, if you have any chronic health conditions, such as kidney disease, diabetes, or autoimmune disorders, and experience symptoms of anemia, it's important to discuss your condition with your healthcare provider. Anemia can complicate the management of chronic conditions and affect overall health outcomes. Women with inherited blood disorders like sickle cell anemia or thalassemia should also seek regular medical care to monitor their condition and prevent complications. Seeking medical help for anemia is essential for effective treatment and maintaining long-term health. If you experience any of the above symptoms, don't wait for them to worsen. Schedule an appointment with your healthcare provider to get a proper diagnosis and start the path to recovery. Chapter 4: Diagnosis and Testing. Diagnosing anemia is a critical first step in managing the condition effectively. Since anemia can be caused by various factors, ranging from nutritional deficiencies to chronic illnesses and genetic disorders, accurate diagnosis is essential to determine the appropriate course of treatment. When a woman presents with symptoms like fatigue, pallor, or shortness of breath, healthcare providers typically conduct a series of tests to pinpoint the type and underlying cause of anemia. The initial step in diagnosing anemia involves a thorough medical history and physical examination. The doctor will ask about the patient's symptoms, menstrual history, dietary habits, any chronic conditions, and family health history. They may also inquire about the patient's lifestyle and any recent changes in energy levels or overall health. A physical examination may reveal physical signs of anemia, such as pallor, irregular heartbeat, or low blood pressure, which can help guide the doctor toward further testing. Once the doctor suspects anemia, the primary test used for diagnosis is a complete blood count, CBC. A CBC provides a comprehensive snapshot of the blood, including the number and size of red blood cells, hemoglobin levels, and hematocrit, the proportion of red blood cells in the blood. Hemoglobin is the protein in red blood cells that carries oxygen, and low levels indicate anemia. The size of the red blood cells, measured by mean corpuscular volume or MCV, can also provide clues about the specific type of anemia. For example, smaller red blood cells typically suggest iron deficiency anemia, while larger cells are indicative of vitamin B12 or folate deficiency. In some cases, additional tests are required to determine the exact cause of anemia. These tests may include serum ferritin and serum iron tests to assess iron stores and identify iron deficiency anemia. If vitamin B12 deficiency is suspected, blood tests to measure B12 levels and intrinsic factor antibodies may be ordered. Folate levels can also be tested if there is concern about a folate deficiency, particularly in pregnant women. For women with chronic diseases or unexplained anemia, more specialized tests might be needed to rule out underlying conditions. Tests to assess kidney function, such as creatinine levels, or tests for autoimmune diseases, such as rheumatoid factor or antinuclear antibodies, may be necessary to determine if anemia is linked to a chronic illness. Additionally, stool tests may be conducted to check for internal bleeding, which could indicate a gastrointestinal issue causing anemia. If an inherited blood disorder like sickle cell anemia or thalassemia is suspected, genetic testing may be recommended. These tests analyze the genetic mutations responsible for the abnormal red blood cell production, allowing for a definitive diagnosis of conditions that run in families. Early and accurate diagnosis of anemia is key to managing the condition and preventing complications. With the right testing, healthcare providers can identify the type and cause of anemia and develop a treatment plan tailored to the individual's needs, whether through dietary changes, supplements, medications, or addressing any underlying health conditions. Regular follow-ups and testing are often necessary to monitor progress and adjust treatment as needed. Common diagnostic methods. The diagnosis of anemia is a multifaceted process, requiring a combination of clinical evaluation and laboratory testing. A range of diagnostic methods are used to determine the presence, type, and cause of anemia. These tests help healthcare providers establish an accurate diagnosis and create an effective treatment plan tailored to the patient's specific needs. While some diagnostic methods are simple and routine, others may require more detailed examination depending on the complexity of the case. The first and most common diagnostic method for anemia is the complete blood count, CBC. The CBC provides a broad overview of the blood's components, including red blood cells, white blood cells, hemoglobin, and hematocrit levels. Anemia is typically identified when hemoglobin levels are found to be lower than normal. The CBC also measures the size of red blood cells through the mean corpuscular volume, MCV, which can help determine the specific type of anemia. For instance, small red blood cells may suggest iron deficiency anemia, while larger red blood cells could point to a deficiency in vitamin B12 or folate. To further investigate the cause of anemia, additional blood tests are commonly performed. One of the most important is the serum ferritin test, which measures the amount of stored iron in the body. A low ferritin level is often a clear indication of iron deficiency anemia. Serum iron tests, which measure the amount of circulating iron in the blood, can also be useful in assessing iron status. In cases where vitamin deficiency is suspected, a vitamin B12 or folate test may be conducted to check for deficiencies in these critical nutrients. These tests are particularly important in women who are pregnant or have malabsorption issues, which can lead to deficiencies in these vitamins. Another diagnostic method used to assess anemia is the reticulocyte count, which measures the number of immature red blood cells in circulation. An elevated reticulocyte count can indicate that the bone marrow is producing more red blood cells in response to anemia, while a low count may suggest bone marrow dysfunction or a more severe form of anemia. This test can provide valuable insight into whether the body is attempting to compensate for the reduced number of mature red blood cells. For women who experience chronic anemia or anemia that is resistant to standard treatment, additional tests may be necessary. For example, stool tests may be conducted to check for internal bleeding, which could be caused by ulcers, hemorrhoids, or gastrointestinal cancers. Tests to evaluate kidney function, such as serum creatinine and glomerular filtration rate, GFR, may be used if kidney disease is suspected, as chronic kidney disease can contribute to anemia by reducing erythropoietin production, a hormone necessary for red blood cell production. If a genetic cause of anemia is suspected, such as sickle cell disease or thalassemia, genetic testing can confirm the diagnosis. These tests analyze specific gene mutations that affect red blood cell production and hemoglobin function, providing a definitive diagnosis of inherited blood disorders. By using these common diagnostic methods, healthcare providers can accurately identify the type and cause of anemia, allowing for timely intervention and effective management of the condition. Regular monitoring and follow-up tests may also be necessary to track the progress of treatment and adjust care plans as needed. Interpreting lab results. Interpreting laboratory results is a crucial step in diagnosing anemia, as it provides valuable information about the type and severity of the condition. When lab tests reveal abnormal blood values, healthcare providers assess these results in conjunction with a patient's symptoms, medical history, and physical examination. Understanding how to interpret common lab results can help clarify the cause of anemia and guide appropriate treatment options. One of the primary markers in diagnosing anemia is hemoglobin HB or hematocrit HCT levels. Hemoglobin is the protein in red blood cells responsible for transporting oxygen, and low levels typically indicate anemia. Normal hemoglobin levels for women range from 12 to 16 grams per deciliter, DLR, though these values can vary slightly depending on the laboratory. If a woman's hemoglobin falls below this range, anemia is suspected. Similarly, hematocrit, which measures the percentage of red blood cells in the blood, will also be low in cases of anemia. The mean corpuscular volume, MCV, is another critical lab value in interpreting anemia. This test measures the average size of red blood cells. A low MCV, microcytic anemia, suggests iron deficiency or thalassemia, while a high MCV, macrocytic anemia, is typically associated with vitamin B12 or folate deficiency. In some cases, an MCV within the normal range can point to anemia of chronic disease or hemolytic anemia, where red blood cells are being destroyed at an accelerated rate. Serum ferritin levels are essential for diagnosing iron deficiency anemia. Ferritin is a protein that stores iron in the body, and low ferritin levels indicate depleted iron stores. A ferritin level below 30 nanograms per milliliter often suggests iron deficiency, though levels can fluctuate based on inflammation or infection. For vitamin B12 and folate deficiencies, blood tests can directly measure the concentrations of these nutrients. A low B12 level, below 200 pigram milliliter, usually points to a deficiency, while folate levels below 3 nanograms per milliliter suggest a lack of folate in the body. If the reticulocyte count is elevated, it may indicate that the bone marrow is actively producing red blood cells in response to anemia. A low reticulocyte count, on the other hand, may point to a problem with red blood cell production, such as bone marrow disorders or chronic illness. Understanding and interpreting lab results helps clinicians make informed decisions regarding the treatment of anemia. By recognizing the underlying causes of abnormal values, healthcare providers can develop a personalized treatment plan that addresses the specific type of anemia and its root cause, ensuring that patients receive the most effective care possible. Challenges in diagnosing women. Diagnosing anemia in women can be particularly challenging due to several factors that intersect with the unique health needs of women. While the core symptoms of anemia, such as fatigue, dizziness, and weakness are commonly recognized, they can often overlap with other conditions that are more prevalent or distinct in women. This overlap can complicate accurate diagnosis, delaying treatment, and increasing the risk of complications. One key challenge is that many of the symptoms of anemia, particularly fatigue and low energy, are often attributed to other common issues, such as stress, hormonal fluctuations, or lifestyle factors. For example, women with heavy menstrual bleeding may assume their fatigue is simply due to their cycle, or women juggling work, family, and personal life may dismiss tiredness as a normal response to a busy schedule. Because these symptoms are so common in everyday life, women may not seek medical attention until their anemia becomes more severe. Additionally, women are more likely to experience certain types of anemia linked to reproductive health, such as iron deficiency anemia, due to heavy menstrual bleeding or pregnancy. These types of anemia may go undiagnosed or untreated until they significantly impact a woman's health. For instance, during pregnancy, iron demand increases, and if dietary intake or supplementation does not meet this demand, iron deficiency anemia can develop. The body may initially compensate for lower iron levels, making early signs subtle and hard to detect without routine screening. Another challenge arises from hormonal influences on anemia. Conditions like polycystic ovary syndrome, PCOS, or fibroids, both of which are common in women, can lead to anemia due to irregular or excessive bleeding. Women with these conditions may not initially associate their menstrual irregularities with the development of anemia, particularly if symptoms such as fatigue are more gradually increasing. Furthermore, social and cultural factors can impact the diagnosis of anemia in women. In some communities, there may be a tendency to overlook or underreport symptoms, especially if they are perceived as minor or due to normal biological processes like menstruation or childbirth. In addition, some women may face barriers to accessing health care, such as financial constraints or lack of health insurance, which can delay the diagnosis and treatment of anemia. Accurate diagnosis of anemia in women requires a careful consideration of all possible factors, from reproductive health and lifestyle to underlying chronic conditions. Healthcare providers must be vigilant in looking beyond common causes and be aware of the unique ways anemia can present in women's health. Early recognition and intervention are key to preventing complications and improving the quality of life for women with anemia. Chapter 5: Nutritional Interventions. Nutritional interventions play a pivotal role in managing and preventing anemia, especially when the condition is linked to dietary deficiencies. For women who are particularly vulnerable to iron, vitamin B12, and folate deficiencies due to menstrual cycles, pregnancy, and dietary habits, addressing nutritional gaps is crucial in alleviating the symptoms and improving overall health. Iron deficiency is the most common cause of anemia, and as such, increasing iron intake is often the first step in treating the condition. Women should aim to consume iron-rich foods such as lean meats, poultry, seafood, beans, lentils, spinach, and fortified cereals. Animal-based iron, known as heme iron, is more easily absorbed by the body than plant-based, non-heme iron. Therefore, women following vegetarian or vegan diets may need to rely on plant sources and enhance absorption by combining them with vitamin C-rich foods, such as citrus fruits, bell peppers, or tomatoes. Vitamin C improves the absorption of non-heme iron, helping to bridge the gap for those who do not consume animal products. In cases of severe iron deficiency anemia, iron supplements may be prescribed. However, it is important to note that supplementation should be done under the guidance of a healthcare provider, as excess iron can cause digestive issues and other complications. Iron supplements are most effective when taken on an empty stomach, although some individuals may need to take them with food to avoid stomach upset. Vitamin B12 and folate are essential for the production of healthy red blood cells. A deficiency in either of these vitamins can lead to megaloblastic anemia, which results in larger than normal red blood cells that cannot function properly. Foods rich in vitamin B12 include meat, dairy products, eggs, and fortified cereals. For women who follow a vegetarian or vegan diet, B12 supplementation may be necessary, as plant-based foods do not naturally contain this vitamin. Folate, on the other hand, is found in leafy greens, legumes, nuts, and seeds. Ensuring an adequate intake of these vitamins, particularly for pregnant women, is essential for both maternal health and fetal development. Aside from individual nutrients, a balanced diet that supports overall health is vital in preventing anemia. Women should focus on a diet that includes a variety of foods rich in vitamins and minerals, as well as adequate protein and healthy fats. This approach not only helps prevent anemia, but also supports the body's ability to absorb nutrients more effectively and maintain energy levels. In addition to dietary changes, women should be mindful of factors that can hinder nutrient absorption. Conditions such as celiac disease, Crohn's disease, and other gastrointestinal disorders can interfere with the body's ability to absorb iron, vitamin B12, and folate. For women with these conditions, tailored nutritional interventions and possibly supplements are essential to manage and prevent anemia. Incorporating these nutritional interventions into a daily routine can significantly improve the management of anemia and promote long-term health and well-being for women. Iron-rich foods and absorption. Iron is a vital nutrient for the production of hemoglobin, the protein in red blood cells responsible for carrying oxygen throughout the body. For individuals with anemia, particularly those with iron deficiency, consuming iron-rich foods is essential for replenishing iron stores and improving overall health. However, not all iron is created equal, and understanding how to optimize iron absorption is equally important in managing anemia effectively. Iron exists in two main forms, heme iron and non-heme iron. Heme iron, found in animal-based products, is more easily absorbed by the body than non-heme iron, which is found in plant-based foods. Sources of heme iron include lean meats, poultry, seafood, and fish. These foods provide the most bioavailable form of iron, meaning they are more readily absorbed by the body and can quickly help address iron deficiencies. Non-heme iron, found in plant-based foods such as beans, lentils, tofu, spinach, and fortified cereals, is also important for those who follow vegetarian or vegan diets. While non-heme iron is not absorbed as efficiently as heme iron, its absorption can be enhanced by combining it with certain nutrients. One of the most effective ways to boost non-heme iron absorption is by consuming vitamin C-rich foods alongside iron-rich meals. Citrus fruits, bell peppers, strawberries, and tomatoes are excellent sources of vitamin C and can significantly improve the body's ability to absorb non-heme iron. This combination is especially beneficial for individuals who rely on plant-based sources of iron. On the other hand, certain foods and substances can inhibit iron absorption. For example, calcium, found in dairy products and supplements, can interfere with iron absorption when consumed in large amounts at the same time as iron-rich meals. Similarly, tannins in tea and coffee, as well as phytates found in whole grains and legumes, can reduce iron absorption. While these foods are part of a healthy diet, it is advisable to consume them separately from iron-rich meals to maximize absorption. Cooking methods can also play a role in iron absorption. For instance, cooking in cast iron skillets can increase the iron content of food, especially when preparing acidic foods like tomatoes. Additionally, soaking, fermenting, and sprouting grains and legumes can help reduce the levels of phytates, which may inhibit iron absorption. By incorporating a variety of iron-rich foods into their diet and being mindful of how different nutrients interact with iron absorption, individuals can improve their iron status and help prevent or manage anemia. For those with iron deficiency, it is important to consult a healthcare provider for tailored dietary recommendations and, if necessary, iron supplements. Supplements and fortified foods. For individuals struggling with anemia, particularly iron deficiency anemia, supplements and fortified foods can be essential tools in restoring optimal iron levels and addressing nutritional deficiencies. While dietary changes alone can help, Supplements and fortified foods offer an effective and sometimes necessary solution to fill the gaps when dietary intake is insufficient or when the body's ability to absorb nutrients is impaired. Iron supplements are among the most commonly prescribed treatments for iron deficiency anemia. These supplements are available in various forms, including tablets, capsules, and liquid preparations, with ferrous sulfate being one of the most common types. While iron supplements can be highly effective in raising iron levels, they should be taken with caution and under medical supervision. Excessive iron intake can lead to side effects such as constipation, stomach upset, and even iron toxicity, particularly in individuals with certain medical conditions. The best approach to taking iron supplements is to follow the recommended dosage and, if necessary, take them on an empty stomach to enhance absorption, though some individuals may need to take them with food to prevent gastrointestinal discomfort. In addition to iron supplements, there are other nutritional supplements that may be recommended for anemia. Vitamin B12 and folate are essential for red blood cell production, and deficiencies in either of these nutrients can contribute to megaloblastic anemia. Vitamin B12 supplements are particularly important for individuals following a vegan or vegetarian diet, as B12 is primarily found in animal products. Folate supplements may be prescribed to women who are pregnant or those with low folate intake to help prevent and treat anemia associated with this deficiency. Fortified foods are another important aspect of managing anemia through nutrition. Many staple foods are now fortified with essential nutrients, including iron, folate, and vitamin B12, to help address common deficiencies. Breakfast cereals, bread, pasta, and milk are often fortified with iron and other nutrients to provide an easy and convenient way to increase nutrient intake. These fortified foods can be especially helpful for individuals who struggle to meet their nutritional needs through whole foods alone. For example, fortified breakfast cereals can be an excellent source of iron and folate, particularly when paired with a source of vitamin C to enhance iron absorption. While supplements and fortified foods are valuable tools for managing anemia, they should not replace a balanced diet. Whole foods, such as leafy greens, lean meats, legumes, and fortified grains, should still form the foundation of any nutritional intervention. Moreover, it's important to consult with a healthcare provider before starting any supplementation, as they can guide the appropriate dosages and recommend the most suitable forms based on individual health needs and conditions. Incorporating supplements and fortified foods alongside a well-rounded diet can significantly help in managing anemia and improving overall health. These interventions, when used properly, play a vital role in treating nutritional deficiencies and preventing the long-term effects of anemia. Cultural and socioeconomic barriers. Cultural and socioeconomic factors can significantly impact the diagnosis, treatment, and management of anemia, particularly among women. These barriers may lead to delayed care, inadequate treatment, or even a lack of awareness about the condition, making it essential to understand how culture and socioeconomic status intersect with health behaviors and access to care. Cultural beliefs and practices play a significant role in shaping health-related decisions, including how women view and address anemia. In some cultures, the symptoms of anemia, such as fatigue and weakness, may be viewed as normal, particularly in women due to menstruation, pregnancy, or motherhood. As a result, women may dismiss these symptoms as part of everyday life and delay seeking medical care. Additionally, cultural dietary practices can influence the intake of essential nutrients. For example, certain cultural traditions may prioritize plant-based diets, which, while healthy, may lack sufficient iron or vitamin B12, increasing the risk of anemia. In such cases, women may not be aware of the need to modify their diets or seek supplementation. Moreover, some cultural attitudes may discourage women from seeking medical attention or using certain treatments. In more conservative societies, women might face restrictions on their healthcare decisions, depending on family dynamics, gender roles, or community expectations. These restrictions can delay or prevent timely treatment, leading to worsened anemia or even complications during pregnancy. Socioeconomic factors also present significant barriers to managing anemia effectively. Economic hardship is one of the most common reasons for limited access to healthcare, especially in low-income populations. Women from lower socioeconomic backgrounds may not have the financial resources to visit a doctor, purchase iron supplements, or afford the necessary foods to correct nutritional deficiencies. Even when healthcare services are available, the costs of medications, blood tests, and treatments may be prohibitive for these women, further exacerbating the problem. In addition, socioeconomic status often correlates with access to education and health literacy. Women in underserved or rural communities may not be aware of the causes and symptoms of anemia or how to prevent and treat it. Lack of awareness can lead to delays in seeking help or incorrect self-management practices. The absence of proper health education programs, particularly in economically disadvantaged areas, further perpetuates this cycle. Access to nutritious food is another socioeconomic challenge that can contribute to anemia. Low-income households may have limited access to iron-rich foods such as meat, poultry, and fresh vegetables. Instead, processed or low-cost foods that lack essential nutrients may be more accessible. Food insecurity is particularly prevalent in economically disadvantaged areas, making it harder for women to obtain the necessary nutrients to maintain good health and prevent anemia. Addressing these cultural and socioeconomic barriers requires a multifaceted approach that includes increasing health education, improving access to affordable health care, and promoting culturally sensitive health interventions. By addressing the root causes of these barriers, it is possible to improve anemia management and reduce the burden of anemia among women worldwide. Chapter 6: Medical Treatments and Therapies. Medical treatments and therapies for anemia aim to address the underlying causes of the condition and restore normal red blood cell production. Depending on the type and severity of anemia, treatment may involve iron supplements, vitamin therapy, blood transfusions, or more advanced therapies to treat underlying conditions. For women, medical interventions are particularly important due to the unique health factors such as menstruation, pregnancy, and reproductive health that can contribute to the development of anemia. One of the most common treatments for anemia, especially iron deficiency anemia, is iron supplementation. Oral iron supplements, such as ferrous sulfate, are often prescribed to replenish iron stores in the body and improve red blood cell production. These supplements are usually taken daily, although they may cause side effects such as constipation or stomach irritation in some individuals. To enhance absorption, iron supplements are typically taken on an empty stomach, although this may not be suitable for everyone. In cases of severe anemia or when oral supplements are not effective, intravenous iron therapy may be recommended. IV iron infusions allow for rapid replenishment of iron levels and are often used for individuals who have difficulty absorbing iron through the digestive system or for those with chronic conditions that interfere with iron metabolism. In addition to iron supplementation, vitamin B12 and folate deficiencies can be treated with supplements. Vitamin B12 injections or high-dose oral supplements are commonly used to treat B12 deficiency anemia, especially in individuals who have difficulty absorbing the vitamin due to gastrointestinal issues. Folate supplementation is recommended for individuals with folate deficiency anemia, and this is particularly important for women who are pregnant or planning to become pregnant, as folate is crucial for fetal development. For women with anemia caused by heavy menstrual bleeding, treatment may focus on managing the underlying condition. Medications to control menstrual bleeding, such as hormonal therapies, birth control pills, or intrauterine devices, may help reduce blood loss and prevent further depletion of iron stores. In some cases, surgical interventions, such as a hysterectomy, may be necessary for women with conditions like fibroids or endometriosis that contribute to excessive bleeding. Severe cases of anemia, particularly when accompanied by symptoms like chest pain, difficulty breathing, or extreme fatigue, may require a blood transfusion. A transfusion involves the direct infusion of donor blood to quickly increase red blood cell count and improve oxygen delivery to tissues. This treatment is typically used in emergency situations or for individuals with chronic anemia that does not respond to other therapies. For anemia caused by chronic conditions, such as kidney disease or autoimmune disorders, treatments may include erythropoiesis-stimulating agents, ESAs, which stimulate the bone marrow to produce more red blood cells. These treatments are tailored to address the specific underlying condition contributing to the anemia. Overall, the medical treatment of anemia involves a thorough diagnosis to determine the root cause and an individualized approach to therapy. Regular monitoring of blood levels and adjustments to treatment plans are important for ensuring that anemia is effectively managed and that patients experience improvement in symptoms and quality of life. For women, addressing the unique factors that contribute to anemia is essential for achieving optimal health outcomes. Iron therapy and medication. Iron therapy is one of the most common and effective treatments for anemia, particularly iron deficiency anemia, which is one of the most prevalent forms of anemia in women. Iron supplements and medications help replenish the body's iron stores, enabling it to produce more hemoglobin and red blood cells. The treatment approach can vary based on the severity of anemia, the patient's tolerance, and the underlying cause of the deficiency. The most common form of iron therapy is oral iron supplementation. Iron supplements such as ferrous sulfate, ferrous gluconate, and ferrous fumarate are typically prescribed to replenish iron stores in individuals with mild to moderate anemia. These supplements are generally taken once or twice a day, and they work by increasing the iron available for hemoglobin production. However, oral iron can cause gastrointestinal side effects, including constipation, nausea, and stomach discomfort. To help reduce these side effects, iron supplements are often recommended to be taken on an empty stomach, but in some cases, patients may need to take them with food to avoid stomach upset. While oral iron therapy is effective for many individuals, some people experience difficulty absorbing iron through the gastrointestinal tract or may not tolerate the oral supplements well. For these individuals, intravenous IV iron therapy may be recommended. IV iron infusions are typically used for patients with severe iron deficiency, those who have chronic conditions that affect iron absorption, such as celiac disease or inflammatory bowel disease, or those who have not responded to oral iron therapy. Intravenous iron is rapidly absorbed into the bloodstream, providing an efficient way to restore iron levels. Common IV iron formulations include iron sucrose and ferric carboxymaltose. While IV iron therapy is generally well tolerated, there may be some side effects, such as allergic reactions, which are usually mild but can occasionally be severe. Iron therapy can be enhanced with the use of medications that promote iron absorption. Vitamin C is often recommended alongside iron supplements as it improves the absorption of non-heme iron, the type of iron found in plant-based foods. In some cases, a healthcare provider may recommend taking vitamin C supplements or consuming foods rich in vitamin C, such as citrus fruits or bell peppers, with iron-rich meals to optimize iron uptake. For individuals who cannot tolerate oral or IV iron supplements, there are other treatment options. For example, patients with chronic anemia due to kidney disease may be prescribed erythropoiesis-stimulating agents, ESAs, which stimulate the bone marrow to produce more red blood cells. These agents are typically used in combination with iron therapy to address both the underlying anemia and iron deficiency simultaneously. While iron therapy is effective for treating iron deficiency anemia, it is important for patients to follow their healthcare provider's guidance closely to avoid potential complications. Excessive iron intake can lead to iron overload, a condition that can damage organs such as the liver and heart. Therefore, it is essential to monitor iron levels regularly and adjust dosages as needed to ensure that treatment is both safe and effective. With proper management, iron therapy can significantly improve the symptoms of anemia and enhance overall health and quality of life. Treating underlying causes. While iron supplementation and other therapies can effectively treat the symptoms of anemia, addressing the underlying causes of the condition is essential for long-term health and well-being. Anemia is not a disease in itself, but rather a symptom of another underlying health issue. Therefore, identifying and treating the root cause of anemia is crucial in preventing recurrence and ensuring that individuals receive comprehensive care. In many cases, anemia is caused by chronic conditions that affect the body's ability to produce or maintain healthy red blood cells. For instance, chronic kidney disease, CKD, is a common cause of anemia, as the kidneys are responsible for producing erythropoietin, a hormone that stimulates red blood cell production in the bone marrow. When kidney function declines, erythropoietin levels drop, leading to anemia. In such cases, treating the kidney disease is paramount to managing anemia. Patients may receive erythropoiesis-stimulating agents, ESAs, to boost red blood cell production while simultaneously managing their kidney function with dialysis or other appropriate treatments. Another common underlying cause of anemia is chronic inflammatory diseases, such as rheumatoid arthritis, lupus, and inflammatory bowel disease, IBD. These conditions lead to a phenomenon known as anemia of chronic disease, ACD, where inflammation interferes with iron metabolism and red blood cell production. In such cases, managing the underlying inflammatory condition through medications like disease-modifying anti-rheumatic drugs, DMARDs, or biologics can help reduce inflammation and improve the body's ability to produce red blood cells. Treating the inflammation often leads to an improvement in anemia as the body's response to iron and red blood cell production is restored. In cases where anemia is caused by heavy menstrual bleeding, such as in women with fibroids or endometriosis, treating the underlying gynecological condition is critical. Medications to control bleeding, such as hormonal therapies, birth control pills, or intrauterine devices, may help reduce blood loss and prevent further depletion of iron stores. In some cases, surgical interventions, such as the removal of fibroids or, in more severe instances, a hysterectomy, may be necessary. By addressing the root cause of the excessive bleeding, these treatments can significantly improve anemia symptoms. Nutritional deficiencies, such as those related to vitamin B12 or folate, can also contribute to anemia. In these instances, supplementing the deficient nutrients is essential, but it is also important to identify why the deficiency exists. For example, a vitamin B12 deficiency may result from a lack of dietary intake, particularly in individuals following a vegetarian or vegan diet, or it may be caused by malabsorption issues, such as in people with celiac disease or gastric surgery. Treating the underlying cause of malabsorption and providing B12 supplementation can restore healthy red blood cell production. In addition to chronic conditions, certain genetic disorders, such as sickle cell anemia and thalassemia, also cause anemia. These genetic conditions require specialized treatments, which may include blood transfusions, bone marrow transplants, or gene therapy in some cases. Treating the genetic disorder is an ongoing process, often involving a multidisciplinary approach, and aims to manage symptoms and improve quality of life. Ultimately, treating the underlying causes of anemia is key to achieving lasting health improvements. By identifying and managing the conditions that contribute to anemia, healthcare providers can help prevent recurrent episodes and ensure that patients receive comprehensive care tailored to their unique needs. It is important for individuals experiencing anemia to work closely with their healthcare providers to address both the symptoms and the root causes of the condition. Monitoring and follow-up. Monitoring and follow-up care are essential components of effective anemia treatment. Even after the initial diagnosis and the commencement of therapy, it is crucial to regularly track a patient's progress, assess treatment effectiveness, and make necessary adjustments to the treatment plan. Regular follow-up visits also provide an opportunity to address any emerging symptoms, side effects, or complications related to anemia or its treatment. After the initiation of treatment, particularly iron supplementation or other therapies for anemia, healthcare providers typically schedule follow-up appointments to evaluate the patient's response to treatment. Blood tests, such as a complete blood count (CBC), ferritin levels, and serum iron levels, are commonly used to monitor progress. These tests help to assess whether the red blood cell count is increasing, iron stores are replenishing, and hemoglobin levels are returning to normal. In some cases, additional tests may be required to monitor vitamin B12 or folate levels if deficiencies are a concern. Depending on the severity of anemia and the treatment plan, follow-up appointments may occur anywhere from every few weeks to several months after starting treatment. One important aspect of monitoring anemia is ensuring that the patient is adhering to their prescribed treatment regimen. For example, some individuals may experience side effects from iron supplements, such as gastrointestinal discomfort or constipation, which can interfere with their ability to continue taking the medication as directed. Healthcare providers may need to adjust the dosage, switch to a different form of iron, or suggest remedies to alleviate side effects. Additionally, for patients undergoing intravenous iron therapy or blood transfusions, follow-up appointments are essential to track iron levels and ensure that there are no adverse reactions. For individuals with chronic or underlying conditions that contribute to anemia, such as kidney disease, chronic inflammation, or gastrointestinal disorders, monitoring goes beyond just the anemia itself. These conditions must be managed in conjunction with the anemia, and regular follow-up appointments allow healthcare providers to assess the overall health of the patient, adjusting treatments as necessary. For example, in patients with chronic kidney disease, regular monitoring of kidney function, hemoglobin levels, and erythropoietin production is crucial in managing anemia effectively. In the case of women with anemia caused by excessive menstrual bleeding or gynecological conditions such as fibroids or endometriosis, follow-up care is especially important. Regular assessments allow healthcare providers to monitor for any changes in symptoms or bleeding patterns, ensuring that any adjustments to hormonal therapy or surgical interventions can be made in a timely manner. In addition to medical monitoring, follow-up care involves educating the patient on the importance of maintaining a nutritious diet, avoiding iron inhibitors, and managing their condition effectively. This includes encouraging a balanced diet rich in iron, vitamin B12, folate, and other essential nutrients to support red blood cell production. Healthcare providers may also offer guidance on how to address side effects, improve absorption of iron, and manage lifestyle factors that could exacerbate anemia. Ultimately, monitoring and follow-up are integral to ensuring that anemia is managed effectively, that the underlying causes are addressed, and that the patient's quality of life is improved. Consistent follow-up care provides the opportunity for early intervention if complications arise and ensures that treatment remains on track, reducing the risk of recurrence or worsening of symptoms. Chapter 7: Preventive Strategies. Preventing anemia, especially among women, is an essential aspect of promoting long-term health and reducing the risk of complications associated with the condition. Anemia can significantly affect a woman's quality of life, leading to fatigue, weakness, and diminished productivity. By adopting effective preventive strategies, women can reduce their risk of developing anemia or mitigate its severity. These strategies encompass dietary interventions, lifestyle modifications, and proactive healthcare practices that aim to address the root causes of anemia. One of the most fundamental preventive measures is maintaining a balanced and nutritious diet. Iron deficiency is a leading cause of anemia in women, and consuming iron-rich foods is crucial for maintaining healthy iron levels. Foods high in heme iron, such as red meat, poultry, and fish, are particularly beneficial as they are more easily absorbed by the body. For those who follow vegetarian or vegan diets, it is essential to include plant-based sources of iron, such as lentils, beans, tofu, and spinach. Pairing non-heme iron from plant-based sources with foods rich in vitamin C, such as citrus fruits, tomatoes, or bell peppers, can enhance absorption. In addition to iron, adequate intake of vitamin B12 and folate is vital for preventing anemia. Foods such as eggs, dairy products, and fortified cereals can help meet the body's requirements for these essential nutrients. Another important preventive strategy is addressing menstrual and reproductive health. Women with heavy menstrual bleeding are at increased risk of developing iron deficiency anemia, as the loss of blood leads to the depletion of iron stores. Managing menstrual health through hormonal therapies, such as birth control pills or intrauterine devices, IUDs, can help regulate menstrual bleeding and reduce the risk of anemia. For women with underlying reproductive health conditions like fibroids or endometriosis, seeking early medical treatment and monitoring is crucial for preventing excessive blood loss. In addition to dietary and reproductive health strategies, it is essential to prioritize regular health screenings and checkups. Routine blood tests can help identify early signs of anemia, allowing for prompt intervention before the condition becomes severe. Regular screenings are particularly important for women who have chronic health conditions, such as gastrointestinal disorders, kidney disease, or autoimmune diseases, which can contribute to anemia. By identifying anemia early and addressing the underlying causes, healthcare providers can help prevent the condition from worsening and reduce the need for more aggressive treatments. Another preventive approach involves addressing socioeconomic and cultural factors that may limit access to adequate nutrition or healthcare. Education about the importance of a healthy diet, regular health checkups, and early intervention can help individuals make informed decisions about their health. In areas where food insecurity is prevalent, community health programs and interventions that provide access to iron-rich foods, supplements, and health services can play a vital role in preventing anemia. Social support systems, particularly for women, can help reduce barriers to accessing care and treatment. Lastly, maintaining a healthy lifestyle is a preventive measure that can help reduce the risk of anemia. Regular exercise, maintaining a healthy weight, and managing stress can all contribute to overall health and well-being, reducing the risk of conditions that can lead to anemia. Adequate rest and sleep are also important for supporting the body's natural processes, including the production of red blood cells. By integrating these preventive strategies into daily life, women can significantly reduce their risk of developing anemia. Proactive health management, including a balanced diet, regular medical checkups, and addressing reproductive health issues, is essential for preventing anemia and supporting overall well-being. Public health and education campaigns. Public health and education campaigns play a crucial role in raising awareness about anemia, its causes, and prevention strategies, especially in vulnerable populations such as women. Anemia is a significant global health issue, and its impact can be reduced through targeted education, better access to healthcare services, and community engagement. Public health campaigns that focus on anemia can empower individuals to take proactive measures to prevent the condition, seek appropriate medical care, and adopt healthy lifestyle habits. One of the primary goals of public health campaigns is to increase awareness about the importance of nutrition in preventing anemia. Many cases of anemia, particularly iron deficiency anemia, are related to poor dietary choices or inadequate access to iron-rich foods. Public health initiatives can educate the population about the importance of incorporating iron-rich foods into daily diets, such as lean meats, leafy greens, and fortified cereals. Additionally, campaigns can emphasize the role of vitamin C in enhancing iron absorption, helping individuals make informed food choices. In low-resource areas where access to iron-rich foods may be limited, education on affordable and locally available iron sources, such as beans, lentils, and dark leafy vegetables is vital. Another focus of anemia-related public health campaigns is the prevention of anemia caused by heavy menstrual bleeding. For women, menstruation is a key risk factor for iron deficiency anemia. Campaigns that promote the management of menstrual health, including the use of hormonal therapies and intrauterine devices, IUDs, can help reduce excessive blood loss and prevent anemia. Additionally, educating women on the importance of seeking medical attention for irregular or heavy bleeding can encourage early diagnosis and treatment of conditions like fibroids or endometriosis, which contribute to anemia. In countries or regions where anemia is widespread due to malnutrition or poverty, public health campaigns often focus on improving access to iron supplements and fortified foods. For instance, many governments and organizations implement iron fortification programs where essential nutrients such as iron, folic acid, and vitamin B12 are added to commonly consumed foods like flour or rice. These efforts are particularly valuable in populations where iron deficiency is prevalent and where dietary changes alone may not be enough to address the problem. In these cases, public health campaigns can promote the benefits of fortified foods and supplements as a key part of anemia prevention. The success of public health campaigns also relies on collaboration with healthcare providers, community leaders, and local organizations. In rural or underserved areas, community health workers can be instrumental in spreading the message about anemia prevention, offering screenings, and providing information on how to access healthcare services. By partnering with schools, workplaces, and religious organizations, public health campaigns can reach a wider audience and foster a greater sense of collective responsibility toward reducing anemia in the community. Furthermore, public health campaigns should address cultural and socioeconomic barriers that may affect the uptake of anemia prevention strategies. In some regions, traditional beliefs or practices may discourage the use of modern healthcare solutions, such as supplements or medications. Campaigns that are culturally sensitive and engage local communities in the design and implementation of education programs are more likely to succeed in changing attitudes and behaviors. Overall, public health and education campaigns are powerful tools in the fight against anemia. By increasing awareness, improving access to iron-rich foods and supplements, and promoting healthier menstrual and reproductive health practices, these campaigns can reduce the global burden of anemia and improve the health of women worldwide. Lifestyle and diet modifications. Making lifestyle and diet modifications is essential in managing and preventing anemia, especially for women who are at higher risk due to factors such as menstruation, pregnancy, and reproductive health issues. Adopting healthier eating habits and incorporating certain lifestyle changes can significantly improve iron levels, enhance overall well-being, and prevent the onset of anemia. A balanced diet rich in iron is one of the most effective ways to combat and prevent anemia. Women should prioritize both heme iron, found in animal products like red meat, poultry, and fish, and non-heme iron, found in plant-based foods such as lentils, beans, tofu, and spinach. The body absorbs heme iron more efficiently, so it is essential for individuals who do not consume animal products to pair non-heme iron sources with foods high in vitamin C, such as citrus fruits, bell peppers, or tomatoes. Vitamin C enhances the absorption of non-heme iron, making it more bioavailable to the body. In addition to iron, adequate intake of folate and vitamin B12 is vital for preventing anemia, especially megaloblastic anemia. Folate-rich foods like leafy greens, avocados, and fortified cereals should be incorporated into the diet. Vitamin B12, found in animal products like eggs, dairy, and meat, is also essential for red blood cell production. For individuals with dietary restrictions or absorption issues, such as vegans or those with gastrointestinal disorders, supplementation may be necessary to meet daily nutritional requirements. Alongside dietary modifications, maintaining a healthy lifestyle can help reduce the risk of anemia. Regular physical activity improves circulation, supports overall cardiovascular health, and enhances the body's ability to transport oxygen via red blood cells. While exercise alone does not directly address iron levels, it helps maintain a healthy body, ensuring that the nutrients consumed are used effectively. Adequate sleep and stress management are equally important in maintaining optimal health and preventing anemia. Chronic stress and lack of sleep can impair nutrient absorption and compromise the body's ability to produce red blood cells. Practices like mindfulness, meditation, or simply ensuring a consistent sleep schedule can go a long way in reducing stress and supporting overall health. Furthermore, managing menstrual health is an important consideration for women at risk of anemia due to excessive blood loss during menstruation. Hormonal contraceptives, such as birth control pills or intrauterine devices IUDs, can help regulate menstrual cycles and reduce heavy bleeding. For women with conditions like fibroids or endometriosis, seeking early medical intervention and treatment is crucial for preventing iron deficiency. In conclusion, lifestyle and diet modifications play a critical role in preventing and managing anemia. By focusing on a well-rounded diet that includes iron, vitamin B12, and folate, alongside maintaining a healthy lifestyle through regular exercise, stress management, and proper sleep, women can significantly reduce their risk of anemia and enhance overall health. Screening and early intervention. Screening and early intervention are essential strategies in the prevention and management of anemia, particularly for women who are more susceptible due to factors like menstruation, pregnancy, and reproductive health conditions. Detecting anemia in its early stages allows for timely treatment, which can prevent complications and improve the overall health and quality of life of affected individuals. Routine screening for anemia is a vital step in identifying the condition before it becomes severe. For women, regular blood tests as part of routine health checkups can help detect low hemoglobin levels or abnormal red blood cell counts. Early screening is especially important for women who are at higher risk, such as those with heavy menstrual bleeding, pregnant women, or those with chronic health conditions like gastrointestinal disorders or kidney disease. Identifying anemia early allows for interventions that can reverse the condition or prevent it from worsening. One of the most commonly used tests for diagnosing anemia is a complete blood count, CBC, which measures various components of the blood, including red blood cells, hemoglobin levels, and hematocrit. If these levels are found to be low, further tests may be conducted to determine the underlying cause of the anemia. These tests could include iron studies, ferritin levels, or vitamin B12 and folate levels. In cases where anemia is suspected due to chronic illness, additional tests may be required to diagnose conditions such as chronic kidney disease or gastrointestinal bleeding. Early intervention is critical in treating anemia and preventing its progression. Once anemia is detected, treatment can begin immediately, often with dietary modifications, iron supplementation, or other targeted therapies depending on the type of anemia. For example, iron deficiency anemia can be managed with iron-rich foods, supplements, or intravenous iron therapy in more severe cases. In contrast, anemia caused by vitamin B12 or folate deficiencies can be treated with supplements or dietary changes to address these specific deficiencies. In addition to medical treatments, early intervention also involves educating patients about the importance of maintaining a healthy diet, managing menstrual health, and addressing any underlying health conditions. For women with heavy menstrual bleeding, timely medical intervention, such as hormonal therapies or surgical options, can help reduce the risk of anemia. In high-risk populations or areas with limited access to healthcare, public health initiatives aimed at increasing awareness and providing regular screenings can make a significant difference in reducing the prevalence of anemia. Programs that offer free or low-cost screenings, as well as educational campaigns on anemia prevention, can help detect the condition early and ensure that women receive the appropriate care and support. In conclusion, screening and early intervention are essential in the fight against anemia. Routine screenings, timely diagnosis, and appropriate treatment can help manage the condition effectively, prevent complications, and improve the health outcomes of women worldwide. Early intervention not only addresses the immediate symptoms, but also tackles the underlying causes, providing a comprehensive approach to anemia care. Chapter 8: Social and Psychological Dimensions. Anemia, especially when left untreated or poorly managed, can have significant social and psychological impacts, particularly for women. Beyond its physical symptoms, such as fatigue and weakness, anemia can influence a woman's emotional well-being, relationships, and overall quality of life. Understanding these social and psychological dimensions is crucial for providing comprehensive care and support to women with anemia. Socially, anemia can affect a woman's ability to participate in daily activities, including work, family responsibilities, and social engagements. Fatigue and weakness may limit her energy levels, making it difficult to perform tasks that are essential for her role at home or in the workplace. This can lead to feelings of inadequacy, frustration, and isolation, especially if her condition is not understood by those around her. Furthermore, the stigma associated with being sick or unable to perform regular tasks can create social barriers, hindering women from seeking help or discussing their symptoms openly. In many cultures, there is also a lack of awareness about anemia, which can exacerbate social stigmas. Women with visible symptoms, such as pale skin or tiredness, may face judgment or misunderstanding from their communities. In some cases, anemia may be incorrectly attributed to laziness or a lack of effort, further compounding the social isolation and emotional distress experienced by those affected. Public health campaigns and community education can play a critical role in reducing these social stigmas, encouraging more open conversations, and improving support networks for women with anemia. Psychologically, anemia can lead to or exacerbate mental health challenges, including anxiety and depression. The constant fatigue and physical limitations associated with anemia can result in feelings of hopelessness or low self-esteem. Women may become frustrated by their inability to perform tasks that they previously managed with ease. Over time, these emotional responses can lead to a sense of powerlessness, especially when symptoms persist despite attempts at treatment. The psychological effects of anemia can be particularly pronounced for women who experience chronic or severe forms of the condition. Chronic anemia may affect cognitive function, leading to difficulties with concentration, memory, and decision-making. These cognitive impairments can further hinder daily activities and contribute to stress, creating a vicious cycle of worsening symptoms and emotional strain. Addressing the social and psychological dimensions of anemia is just as important as treating the physical aspects. Providing emotional support, promoting social inclusion, and reducing stigma are essential components of comprehensive anemia care. Counseling, support groups, and community education can help women navigate the psychological challenges associated with anemia, improving their overall mental health and well-being. In conclusion, the social and psychological impacts of anemia on women cannot be overlooked. By recognizing the emotional and social challenges associated with the condition, healthcare providers can offer a more holistic approach to care. This ensures that women receive not only the physical treatment they need, but also the emotional support and understanding necessary to thrive in all aspects of their lives. Stigma and misconceptions. Stigma and misconceptions surrounding anemia, particularly in women, can create significant barriers to diagnosis, treatment, and emotional well-being. Despite being a common and manageable condition, anemia is often misunderstood, and those affected may face unnecessary judgment and isolation. These social perceptions can hinder individuals from seeking help or fully engaging with the necessary interventions to manage their condition. One of the most prevalent misconceptions about anemia is that it is simply a result of laziness or poor personal habits, particularly when fatigue and weakness are the primary symptoms. Women who experience the debilitating effects of anemia, such as low energy and difficulty performing daily tasks, may be mistakenly perceived as lacking motivation or not trying hard enough. This stigma can make it even more challenging for women to acknowledge their condition and seek medical attention, as they might feel embarrassed or ashamed of their symptoms. In many cases, these misconceptions are rooted in a lack of awareness and education about anemia, which only exacerbates the social stigma. Additionally, cultural beliefs and societal expectations can contribute to the stigma surrounding anemia. In some communities, there may be a tendency to downplay or ignore health conditions that are seen as invisible, such as anemia. Women who are expected to maintain certain roles, whether at home or in the workplace, may fear being judged for taking time off or seeking treatment for what others may perceive as a trivial issue. In some cultures, there may be a reluctance to discuss health problems openly, especially those related to menstruation, which is a common cause of anemia. As a result, women may suffer in silence, feeling isolated and unsupported. The misconception that anemia is a minor or temporary condition can also lead to delayed treatment and mismanagement. Without proper education, both the public and healthcare providers may fail to recognize the more serious consequences of untreated anemia, such as cognitive impairments, weakened immunity, and increased vulnerability during pregnancy. Women who experience long-term anemia may also be at risk for chronic fatigue and emotional distress, which are often overlooked or attributed to unrelated causes, further perpetuating the stigma. Reducing the stigma and misconceptions surrounding anemia requires a concerted effort to educate both the public and healthcare professionals. Awareness campaigns that highlight the importance of early detection and treatment, along with the real-life challenges faced by individuals with anemia, can help reduce judgment and foster empathy. Moreover, normalizing conversations around women's health, including menstrual health and anemia, can help break down cultural taboos and encourage women to seek medical care without fear of stigma. In conclusion, stigma and misconceptions surrounding anemia can significantly impact women's health and well-being. By challenging these false beliefs and promoting accurate information about the condition, society can better support women in managing anemia and improve their overall health outcomes. Addressing these issues is essential in reducing the barriers to treatment and ensuring that women receive the care and understanding they deserve. Impact on daily life and relationships. Anemia can significantly affect various aspects of daily life, especially for women who are more prone to the condition. The physical symptoms, such as fatigue, weakness, and dizziness, often make it challenging to maintain a normal routine. These limitations can ripple through personal, social, and professional spheres, impacting relationships, work performance, and overall quality of life. For many women, the fatigue associated with anemia is the most debilitating symptom. Simple tasks like cooking, cleaning, or caring for family members may become exhausting and overwhelming. As a result, women may experience feelings of frustration or guilt for not being able to perform at their usual levels. These emotional burdens are often compounded by the physical exhaustion that prevents them from engaging in activities they once enjoyed, such as exercise or socializing with friends and family. This can create a sense of isolation and disconnection, particularly if others do not understand the invisible nature of the condition. The impact of anemia on relationships is also noteworthy. Women with anemia may feel hesitant to discuss their condition with loved ones, either due to a lack of awareness about the severity of the symptoms or the stigma surrounding the illness. This can lead to misunderstandings, with partners, family members, or friends perceiving the affected individual as being lazy or uninterested. Without open communication, the person with anemia may feel unsupported, further exacerbating feelings of loneliness and distress. In the workplace, anemia can also pose challenges. Chronic fatigue and difficulty concentrating can hinder performance, leading to a decrease in productivity, and potentially affecting career progression. Women may find it difficult to meet deadlines or fulfill job responsibilities, especially in physically demanding roles. This can lead to increased stress, anxiety, and even workplace discrimination if the condition is not well understood or accommodated by employers. Additionally, anemia can strain relationships with healthcare providers if symptoms are dismissed or misdiagnosed. A lack of proper diagnosis or ineffective treatment can result in prolonged suffering and frustration. Women may feel that their concerns are not being taken seriously, which could lead to diminished trust in the healthcare system and reluctance to seek further medical advice. In conclusion, the impact of anemia on daily life and relationships is far-reaching. The physical, emotional, and social challenges posed by the condition can affect a woman's ability to engage fully in her personal and professional life. A supportive environment, open communication, and increased awareness of anemia's impact are essential for helping women manage their condition and maintain healthy relationships. By addressing these challenges, women can improve their quality of life and reduce the burden of anemia on their daily lives. Empowerment and advocacy. Empowerment and advocacy are crucial elements in addressing the challenges of anemia, particularly for women who are disproportionately affected by this condition. Raising awareness, providing education, and advocating for better access to healthcare can help women take control of their health and navigate the obstacles associated with anemia. By fostering empowerment, individuals are better equipped to make informed decisions about their health, seek timely treatment, and advocate for their needs within healthcare systems and communities. Empowerment begins with education. Knowledge about anemia, its causes, symptoms, and treatment options enables individuals to recognize when they might be affected and to seek medical attention promptly. Women who are aware of the risk factors, such as heavy menstrual bleeding, pregnancy, or nutritional deficiencies, are more likely to engage in preventative measures and understand when their symptoms might indicate something more serious. Access to reliable information about anemia and its management can demystify the condition and help reduce the stigma associated with it. Advocacy plays a significant role in ensuring that women have access to the resources and support they need to manage anemia effectively. This includes advocating for better healthcare services, policies that prioritize women's health, and the availability of affordable treatments. In many regions, anemia, particularly iron deficiency anemia, remains an under-recognized and undertreated condition. By advocating for comprehensive healthcare screenings, especially for vulnerable populations, health professionals and community leaders can ensure that anemia is diagnosed and treated early, preventing complications and improving outcomes for women. On a personal level, empowerment comes from a woman's ability to speak up about her health and seek the necessary care without fear of judgment or misunderstanding. Women who feel empowered are more likely to discuss their symptoms openly with healthcare providers, leading to accurate diagnoses and timely treatment. This is particularly important in cultures or communities where women's health issues may be downplayed or stigmatized. By advocating for better healthcare services, women can challenge these societal barriers and demand that their health needs be addressed. Furthermore, advocacy extends beyond individual efforts to include collective action. Women's health organizations and support groups can unite to raise awareness, organize educational campaigns, and push for systemic changes that make healthcare more accessible. By sharing their stories and supporting each other, women with anemia can build a sense of community, reduce stigma, and encourage others to seek help. In conclusion, empowerment and advocacy are vital in addressing the challenges of anemia among women. By providing education, advocating for better healthcare, and fostering an environment where women feel confident in seeking care, we can help mitigate the impact of anemia. Empowered women are better equipped to navigate the complexities of the condition and advocate for themselves and others, ensuring improved health outcomes and reduced stigma. Conclusion: anemia in women is a multifaceted condition that affects physical, emotional, and social well-being. The prevalence of anemia is particularly high in women due to factors such as menstruation, pregnancy, and nutritional deficiencies. While the physical symptoms of anemia, such as fatigue, dizziness, and weakness, are often well known, the psychological and social implications of the condition are equally significant. These impacts can influence a woman's daily life, relationships, and overall quality of life. Understanding the causes and risk factors of anemia is crucial for effective prevention and management. Nutritional deficiencies, particularly iron and vitamins like B12 and folate, are common contributors, but chronic illnesses and reproductive health issues can also increase the risk. Recognizing these factors helps in developing targeted interventions that address the root causes of anemia. Moreover, early detection through regular screenings is vital for reducing the long-term impact of the condition and preventing complications, especially for women in high-risk groups. Despite the availability of medical treatments and nutritional interventions, stigma and misconceptions surrounding anemia persist, hindering many women from seeking help. Social barriers, including cultural attitudes and a lack of understanding, often prevent open discussions about the condition. This results in delayed diagnoses, inadequate treatment, and unnecessary suffering. Addressing these stigmas through public health campaigns, education, and community support can foster a more inclusive and understanding approach to managing anemia. Empowerment and advocacy are key in improving outcomes for women with anemia. Educating women about the condition and providing access to healthcare resources enables them to take control of their health. Additionally, advocating for better healthcare policies, increased access to screenings, and reduced healthcare costs is essential in addressing anemia on a systemic level. Advocacy not only helps individuals, but also works toward creating societal changes that support the health and well-being of women. In conclusion, anemia is a condition that requires comprehensive attention: physical, emotional, and social. Through awareness, education, early diagnosis, and effective treatment, it is possible to gauge the impact of anemia on women's lives. Breaking down the stigma, addressing the underlying causes, and empowering women to advocate for their health can lead to better outcomes and improved quality of life for those affected by anemia. Childhood Anemia, a Pediatrician's Handbook written by Julie Hord, narrated by Graziella Newson. Chapter 1: Understanding Anemia in Children. Anemia in children is a common yet often underestimated medical condition that can significantly impact growth, development, and overall well-being. It is defined as a reduction in the number of red blood cells or hemoglobin concentration below age-appropriate reference values, resulting in decreased oxygen delivery to tissues. Childhood anemia is not a single disease, but a manifestation of various underlying causes, making a thorough understanding essential for effective diagnosis and treatment. Pediatric hematology differs from adult hematology in several important ways. Hemoglobin levels naturally vary with age, and infants undergo physiological changes such as the transition from fetal to adult hemoglobin and fluctuations in erythropoietin production. These factors must be considered when evaluating a child for anemia. Additionally, nutritional demands during periods of rapid growth make children particularly vulnerable to deficiencies, especially iron, which is the most common cause of anemia worldwide. Globally, childhood anemia remains a major public health issue, particularly in low and middle-income countries. According to the World Health Organization, nearly half of children under the age of 5 are anemic, with iron deficiency being the leading contributor. However, regional variations also highlight the influence of infections, genetic disorders, and socioeconomic status on prevalence rates. In high-income countries, while the overall incidence is lower, certain populations, such as preterm infants, children with chronic illnesses, and those from disadvantaged backgrounds, remain at increased risk. Understanding the epidemiology and pathophysiology of anemia in children is foundational for effective prevention and management. It allows pediatricians to recognize at-risk populations, tailor diagnostic evaluations, and implement appropriate interventions early. As the chapters ahead will explore, addressing childhood anemia requires a multifaceted approach that integrates nutritional support, public health strategies, and individualized medical care. Definition and classification of anemia. Anemia is defined as a reduction in the concentration of hemoglobin, hematocrit, or red blood cell count below established age-specific reference ranges. In children, these values vary significantly depending on age, sex, and developmental stage, so it is critical for clinicians to use appropriate pediatric reference intervals when evaluating hematologic parameters. Anemia reflects a decreased capacity of the blood to carry oxygen, leading to tissue hypoxia and the array of clinical symptoms commonly seen in affected children. The classification of anemia is generally approached in two main ways: by etiology and by red blood cell morphology. Etiologically, anemia can be categorized into three broad groups: decreased red blood cell production, increased destruction hemolysis, and blood loss. Nutritional deficiencies, particularly iron, vitamin B12, and folate, are among the most frequent causes of decreased production in children. Chronic diseases, bone marrow suppression, and inherited disorders also contribute to this group. Hemolytic anemias may result from intrinsic red cell defects, such as sickle cell disease or thalassemia, or from extrinsic factors like autoimmune processes. Blood loss, whether acute, trauma, or chronic, gastrointestinal bleeding, menstruation, also plays a significant role, especially in adolescents. From a morphological perspective, anemia is often classified based on the mean corpuscular volume, MCV, which helps guide the diagnostic process. Microcytic anemia, where red blood cells are smaller than normal, is most commonly due to iron deficiency or thalassemia. Normocytic anemia, with normal-sized red cells, may indicate acute blood loss, chronic disease, or bone marrow failure. Macrocytic anemia, characterized by enlarged red cells, typically suggests vitamin B12 or folate deficiency, though it may also be seen in bone marrow disorders or hypothyroidism. An integrated approach that considers both the underlying cause and the red blood cell indices is essential for accurate diagnosis and management. Recognizing the classification system allows clinicians to form a structured differential diagnosis and prioritize investigations, especially in resource-limited settings where comprehensive testing may not be immediately available. Early identification and appropriate categorization of anemia can significantly improve outcomes by guiding targeted treatment and preventing complications associated with delayed diagnosis. Physiological differences in pediatric hematology. Pediatric hematology is distinct from adult hematology due to several age-specific physiological differences that influence the interpretation of blood values and the clinical presentation of hematologic disorders. Understanding these developmental variations is critical when assessing children for anemia and other blood-related conditions. At birth, newborns have significantly higher hemoglobin concentrations than older children and adults, primarily due to the presence of fetal hemoglobin, HbF, which has a higher affinity for oxygen. This adaptation is essential for intrauterine life, where oxygen levels are lower. However, following birth, the body begins a natural transition from fetal to adult hemoglobin, HbA. This change is accompanied by a physiological decline in hemoglobin levels, often referred to as physiologic anemia of infancy, which typically occurs between 6 and 12 weeks of age. While this is a normal developmental process, it can sometimes be mistaken for pathological anemia if not properly recognized. Erythropoiesis, the process of red blood cell production, also varies with age. In utero, erythropoiesis primarily occurs in the liver, but after birth, it shifts to the bone marrow. Infants and young children have a higher rate of bone marrow activity to support rapid growth and increased oxygen demands. Consequently, their reticulocyte counts, immature red blood cells, may be higher during periods of growth or after recovery from anemia. Iron metabolism is another area with significant pediatric considerations. Infants are born with iron stores that are typically sufficient for the first 4 to 6 months of life. However, after this period, dietary iron becomes essential to meet the demands of expanding blood volume and rapid development. Premature infants and those with low birth weights are particularly at risk for early depletion of iron stores and subsequent iron deficiency anemia due to reduced in utero iron accumulation. Moreover, normal reference ranges for hemoglobin, hematocrit, mean corpuscular volume, MCV, and other hematological parameters change with age. For example, the MCV is higher in newborns and gradually decreases during infancy before stabilizing in childhood. These dynamic changes necessitate age-adjusted interpretation of laboratory results to avoid misdiagnosis or overtreatment. In summary, pediatric hematology is shaped by unique developmental and physiological processes that differ markedly from adults. A thorough understanding of these differences enables clinicians to distinguish between normal age-related variations and true pathological conditions. This knowledge forms the foundation for accurate diagnosis, appropriate intervention, and effective management of anemia and other hematologic disorders in children. Epidemiology and global burden. Childhood anemia remains one of the most widespread and persistent public health challenges worldwide, affecting both developing and developed nations. According to the World Health Organization, WHO, anemia affects nearly 43% of children under the age of 5 globally, with the highest prevalence in low and middle-income countries. These figures translate to hundreds of millions of children who are at risk of impaired cognitive development, reduced physical capacity, and increased morbidity and mortality due to untreated anemia. The epidemiology of childhood anemia varies significantly by region, with sub-Saharan Africa and South Asia bearing the greatest burden. In these areas, contributing factors include widespread nutritional deficiencies, particularly iron deficiency, high rates of infectious diseases such as malaria and intestinal parasites, and limited access to healthcare and preventive services. Iron deficiency is the leading cause of anemia worldwide, accounting for roughly half of all cases in children, although the proportion may vary depending on local factors such as diet and public health infrastructure. Beyond iron deficiency, other etiologies contribute significantly to the global burden. Genetic hemoglobinopathies such as sickle cell disease and thalassemia are particularly prevalent in certain regions, including Africa, the Middle East, and parts of Southeast Asia. These inherited conditions often coexist with nutritional and infectious causes, creating complex clinical scenarios that complicate diagnosis and treatment. Chronic diseases, inflammatory conditions, and inadequate healthcare access further exacerbate the problem in many countries. In high-income countries, the prevalence of anemia is generally lower, but certain groups remain vulnerable. These include children from low-income families, recent immigrants, and those with chronic illnesses or dietary restrictions. Even within affluent societies, pockets of high prevalence can exist due to socioeconomic disparities, undernutrition, and limited health education. The global burden of childhood anemia carries far-reaching consequences. Anemia in early childhood has been linked to delayed cognitive and motor development, poor school performance, and decreased economic productivity in adulthood. It also increases the risk of maternal mortality when adolescent girls enter pregnancy with pre-existing anemia. Addressing childhood anemia is therefore not only a clinical priority, but also a developmental and economic imperative for nations. Efforts to reduce the prevalence of childhood anemia must include a combination of strategies: improving maternal and child nutrition, fortifying staple foods with iron and other micronutrients, controlling infectious diseases, and expanding access to diagnostic and treatment services. Understanding the epidemiology and global burden of anemia is the first step toward targeted interventions that can improve health outcomes for children around the world. Chapter 2: Causes of Childhood Anemia. The causes of childhood anemia are diverse and multifactorial, often overlapping in clinical presentation and complicating diagnosis. Anemia is not a diagnosis in itself, but rather a manifestation of an underlying problem. Understanding the various etiologies is crucial to effective treatment, prevention, and long-term management. Broadly, the causes of anemia in children can be grouped into three main categories: decreased red blood cell production, increased red blood cell destruction, and blood loss. One of the most prevalent causes of anemia in children worldwide is nutritional deficiency, particularly iron deficiency. Iron is essential for hemoglobin synthesis, and its absence leads to the production of smaller, less functional red blood cells. Infants, toddlers, and adolescents are particularly vulnerable due to increased iron requirements during periods of rapid growth. Inadequate dietary intake, poor absorption, or increased demands can all contribute to deficiency. Other nutritional deficiencies, such as vitamin B12 and folate, though less common, can also result in anemia, typically macrocytic in nature, often related to malabsorption syndromes, restrictive diets, or congenital disorders. Hemolytic anemias, which involve the premature destruction of red blood cells, are another significant group of causes. These can be hereditary or acquired. Common genetic causes include sickle cell disease, thalassemia, and glucose 6-phosphate dehydrogenase G6PD deficiency. These conditions are especially prevalent in certain geographic regions due to genetic selection pressures, such as malaria resistance. Acquired hemolysis can result from infections, autoimmune conditions, or exposure to certain medications or toxins. Chronic diseases can also suppress red blood cell production, either directly or through chronic inflammation. Anemia of chronic disease is common in children with infections like tuberculosis or HIV, autoimmune disorders such as juvenile idiopathic arthritis, and chronic kidney disease. In these cases, iron may be present in the body, but is poorly utilized due to inflammatory blockade of iron metabolism and erythropoiesis. Bone marrow failure syndromes, including aplastic anemia, leukemia, and myelodysplastic syndromes, are less common but critical to consider, especially when anemia is accompanied by other cytopenias. These conditions can severely impair the body's ability to produce red blood cells and may present with fatigue, pallor, infections, and bleeding. Lastly, blood loss, either acute or chronic, can also lead to anemia. In children, sources of blood loss may include gastrointestinal bleeding from parasitic infections, cow's milk protein intolerance, or inflammatory bowel disease, as well as heavy menstrual bleeding in adolescent girls. A careful evaluation of the clinical history, physical examination, and laboratory findings is essential to identify the root cause of anemia in children. Tailoring treatment to the underlying etiology is key to effective and lasting recovery. Nutritional deficiencies: iron, B12, folate. Nutritional deficiencies are among the most common and preventable causes of anemia in children, with iron, vitamin B12, and folate playing critical roles in red blood cell production. Deficiencies in these nutrients can lead to distinct types of anemia, each with its own clinical features and management strategies. Early identification and correction are essential to prevent long-term complications, particularly during periods of rapid growth in infancy and adolescence. Iron deficiency is the most prevalent cause of anemia globally, especially in children under 5. Iron is a key component of hemoglobin, and its deficiency results in microcytic, hypochromic anemia, where red blood cells are smaller and paler than normal. Infants are particularly susceptible after 6 months of age when their natural iron stores begin to deplete. Risk factors include exclusive breastfeeding without iron supplementation beyond 6 months, low birth weight, preterm birth, and diets low in iron-rich foods. Additionally, chronic blood loss from parasitic infections or cow's milk intolerance can contribute to iron deficiency. Symptoms often include fatigue, pallor, irritability, poor appetite, and in more severe cases, delayed cognitive and motor development. Vitamin B12 deficiency, though less common, can have profound effects on the nervous system as well as on blood formation. B12 is essential for DNA synthesis and neurological function, and its deficiency leads to megaloblastic anemia, characterized by large, immature red blood cells. In children, B12 deficiency may result from strict vegetarian or vegan diets without supplementation, malabsorption syndromes such as pernicious anemia, or inherited disorders affecting B12 metabolism. Clinical manifestations can include weakness, glossitis, developmental delay, and in severe cases, neurological signs like ataxia or hypotonia. Folate deficiency also causes megaloblastic anemia and is particularly important during periods of rapid cell division, such as infancy and adolescence. Folate is found in green leafy vegetables, legumes, and fortified grains, but deficiency can occur with poor dietary intake, malabsorption, or increased requirements, such as in chronic hemolysis or infections. Unlike B12 deficiency, folate deficiency does not typically cause neurological symptoms, but it can still lead to significant fatigue, poor growth, and irritability in children. In all cases, nutritional anemia requires a targeted approach, dietary counseling, supplementation, and treatment of any underlying causes, such as infections or malabsorption. Public health measures, including food fortification and nutrition education, are also vital in addressing widespread deficiencies. Preventing and treating nutritional anemia not only improves hematologic health, but also supports optimal growth and cognitive development in children. Hemolytic anemias and genetic disorders. Hemolytic anemias result from the premature destruction of red blood cells, leading to a shortened red cell lifespan and, consequently, anemia. In children, many of these conditions are genetic in origin, inherited through autosomal recessive or X-linked patterns. These disorders often present early in life and can range in severity from mild, compensated hemolysis to life-threatening anemia requiring regular transfusions. Understanding the mechanisms behind hemolytic anemias is critical for diagnosis, management, and genetic counseling. One of the most well-known hemolytic disorders is sickle cell disease, caused by a mutation in the beta-globin gene. This results in the production of abnormal hemoglobin S, which polymerizes under low oxygen conditions, causing red blood cells to become rigid and take on a sickle shape. These misshapen cells are prone to hemolysis and can obstruct small blood vessels, leading to painful vaso-occlusive crises, stroke, and organ damage. Sickle cell disease is particularly prevalent in regions where malaria is endemic, including sub-Saharan Africa, parts of India, and the Middle East, as carriers of the sickle cell trait have some protection against malaria. Thalassemia is another group of inherited hemolytic anemias characterized by impaired synthesis of one or more of the globin chains that make up hemoglobin. In beta thalassemia major, children experience severe anemia within the first year of life and often require lifelong transfusions. Alpha thalassemia, depending on the number of affected genes, can range from asymptomatic trait carriers to fatal hydrops fetalis. These disorders are common in Mediterranean, Middle Eastern, and Southeast Asian populations. Repeated transfusions can lead to iron overload, making iron chelation therapy an essential component of long-term management. Glucose 6-phosphate dehydrogenase, G6PD, deficiency is the most common enzyme deficiency worldwide and an X-linked disorder. It renders red blood cells vulnerable to oxidative stress, leading to hemolysis when exposed to certain triggers such as infections, fava beans, or specific medications. Most children with G6PD deficiency are asymptomatic until exposed to a trigger, after which they may present with jaundice, dark urine, and anemia. Other rare hemolytic disorders include hereditary spherocytosis and elliptocytosis, which involve defects in red cell membrane proteins. These conditions result in abnormal red blood cell shapes, increased fragility, and splenic destruction. Accurate diagnosis of hemolytic anemias involves a combination of clinical history, peripheral blood smear examination, hemoglobin electrophoresis, and specific genetic or enzymatic testing. Early identification and tailored management, including transfusion support, folic acid supplementation, infection prevention, and sometimes curative treatments like bone marrow transplant, can significantly improve outcomes for affected children. Chronic illnesses and bone marrow suppression. Chronic illnesses and bone marrow suppression are important but often underrecognized causes of anemia in children. Unlike nutritional deficiencies or genetic disorders, these conditions typically result in normocytic or macrocytic anemia and may present with additional systemic signs depending on the underlying disease. In many cases, the anemia is multifactorial, involving both decreased production and altered red blood cell lifespan, making diagnosis and management more complex. Anemia of chronic disease, also referred to as anemia of inflammation, is commonly seen in children with long-standing infections, autoimmune disorders, or chronic kidney disease. In these conditions, inflammatory cytokines interfere with iron metabolism and inhibit erythropoiesis. Specifically, the liver produces increased levels of hepcidin, a hormone that prevents the release of iron from storage sites and reduces intestinal absorption. As a result, iron becomes sequestered in the body, and red blood cell production slows, even though iron stores may appear adequate. Children with chronic infections, such as tuberculosis or HIV, or those with autoimmune diseases like juvenile idiopathic arthritis, frequently develop this type of anemia. Chronic kidney disease, CKD, contributes to anemia primarily through decreased production of erythropoietin, a hormone necessary for red blood cell synthesis. Pediatric patients with CKD may also experience iron deficiency, chronic inflammation, and uremic toxins that suppress marrow function. Treatment often requires a combination of erythropoietin-stimulating agents, iron supplementation, and management of the underlying renal condition. Bone marrow suppression is a more direct cause of decreased red blood cell production and may result from a range of conditions, including infections, malignancies, and drug toxicities. Viral infections such as parvovirus B19 can cause transient aplastic crises by directly inhibiting red cell precursors. Chemotherapy, radiation, and certain medications can damage the marrow, leading to pancytopenia. Bone marrow failure syndromes, such as aplastic anemia, present with profound anemia and low counts in other cell lines, including white blood cells and platelets. These cases require urgent evaluation and often need bone marrow transplantation or immunosuppressive therapy. Infiltrative diseases such as leukemia and myelodysplastic syndromes may also suppress normal marrow activity. These conditions can be life-threatening and are often suspected when anemia is accompanied by fatigue, bruising, recurrent infections, or abnormal physical findings like hepatosplenomegaly. Management of anemia related to chronic illness or marrow suppression involves treating the underlying disease, supporting hematopoiesis with nutritional or pharmacologic therapies, and in some cases, providing transfusions. Close monitoring and interdisciplinary care are essential to address both the hematologic and systemic aspects of these conditions. Chapter 3: Clinical Presentation and Symptoms. The clinical presentation of anemia in children can vary widely depending on the severity, duration, and underlying cause of the condition. While some cases are detected incidentally through routine blood tests, others may present with clear and sometimes alarming symptoms. Recognizing the signs of anemia early is essential for timely diagnosis, appropriate investigation, and effective management. Mild anemia is often asymptomatic and may go unnoticed without laboratory evaluation. However, as hemoglobin levels drop, the child's ability to transport oxygen effectively decreases, leading to more pronounced symptoms. One of the most common early signs is pallor, particularly noticeable in the skin, nail beds, lips, and conjunctiva. Parents or caregivers may also report increased fatigue, decreased activity levels, or a general lack of energy. These changes are often gradual, making them harder to detect in chronic cases. As anemia progresses, symptoms may become more pronounced. Children might experience shortness of breath, especially with exertion, and an increased heart rate as the body tries to compensate for reduced oxygen carrying capacity. Irritability, poor concentration, and difficulty keeping up with peers in physical activities or schoolwork may also become apparent. In infants and toddlers, anemia can impair growth and developmental milestones, contributing to delayed motor or cognitive progress. The presentation can differ based on the cause of anemia. For example, in iron deficiency anemia, children may exhibit pica, craving for non-nutritive substances such as dirt or ice. In cases of vitamin B12 deficiency, neurological symptoms like numbness, unsteady gait, or delayed language development may be observed. Children with hemolytic anemia may have episodes of jaundice, dark-colored urine, or splenomegaly due to increased red cell breakdown. In inherited disorders like sickle cell disease, pain crises and swelling of the hands and feet can be key clinical features. Severe anemia can lead to signs of cardiovascular strain, such as a systolic flow murmur, increased pulse pressure, or heart failure in extreme cases. These are medical emergencies that require urgent intervention. In adolescence, heavy menstrual bleeding or poor nutritional intake may be contributing factors, and menstrual history becomes an important part of the evaluation. A thorough clinical assessment, including a detailed history and physical examination, is crucial in identifying both the presence of anemia and clues to its underlying cause. Clinicians should consider the duration, onset, and associated symptoms to guide further investigation. Early recognition of clinical signs allows for prompt treatment and the prevention of potential complications related to untreated or progressive anemia in children. Recognizing early signs and symptoms. Recognizing the early signs and symptoms of anemia in children is essential for prompt diagnosis and intervention. Early detection can prevent the progression of the condition and minimize the risk of complications. While some children with mild anemia may not exhibit any noticeable symptoms, others may present with subtle signs that require keen observation from caregivers and healthcare providers. The most common early symptom of anemia in children is pallor, which occurs when there is insufficient hemoglobin in the blood to provide the usual rosy color to the skin. Pallor is typically most evident in the nail beds, the inner aspect of the lower eyelids, and the mucous membranes, such as the lips and tongue. Parents may first notice a paleness that persists even after the child has rested or recovered from physical exertion. It is important to note that pallor alone is not diagnostic of anemia, but when observed alongside other signs, it should raise concern. Fatigue and lethargy are often among the earliest and most prominent symptoms of anemia. Children may seem more tired than usual, with a reduced ability to engage in physical activities they previously enjoyed. They may tire easily during play or appear more irritable than normal. In younger children, parents may report that the child is sleeping more often or showing disinterest in their usual activities. As anemia becomes more pronounced, children may also develop shortness of breath or increased heart rate with even mild exertion. This is because the body tries to compensate for the lack of oxygen carrying capacity in the blood by pumping more blood to tissues and organs. If anemia is severe or long-standing, the body may exhibit compensatory mechanisms like an increase in respiratory rate or a noticeable increase in the child's resting pulse. Another early symptom in some cases of iron deficiency anemia is pica, where children develop cravings for non-food substances, such as dirt, ice, or starch. This unusual behavior is thought to be a result of the body's attempt to obtain missing nutrients or minerals. Additionally, in more severe forms of anemia, children may experience dizziness, headaches, or even fainting spells. Neurological symptoms can be early indicators in certain types of anemia, such as vitamin B12 deficiency. In these cases, parents may notice developmental delays, difficulty with coordination or balance, and speech delays. Ultimately, the key to recognizing anemia early lies in observing changes in a child's energy levels, physical performance, and overall behavior. Parents should be vigilant for subtle signs of fatigue, pallor, or changes in appetite or activity levels. If these signs are observed, a healthcare provider should be consulted for further evaluation and, if necessary, appropriate testing to confirm the diagnosis and determine the underlying cause. Age-specific manifestations. The clinical manifestations of anemia in children can vary significantly depending on the child's age, with different age groups displaying unique symptoms and patterns. Recognizing these age-specific manifestations is crucial for early diagnosis and appropriate management, as the impact of anemia can differ based on a child's developmental stage. In infants, anemia may often be asymptomatic in the early stages, but as hemoglobin levels drop, parents may notice subtle signs such as irritability, poor feeding, and decreased activity. Infants who are exclusively breastfed and not supplemented with iron may be at higher risk for iron deficiency anemia after 6 months of age, when their natural iron stores begin to deplete. Growth delays, including reduced weight gain and slower motor development, are common signs of anemia in this age group. If the anemia is severe, symptoms like pallor, lethargy, and poor feeding may become more pronounced, and the infant may appear more fatigued than usual during feeding or playtime. In toddlers and preschool-aged children, the clinical signs of anemia become more noticeable. These children may become easily fatigued, and parents might observe that their child tires quickly during physical activities such as running or climbing. Decreased stamina during play, along with irritability, poor appetite, and slower developmental milestones, can signal the presence of anemia. Iron deficiency in this age group is often linked to inadequate dietary intake or poor absorption, and children may exhibit symptoms like pica, craving non-nutritive substances such as dirt or ice. In school-aged children, symptoms of anemia, such as pallor and fatigue, often interfere with daily activities and academic performance. These children may show difficulty concentrating in school, have reduced energy levels during physical activities, or demonstrate decreased endurance during sports. They may also have a decreased interest in engaging with peers, and in some cases, a noticeable drop in academic performance. It's also important to note that anemia can be especially prevalent during periods of rapid growth, such as in early adolescence. Adolescents, particularly girls, may present with anemia related to heavy menstrual bleeding, which can cause a slow but steady decline in hemoglobin levels. Anemia in adolescent girls may present with symptoms such as pallor, fatigue, and lightheadedness, especially during or after menstruation. In this group, anemia can also result from poor dietary habits, including restrictive diets or inadequate intake of essential nutrients like iron and vitamin B12. For both boys and girls, delayed puberty or slower physical growth may also be observed in more severe cases. Each age group presents distinct challenges in identifying and managing anemia. In infants and young children, caregivers need to be especially attuned to subtle changes in behavior, while school-aged children and adolescents may show more apparent effects of anemia on physical activity and academic performance. Early intervention is key to preventing long-term developmental and cognitive effects of anemia across all age groups. Differentiating anemia from other conditions. When a child presents with symptoms such as fatigue, pallor, or poor growth, it is essential to differentiate anemia from other medical conditions that can cause similar signs. Although anemia is one of the most common causes of these symptoms, numerous other disorders can present with overlapping clinical features. Therefore, a thorough clinical evaluation, including history, physical examination, and laboratory tests, is necessary to reach an accurate diagnosis. One of the key challenges in differentiating anemia from other conditions is recognizing that fatigue, pallor, and irritability are nonspecific symptoms. For example, these symptoms are also commonly seen in children with infections, chronic diseases, or endocrine disorders. Viral infections, such as the common cold or influenza, can cause generalized malaise and pallor. However, in these cases, other signs, such as fever, congestion, and cough, are typically present, which can help distinguish these conditions from anemia. If an infection leads to anemia, it is typically due to blood loss or hemolysis, and the anemia may resolve as the infection subsides. Other chronic conditions, such as inflammatory bowel disease, IBD, can also present with symptoms similar to those of anemia, including fatigue, weight loss, and pallor. IBD, which includes Crohn's disease and ulcerative colitis, can lead to anemia through both chronic blood loss from gastrointestinal bleeding and malabsorption of nutrients. A careful assessment of gastrointestinal symptoms, such as abdominal pain, diarrhea, and blood in the stool, is essential in distinguishing IBD from primary anemia. Endocrine disorders, such as hypothyroidism, can mimic the symptoms of anemia. Children with hypothyroidism may experience fatigue, lethargy, constipation, and weight gain, all of which overlap with the symptoms of anemia. However, in hypothyroidism, additional signs such as dry skin, cold intolerance, and delayed growth are typically present. Blood tests measuring thyroid function, T3, T4, and TSH can confirm the diagnosis of hypothyroidism. Iron deficiency anemia may also need to be differentiated from other types of anemia, such as thalassemia or anemia of chronic disease. Thalassemia, for example, can present with microcytic anemia and pallor, similar to iron deficiency anemia. However, thalassemia typically shows more pronounced abnormalities in red blood cell morphology, such as target cells and microcytosis, and is often diagnosed through hemoglobin electrophoresis or genetic testing. Anemia of chronic disease is characterized by low iron stores despite normal or elevated ferritin levels, and it is usually associated with underlying conditions such as infections, autoimmune diseases, or chronic kidney disease. Finally, nutritional deficiencies in vitamin B12 and folate can present with megaloblastic anemia, which can be confused with iron deficiency anemia, but the blood smear typically reveals larger red blood cells, macrocytosis. B12 deficiency may also present with neurological symptoms, such as numbness or difficulty walking, which can help distinguish it from iron deficiency anemia. In conclusion, differentiating anemia from other conditions requires a comprehensive approach that includes taking a detailed medical history, performing a thorough physical examination, and conducting appropriate laboratory tests. By carefully considering the full range of symptoms and using diagnostic tools such as blood tests, healthcare providers can ensure that the child receives the correct diagnosis and appropriate treatment. Chapter 4, Diagnostic Approach. The diagnostic approach to anemia in children involves a systematic process that begins with a thorough clinical assessment and is followed by appropriate laboratory investigations. Identifying the underlying cause of anemia is crucial for selecting the most effective treatment. The diagnostic process can be broken down into several key steps: history taking, physical examination, initial laboratory tests, and, when necessary, further specialized investigations. The first step in the diagnostic approach is a detailed history. The clinician should inquire about the child's dietary habits, any known chronic illnesses, family history of anemia or genetic disorders, and any recent infections or medications that may contribute to anemia. Particular attention should be given to symptoms such as fatigue, pallor, weight loss, or changes in appetite, as well as to any signs of blood loss, such as gastrointestinal bleeding, heavy menstrual periods, or frequent nosebleeds. A comprehensive family history can help identify inherited conditions like sickle cell disease or thalassemia, which may be more prevalent in certain ethnic groups. A thorough physical examination follows the history, focusing on signs of anemia such as pallor of the skin, conjunctiva, and mucous membranes. The clinician should also check for other potential findings, such as an enlarged spleen, splenomegaly, or liver, hepatomegaly, which may suggest hemolytic anemia or a systemic condition like chronic infection or malignancy. A heart murmur, especially a systolic murmur, may be present in severe anemia due to increased cardiac output, and tachycardia is a common compensatory response to anemia. Once the clinical assessment is completed, laboratory tests form the cornerstone of the diagnostic workup. The initial test is typically a complete blood count, CBC, with reticulocyte count, which provides essential information about red blood cell production. The CBC will help assess hemoglobin levels, red blood cell count, hematocrit, and the mean corpuscular volume, MCV, which can guide the clinician toward a specific type of anemia, e.g., microcytic, normocytic, or macrocytic. Reticulocyte counts help assess bone marrow response to anemia. An elevated reticulocyte count suggests active erythropoiesis, while a low count may indicate a failure to produce red blood cells. Based on the results of the CBC, further tests may be needed. If the anemia is microcytic, low MCV, the clinician may suspect iron deficiency or thalassemia, and additional tests such as serum ferritin, transferrin saturation, and hemoglobin electrophoresis may be ordered. For macrocytic anemia, vitamin B12 and folate levels should be assessed, as deficiencies in these nutrients can lead to impaired DNA synthesis and large red blood cells. If the anemia appears to be related to chronic disease, tests for inflammatory markers, such as C-reactive protein, CRP, or erythrocyte sedimentation rate, ESR, may be helpful. In cases of suspected hemolytic anemia, further investigations are warranted to evaluate the cause of increased red blood cell destruction. These tests may include a peripheral blood smear, which can reveal the presence of abnormal red blood cell shapes, e.g., sickle cells or spherocytes, and a direct antiglobulin test, Coombs test, to detect autoimmune hemolysis. When the cause of anemia remains unclear, or when more complex genetic or bone marrow disorders are suspected, additional testing, such as bone marrow aspiration or genetic testing, may be required. Bone marrow examination is particularly useful in diagnosing conditions like aplastic anemia or leukemia, while genetic tests can confirm inherited disorders like sickle cell disease or thalassemia. In summary, a systematic diagnostic approach to childhood anemia involves careful history taking, thorough physical examination, and targeted laboratory investigations. This comprehensive approach ensures that the underlying cause of anemia is identified and enables appropriate treatment strategies to be implemented. History taking and physical examination. Effective history taking and a thorough physical examination are essential components of diagnosing anemia in children. These initial steps provide valuable clues that guide further investigation and help identify the underlying cause of anemia. The clinician must approach the child with a systematic and comprehensive evaluation to gather all pertinent information that may influence diagnosis and treatment. The history-taking process begins with an assessment of the child's symptoms. The clinician should inquire about the duration, onset, and severity of symptoms, such as fatigue, pallor, irritability, poor appetite, and any signs of decreased physical activity. Symptoms like difficulty concentrating or frequent complaints of tiredness during routine activities are common in children with anemia. Parents should also be asked about any recent growth or developmental delays, as anemia can impact a child's physical and cognitive growth. In addition to symptoms, the clinician should explore the child's dietary history. Questions should focus on iron-rich foods, such as meats, beans, and leafy greens, as well as the intake of vitamin B12 and folate. For younger children, an assessment of feeding habits, including breastfeeding and formula supplementation, is necessary. The presence of pica, craving for non-food substances like dirt or ice, is often a red flag for iron deficiency anemia and should be specifically inquired about. A comprehensive family history is also important, as many types of anemia, such as thalassemia and sickle cell disease, have a genetic component. Inquiring about family members with similar symptoms, genetic blood disorders, or chronic diseases can help identify inherited causes of anemia. Additionally, family members with chronic illnesses or autoimmune diseases may provide clues about anemia related to systemic conditions. When it comes to the physical examination, the clinician should focus on signs that may indicate the severity and cause of anemia. Pallor is a hallmark sign of anemia and should be assessed in the skin, nail beds, conjunctiva, and mucous membranes. The color of the child's lips, gums, and the inside of the lower eyelids can provide insight into the degree of anemia. The examiner should also look for signs of underlying disease, such as fever or signs of infection, which might suggest anemia due to chronic illness. A key component of the physical exam is checking for signs of blood loss or excessive red blood cell destruction. This includes looking for bruising, petechiae, small red spots, or signs of gastrointestinal bleeding, such as black, tarry stools, or abdominal pain. In children with suspected hemolytic anemia, the presence of jaundice, yellowing of the skin or eyes, or an enlarged spleen, splenomegaly, or liver hepatomegaly should be evaluated. In cases of severe anemia, a heart murmur may be heard on auscultation, especially a systolic murmur, which occurs due to increased cardiac output as the heart compensates for the decreased oxygen carrying capacity of the blood. In addition to the basic exam, the clinician should assess the child's growth and development, particularly in younger children. Delayed growth or failure to thrive can indicate chronic or severe anemia, and the impact of anemia on development can be significant in the early years. In summary, a thorough history and physical examination are the foundation of diagnosing anemia in children. By carefully assessing symptoms, dietary history, family background, and performing a detailed physical exam, healthcare providers can gather vital information that directs the next steps in diagnostic testing and management. This systematic approach ensures that anemia is appropriately diagnosed and treated based on its underlying cause. Laboratory investigations and interpretation. Laboratory investigations are a critical component in the diagnostic approach to anemia in children. After a detailed history and physical examination, the results of laboratory tests provide essential information to confirm the diagnosis, assess the severity of anemia, and identify its underlying cause. Proper interpretation of these tests is crucial for determining the appropriate treatment plan. The first and most essential test in the diagnostic workup of anemia is a complete blood count, CBC. The CBC provides a comprehensive overview of the child's blood and helps assess key parameters such as hemoglobin, HB concentration, hematocrit, red blood cell RBC count, and mean corpuscular volume, MCV. Hemoglobin levels are crucial in determining the severity of anemia, with values below the reference range indicating anemia. The MCV helps categorize the anemia as microcytic, low MCV, normocytic, normal MCV, or macrocytic, high MCV, guiding further investigations into the type of anemia. In addition to the CBC, the reticulocyte count is another important test that evaluates the bone marrow's response to anemia. Reticulocytes are immature red blood cells released by the bone marrow into circulation, and an elevated reticulocyte count typically indicates active red blood cell production, often in response to acute blood loss or hemolysis. A low reticulocyte count, on the other hand, suggests impaired bone marrow function, which could be due to iron deficiency, chronic disease, or bone marrow failure. Once the initial blood counts are obtained, additional tests are often necessary to narrow down the cause of the anemia. For example, if the anemia is microcytic, further testing for iron deficiency is essential. Serum ferritin, which reflects iron stores in the body, is a key marker for iron deficiency anemia. Low ferritin levels, along with low hemoglobin and MCV, strongly suggest iron deficiency. In contrast, if ferritin levels are normal or elevated despite low hemoglobin, anemia of chronic disease or thalassemia should be considered. For macrocytic anemia, measuring levels of vitamin B12 and folate is critical, as deficiencies in these nutrients can lead to impaired red blood cell production and larger than normal red blood cells. A deficiency in vitamin B12 is also associated with neurological symptoms, such as numbness or difficulty walking, which can aid in diagnosis. If B12 or folate levels are low, supplementation can be started to correct the deficiency. For suspected hemolytic anemia, a peripheral blood smear can reveal abnormal red blood cell shapes or the presence of fragmented red cells. A direct antiglobulin test, Coombs test, can help identify autoimmune hemolysis, while other tests like haptoglobin, lactate dehydrogenase, LDH, and bilirubin levels can assess the degree of red blood cell destruction. In some cases, additional specialized tests are needed to further investigate the cause of anemia. These may include hemoglobin electrophoresis to diagnose hemoglobinopathies like sickle cell disease or thalassemia, or bone marrow aspiration in cases of suspected bone marrow failure or leukemia. In conclusion, laboratory investigations are essential for confirming the diagnosis of anemia and identifying its cause. By interpreting the results of the CBC, reticulocyte count, and additional specialized tests, healthcare providers can determine the underlying condition and guide appropriate treatment. Accurate interpretation of these laboratory findings is critical for effective management and ensuring the child's recovery. Diagnostic challenges in resource-limited settings. In resource-limited settings, diagnosing anemia in children presents unique challenges that can hinder timely and accurate diagnosis, leading to delays in treatment and management. Limited access to healthcare facilities, diagnostic tools, and specialized personnel complicates the process of identifying the underlying cause of anemia. These challenges are particularly pronounced in low and middle-income countries, where healthcare systems may be underfunded or overburdened, affecting the quality and availability of diagnostic services. One of the most significant challenges is the lack of access to advanced diagnostic technologies. In well-equipped healthcare settings, tests like hemoglobin electrophoresis, bone marrow aspiration, or specialized imaging studies can help pinpoint the exact cause of anemia. However, these tests may not be readily available in resource-limited settings. As a result, healthcare providers often rely on basic tools, such as a complete blood count, CBC, to make a diagnosis. While the CBC is a valuable initial screening test, it may not provide enough information to determine the specific type of anemia or its cause, necessitating further clinical investigation or trial and error in treatment. Another challenge in these settings is the limited availability of blood products or treatments for anemia, such as iron supplementation or blood transfusions. In cases of severe anemia, especially when caused by acute blood loss or hemolytic anemia, the lack of access to timely interventions can lead to complications and even death. Additionally, pediatricians may face difficulties in providing adequate follow-up care to monitor the effectiveness of treatment due to resource constraints and the high volume of patients. The scarcity of trained healthcare professionals in resource-limited settings also contributes to diagnostic difficulties. Skilled pediatricians, hematologists, or laboratory technicians may be in short supply, leading to challenges in interpreting test results accurately or in making complex clinical decisions. In areas with a shortage of specialized care, healthcare workers may have limited experience in managing the range of anemias that exist, further complicating diagnosis and treatment. Moreover, the prevalence of malnutrition, infections, and chronic diseases in resource-poor settings can lead to anemia being one symptom among many. Conditions such as malaria, tuberculosis, or parasitic infections can present with anemia, often making it difficult to determine whether anemia is the primary condition or a secondary manifestation of another illness. In these contexts, healthcare providers must rely heavily on clinical judgment, sometimes making it harder to differentiate between conditions without the luxury of more advanced diagnostic testing. In conclusion, diagnostic challenges in resource-limited settings are multifaceted, involving issues related to access to healthcare services, diagnostic tools, trained personnel, and follow-up care. Overcoming these barriers requires innovative solutions, including improving healthcare infrastructure, increasing access to basic diagnostic equipment, and providing ongoing education and training to healthcare providers. In the face of these challenges, early clinical recognition, prudent use of available resources, and targeted interventions are essential for managing childhood anemia in these settings. Chapter 5, Iron Deficiency Anemia. Iron deficiency anemia, IDA, is the most common form of anemia in children worldwide. It occurs when there is an insufficient amount of iron in the body, leading to decreased production of hemoglobin and consequently reduced oxygen carrying capacity of the blood. This condition can have significant implications for a child's growth, development, and overall health, making early detection and treatment crucial. The primary cause of iron deficiency anemia is inadequate iron intake, often due to a diet lacking in iron-rich foods such as meat, beans, and leafy greens. In infants and young children, iron deficiency anemia is often seen when they transition from breast milk or formula, which contain adequate iron, to a diet that lacks sufficient iron. For older children, inadequate dietary intake, increased iron requirements due to rapid growth, or both can contribute to the development of IDA. Additionally, blood loss from conditions like gastrointestinal bleeding or heavy menstruation in adolescent girls can also lead to iron deficiency. The clinical presentation of iron deficiency anemia can vary depending on the severity of the deficiency. Common symptoms include fatigue, pallor, irritability, and weakness. Children with more severe anemia may experience dizziness, tachycardia, or poor appetite. In some cases, iron deficiency can lead to pica, a condition where children crave non-food items such as dirt, ice, or starch. In addition, children with IDA may show delayed cognitive development, as iron plays a critical role in brain function, particularly in early childhood. Diagnosis of iron deficiency anemia is made through laboratory tests, with the most important being the complete blood count, CBC, which will typically show a low hemoglobin level, and low mean corpuscular volume, MCV, indicating microcytic anemia. The serum ferritin level is the most specific test for diagnosing iron deficiency, as it reflects the body's iron stores. Low ferritin levels, along with low hemoglobin and low MCV, confirm the diagnosis. Other tests, such as serum iron, transferrin saturation, and total iron binding capacity, may also be helpful in assessing the degree of deficiency and monitoring treatment progress. Treatment of iron deficiency anemia primarily involves iron supplementation, either through oral iron preparations or, in more severe cases, intravenous iron. Oral iron supplements are typically well tolerated but can cause gastrointestinal side effects such as constipation or upset stomach. The duration of treatment varies, but iron supplementation is usually continued for several months to replenish iron stores in the body. In cases where there is an underlying cause of blood loss, such as gastrointestinal bleeding, that cause must be addressed in conjunction with iron supplementation. Prevention of iron deficiency anemia focuses on ensuring that children receive an adequate intake of iron-rich foods. For infants, continued breastfeeding or iron-fortified formula is recommended during the first year of life. As children begin eating solid foods, caregivers should offer iron-rich foods and include vitamin C-rich foods, which enhance iron absorption. In areas with high rates of iron deficiency, iron supplementation may be recommended as a preventive measure, especially for high-risk groups such as premature infants, toddlers, and adolescent girls. In conclusion, iron deficiency anemia is a common and preventable condition in children. Timely diagnosis and appropriate treatment, including iron supplementation and dietary adjustments, are key to managing the condition and promoting optimal growth and development. By addressing the root cause of the deficiency and preventing recurrence, the long-term impact of iron deficiency anemia on a child's health can be minimized. Pathophysiology and risk factors. The pathophysiology of iron deficiency anemia, IDA, centers around the insufficient availability of iron, which is a crucial component for the production of hemoglobin in red blood cells. Hemoglobin is responsible for carrying oxygen throughout the body, and when iron is deficient, the body is unable to produce adequate amounts of hemoglobin. This results in a reduced oxygen-carrying capacity of the blood, leading to the common symptoms of anemia, such as fatigue, pallor, and weakness. The body responds to the lack of hemoglobin by increasing the production of erythropoietin, a hormone that stimulates red blood cell production. However, without enough iron, the bone marrow produces smaller, microcytic, and fewer red blood cells, further exacerbating the condition. Iron is an essential mineral involved in several biological processes, including oxygen transport, DNA synthesis, and electron transport in cells. It is absorbed in the small intestine and stored in the liver, bone marrow, and spleen as ferritin. When iron stores are depleted, the body prioritizes its use for critical processes, such as oxygen transport, which can leave other functions impaired. Over time, if iron deficiency persists, it can result in impaired red blood cell production and contribute to the clinical manifestations of anemia. Several risk factors contribute to the development of iron deficiency anemia in children. One of the primary risk factors is inadequate dietary intake of iron. Infants and toddlers who are not breastfed or who are given cow's milk before their first year of life are at increased risk due to the low bioavailability of iron in cow's milk. Additionally, children with diets that lack sufficient iron-rich foods, such as meat, beans, and leafy vegetables, are more likely to develop IDA. Rapid growth periods, particularly during infancy and adolescence, increase iron requirements. During these times, if dietary intake is not adjusted to meet the increased demand for iron, children are at heightened risk for developing anemia. For adolescent girls, menstrual blood loss can also lead to iron deficiency, especially if menstrual periods are heavy or if there is inadequate dietary iron intake to compensate for the loss. Other significant risk factors include gastrointestinal disorders, such as celiac disease or inflammatory bowel disease, which can impair iron absorption. Children with chronic infections or conditions like malaria are also at higher risk, as the body's ability to absorb and utilize iron is often compromised in these states. Premature infants, who have lower iron stores at birth, are also at a greater risk for developing iron deficiency anemia, especially if they are not given iron supplements. In summary, the pathophysiology of iron deficiency anemia is primarily driven by a lack of iron, leading to impaired hemoglobin production and reduced oxygen transport. Understanding the risk factors, including dietary habits, growth stages, and underlying medical conditions, is essential for identifying children at risk and implementing early prevention and treatment strategies. Prevention strategies and nutritional guidelines. Preventing iron deficiency anemia (IDA) in children requires a multifaceted approach with an emphasis on improving dietary intake, early detection, and addressing underlying risk factors. Nutritional strategies play a crucial role in preventing the onset of IDA, while appropriate supplementation and education can further reduce the prevalence of this condition. One of the most effective prevention strategies begins with ensuring that infants receive adequate iron from the outset. Exclusive breastfeeding for the first 6 months of life provides the best source of iron, as breast milk contains highly bioavailable iron. For infants who are not breastfed, iron-fortified formula is recommended. After 6 months, when the infant's iron stores are depleted, introducing complementary iron-rich foods, such as pureed meats, iron-fortified cereals, and legumes, is essential. Iron absorption is enhanced by consuming foods high in vitamin C, such as citrus fruits, which should be incorporated into the diet at this stage. For toddlers and young children, a well-balanced diet is key to preventing iron deficiency anemia. Foods rich in heme iron, such as lean red meat, poultry, and fish, should be prioritized, as they are more easily absorbed by the body than non-heme iron found in plant-based foods. Vegetarian children, or those with limited access to animal products, should be provided with plant-based sources of iron, such as beans, lentils, tofu, and fortified cereals. Since non-heme iron is less efficiently absorbed, pairing these foods with vitamin C-rich foods can enhance absorption. Iron supplementation is an important preventive measure for high-risk groups, including premature infants, children with low birth weight, or those with a history of iron deficiency. In certain regions or populations where IDA is prevalent, public health interventions such as iron fortification of staple foods, e.g. flour, rice, or milk, can have a significant impact on reducing the incidence of iron deficiency in children. Routine iron supplementation is also recommended for adolescent girls, particularly those with heavy menstrual cycles, to help offset the iron lost during menstruation. Preventing iron deficiency anemia also involves addressing the factors that can impair iron absorption. For example, children who consume excessive amounts of cow's milk, particularly before the age of 1, may be at higher risk for IDA due to the low iron content of milk and the potential for milk-induced intestinal blood loss. Limiting milk intake and ensuring a balanced diet is crucial. Additionally, children with chronic diseases such as gastrointestinal disorders, which interfere with iron absorption, may require specialized nutritional guidance and supplementation. In conclusion, effective prevention strategies for iron deficiency anemia in children focus on promoting proper dietary intake of iron-rich foods, providing supplementation when necessary, and addressing underlying health conditions that may impair iron absorption. By ensuring that children receive adequate iron during the critical stages of growth and development, the risk of IDA can be significantly reduced, promoting optimal health and well-being. Treatment protocols and monitoring. The treatment of iron deficiency anemia, IDA, in children is centered around replenishing iron stores and addressing any underlying causes. The primary goal is to restore hemoglobin levels, improve symptoms, and prevent complications. Treatment protocols vary based on the severity of anemia, the age of the child, and the presence of any underlying health conditions. The first line of treatment for IDA is iron supplementation. Oral iron is typically the most effective and preferred method for repleting iron stores. The standard dose for treating IDA is usually 3 to 6 milligrams of elemental iron per kilogram of body weight per day, divided into 2 or 3 doses. Ferrous sulfate is commonly prescribed, although other forms of iron, such as ferrous gluconate or ferrous fumarate, may also be used depending on tolerability. It is important to administer iron on an empty stomach to maximize absorption, although if gastrointestinal side effects such as nausea or constipation occur, it can be taken with food to minimize discomfort. Iron supplementation should be continued for at least 3 to 6 months after normalization of hemoglobin levels to replenish iron stores. In cases of severe anemia or when oral iron is poorly tolerated, intravenous IV iron may be considered. IV iron is typically reserved for children who cannot tolerate oral iron, those with significant malabsorption issues, or in cases where rapid replenishment is needed. IV iron can be administered in a clinical setting under medical supervision. In addition to iron supplementation, addressing the underlying causes of anemia is essential. For instance, if the child has a gastrointestinal condition affecting iron absorption, such as celiac disease or inflammatory bowel disease, appropriate management of the condition is necessary. If blood loss from conditions like gastrointestinal bleeding or heavy menstruation in adolescents is identified, treating the source of blood loss is crucial. Monitoring the child's response to treatment involves regular follow-up appointments to assess clinical improvement and laboratory values. Hemoglobin levels should be checked within 2 to 4 weeks of starting treatment to evaluate the effectiveness of iron supplementation. A significant rise in hemoglobin, about 1 to 2 grams per deciliter, is usually observed within the first month, with normalization of hemoglobin levels typically occurring within 2 to 3 months. Reticulocyte count is also useful in monitoring bone marrow response. An increase in reticulocytes indicates that the bone marrow is effectively producing red blood cells in response to treatment. Additionally, ferritin levels should be monitored to assess iron stores and ensure that the child is not being oversupplemented. It is important to educate caregivers and children, if age appropriate, on the importance of adhering to the prescribed treatment regimen. Non-adherence can lead to a recurrence of anemia and a prolonged treatment course. Managing side effects of iron supplementation, such as gastrointestinal discomfort, and encouraging iron-rich dietary habits can also aid in successful treatment outcomes. In conclusion, the treatment of iron deficiency anemia in children involves oral or intravenous iron supplementation, addressing underlying causes, and regular monitoring to ensure effective treatment. With proper management and adherence to treatment protocols, most children recover fully from IDA, with improvements in both their clinical symptoms and overall health. Chapter 6, Hemolytic Inherited Anemias. Hemolytic and inherited anemias represent a diverse group of blood disorders characterized by the premature destruction of red blood cells, hemolysis, or genetic defects affecting red blood cell production. These conditions can lead to anemia, which occurs when the body does not have enough healthy red blood cells to carry oxygen efficiently. The causes of hemolytic and inherited anemias are varied, ranging from genetic mutations to autoimmune reactions, and the clinical manifestations can differ based on the underlying condition. Hemolytic anemia is a type of anemia in which red blood cells are destroyed faster than the body can produce them. This destruction of red blood cells can be caused by intrinsic factors, such as hereditary conditions that affect the red blood cells themselves, or extrinsic factors, such as infections, medications, or autoimmune diseases. Common inherited forms of hemolytic anemia include sickle cell disease and hereditary spherocytosis. In sickle cell disease, the red blood cells become abnormally shaped, sickle-shaped, leading to blockages in blood flow and premature destruction. Hereditary spherocytosis is a condition where red blood cells are sphere-shaped rather than the typical biconcave shape, making them more prone to rupture. Inherited anemias are typically caused by genetic mutations that affect hemoglobin production or the structure of red blood cells. Sickle cell anemia is one of the most well-known inherited anemias and is caused by a mutation in the hemoglobin gene, leading to the production of abnormal hemoglobin, hemoglobin S. This abnormal hemoglobin causes red blood cells to become rigid and crescent-shaped, leading to blockages in blood vessels, pain episodes, and early destruction of the cells. Thalassemia, another inherited anemia, is characterized by defective hemoglobin synthesis due to mutations in the genes responsible for producing the alpha or beta globin chains. Depending on the severity, thalassemia can lead to mild or severe anemia and requires lifelong management. G6PD deficiency is another common inherited hemolytic anemia. It results from a deficiency of the enzyme glucose 6-phosphate dehydrogenase, G6PD, which protects red blood cells from oxidative damage. When individuals with G6PD deficiency are exposed to certain triggers, such as infections or specific medications, their red blood cells are more likely to undergo hemolysis. The clinical presentation of hemolytic and inherited anemias can vary. Common symptoms include fatigue, pallor, jaundice, yellowing of the skin and eyes, and an increased heart rate. In severe cases, patients may experience pain episodes, splenomegaly, enlarged spleen, or even life-threatening complications such as stroke in the case of sickle cell disease. Diagnosis involves a combination of clinical evaluation, family history, and laboratory tests, including blood smears, reticulocyte counts, and specific genetic tests. Treatment for hemolytic and inherited anemias varies depending on the specific condition, but may include blood transfusions, pain management, hydroxyurea for sickle cell disease, or bone marrow transplants for severe cases. In conclusion, hemolytic and inherited anemias are a group of disorders with diverse causes and clinical presentations. While these conditions can be challenging to manage, early diagnosis and appropriate treatment can significantly improve outcomes for affected children. Ongoing research into genetic therapies and advanced treatments offers hope for more effective management and potential cures in the future. Sickle cell disease and thalassemia. Sickle cell disease, SCD, and thalassemia are two of the most common inherited hemolytic anemias, both characterized by abnormal hemoglobin production that leads to red blood cell destruction. Although both conditions result in anemia and share some clinical features, they are caused by distinct genetic mutations and have different underlying pathophysiologies, presentations, and treatment approaches. Sickle cell disease is caused by a mutation in the hemoglobin gene that results in the production of abnormal hemoglobin, known as hemoglobin S. When red blood cells containing hemoglobin S are exposed to low oxygen levels, they undergo polymerization, becoming rigid and sickle-shaped. These misshapen cells can block blood flow in small vessels, causing pain crises, organ damage, and an increased rate of red blood cell destruction, hemolysis. The clinical manifestations of sickle cell disease are highly variable, but typically include episodes of severe pain, called sickle cell crises, anemia, delayed growth, frequent infections, and an increased risk of stroke or organ failure. SCD is inherited in an autosomal recessive pattern, meaning that a child must inherit one copy of the sickle cell gene from each parent to develop the disease. Thalassemia, on the other hand, is a group of inherited blood disorders characterized by reduced or absent production of one of the globin chains that make up hemoglobin. There are two main types of thalassemia, alpha and beta, depending on which globin chain is affected. In beta thalassemia, mutations in the beta globin gene lead to a decreased production of beta globin chains, resulting in an imbalance in hemoglobin production. This imbalance leads to the formation of abnormal red blood cells that are more fragile and prone to destruction, resulting in anemia. Beta thalassemia can vary in severity, with thalassemia major, also known as Cooley's anemia, causing severe anemia and requiring lifelong blood transfusions, while thalassemia minor is usually asymptomatic or presents with mild anemia. Alpha thalassemia is caused by deletions or mutations in the genes responsible for alpha globin production, leading to varying degrees of anemia. The clinical presentation of both conditions includes pallor, fatigue, and splenomegaly, enlarged spleen, as the body tries to compensate for the increased destruction of red blood cells. In sickle cell disease, however, additional symptoms such as painful crises, organ damage, and increased risk of infections are more common. Thalassemia patients may experience more chronic complications related to iron overload due to frequent blood transfusions. Diagnosis of both sickle cell disease and thalassemia is based on blood tests, including hemoglobin electrophoresis, which can detect abnormal hemoglobin types, and genetic testing to identify the specific mutations. Management of these conditions typically involves supportive care, blood transfusions, iron chelation therapy to prevent iron overload from transfusions, and, in some cases, bone marrow or stem cell transplants. In conclusion, while sickle cell disease and thalassemia are both inherited anemias that affect red blood cell production, they differ significantly in their pathophysiology and clinical presentation. Early diagnosis and appropriate management are critical to improving the quality of life and prognosis for children with these conditions. Ongoing advances in genetic therapies offer hope for more effective treatments in the future. G6PD deficiency and other enzyme disorders. G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, and other enzyme disorders are a group of inherited conditions that affect the functioning of red blood cells. These disorders typically result in hemolytic anemia, which occurs when red blood cells are prematurely destroyed, leading to a shortage of healthy red blood cells. While G6PD deficiency is the most common enzyme deficiency leading to hemolytic anemia, other enzyme defects can also contribute to red blood cell instability and subsequent anemia. G6PD deficiency is caused by mutations in the G6PD gene, which provides instructions for producing the G6PD enzyme. This enzyme plays a crucial role in protecting red blood cells from oxidative stress, a condition where harmful reactive molecules damage cell structures, including cell membranes. In individuals with G6PD deficiency, the lack of sufficient G6PD enzyme makes red blood cells more vulnerable to oxidative damage. Hemolysis can occur after exposure to specific triggers, such as certain medications, e.g., sulfa drugs, aspirin, infections, or foods like fava beans, a condition known as favism. The resulting hemolysis can lead to symptoms such as jaundice, fatigue, and pallor. G6PD deficiency is inherited in an X-linked recessive manner, meaning it primarily affects males, while females are typically carriers. The severity of hemolytic episodes in G6PD deficiency can vary depending on the degree of enzyme deficiency and the presence of triggering factors. Most affected individuals are asymptomatic between episodes, but during oxidative stress, they may experience acute hemolytic anemia, which can be life-threatening in severe cases. The diagnosis of G6PD deficiency is confirmed through blood tests measuring G6PD enzyme activity and genetic testing can identify mutations in the G6PD gene. In addition to G6PD deficiency, there are other inherited enzyme disorders that can lead to hemolytic anemia. One example is pyruvate kinase PK deficiency, which is caused by mutations in the PKLR gene. Pyruvate kinase is an enzyme involved in energy production within red blood cells. A deficiency in this enzyme leads to a reduced ability of red blood cells to produce energy, causing them to become fragile and prone to hemolysis. Symptoms of pyruvate kinase deficiency can range from mild anemia to severe hemolytic episodes, and it is typically diagnosed through enzyme activity tests. Another example is glucose 6-phosphate isomerase deficiency, a rare condition that also results in hemolytic anemia. This enzyme disorder impairs the glycolytic pathway, which is essential for energy production in red blood cells, leading to red blood cell destruction. The management of G6PD deficiency and other enzyme disorders focuses on avoiding known triggers of hemolysis. This may include avoiding certain medications, infections, and foods that can induce oxidative stress. In cases of acute hemolysis, treatment may involve supportive care, including blood transfusions if necessary. In severe cases, patients with pyruvate kinase deficiency or other enzyme disorders may require more intensive treatment, such as splenectomy, to reduce the frequency of hemolytic episodes. In conclusion, G6PD deficiency and other enzyme disorders are important causes of hemolytic anemia in children. Although these conditions are typically manageable with careful avoidance of triggers, prompt diagnosis and appropriate management are crucial to prevent serious complications. With ongoing advancements in genetic testing and treatment options, the prognosis for affected individuals continues to improve. Genetic counseling and family screening. Genetic counseling and family screening play a crucial role in the management of inherited anemias, such as sickle cell disease, thalassemia, G6PD deficiency, and other enzyme disorders. These conditions are passed down through generations, and understanding the genetic basis of these diseases allows for better risk assessment, early diagnosis, and informed decision-making for affected families. Genetic counseling involves providing families with information about the genetic causes of inherited blood disorders, the risks of passing these conditions to offspring, and available testing options. It helps parents understand the inheritance patterns, which may be autosomal recessive, autosomal dominant, or X-linked, depending on the specific condition. In autosomal recessive disorders, like sickle cell disease and thalassemia, both parents must carry one copy of the mutated gene for a child to inherit the condition. In X-linked conditions, such as G6PD deficiency, the gene is located on the X chromosome, and males are more likely to be affected, while females are typically carriers. During genetic counseling, families can discuss their concerns about having children with inherited anemias. Counselors provide information about the likelihood of the condition occurring in future pregnancies, the availability of prenatal testing, such as chorionic villus sampling or amniocentesis, and options like pre-implantation genetic diagnosis, PGD, for couples undergoing in vitro fertilization, IVF. This information empowers families to make decisions aligned with their values and preferences. Family screening is an essential component of genetic counseling, particularly for conditions like sickle cell disease and thalassemia, which may be undiagnosed in some family members. Screening can identify carrier status, allowing for early intervention and prevention strategies. For example, screening siblings of affected individuals can identify carriers who may be at risk of having affected children. In the case of sickle cell disease, newborn screening programs in many countries can detect the disease early, enabling prompt treatment and reducing complications. Carrier screening for conditions like thalassemia or G6PD deficiency is also beneficial in regions where these conditions are more prevalent. By identifying carriers, families can make informed decisions about marriage and reproduction. Additionally, some countries have implemented routine carrier screening programs, especially for individuals of specific ethnic backgrounds at higher risk for these genetic disorders. In conclusion, genetic counseling and family screening are integral in managing inherited anemias. They provide families with the knowledge needed to understand the genetic nature of these conditions, assess the risks for future generations, and make informed decisions about family planning and preventive care. With the help of genetic counseling and screening, families can receive appropriate support, leading to better outcomes for individuals with inherited anemias and their families. Chapter 7: Anemia of Chronic Disease and Bone Marrow Failure. Anemia of chronic disease, ACD, and bone marrow failure are two important causes of anemia that occur as a result of underlying medical conditions such as chronic inflammation, infection, or bone marrow dysfunction. These conditions affect the body's ability to produce or maintain an adequate number of red blood cells, leading to symptoms of anemia, including fatigue, pallor, and weakness. Anemia of chronic disease, also known as anemia of inflammation, is commonly seen in patients with chronic conditions such as autoimmune diseases, chronic infections, cancer, or renal failure. The underlying mechanism involves the body's inflammatory response, which alters iron metabolism and red blood cell production. During chronic illness, inflammatory cytokines, particularly interleukin 6, IL-6, stimulate the liver to produce hepcidin, a protein that decreases iron availability by inhibiting iron absorption and limiting iron release from stores. This reduction in available iron, combined with impaired red blood cell production by the bone marrow, results in anemia. The anemia seen in ACD is typically mild to moderate and can improve with the treatment of the underlying disease. However, in some cases, particularly in chronic kidney disease, erythropoietin levels may be insufficient, exacerbating the anemia. The diagnosis of anemia of chronic disease is primarily based on clinical history, laboratory findings, and ruling out other causes of anemia. Common laboratory findings include low serum iron levels, low transferrin saturation, and normal or elevated ferritin levels, which is in contrast to iron deficiency anemia, where ferritin levels are low. Treatment usually focuses on managing the underlying condition causing the inflammation or infection. In some cases, erythropoiesis-stimulating agents or iron supplementation may be considered to help improve red blood cell production. Bone marrow failure refers to a condition where the bone marrow fails to produce sufficient amounts of one or more types of blood cells, including red blood cells. This can result from intrinsic bone marrow disorders, such as aplastic anemia, or as a consequence of other conditions like leukemia or myelodysplastic syndromes. In bone marrow failure, the marrow becomes unable to generate enough healthy red blood cells, leading to pancytopenia, a decrease in red blood cells, white blood cells, and platelets. Aplastic anemia, which can be acquired or inherited, is characterized by a hypocellular bone marrow that fails to produce adequate blood cells. The causes of bone marrow failure can include autoimmune diseases, viral infections, exposure to toxins or certain medications, and genetic disorders. The clinical presentation of bone marrow failure includes symptoms of anemia, such as fatigue and pallor, along with signs of leukopenia, frequent infections, and thrombocytopenia, easy bruising or bleeding. Diagnosis involves blood tests showing low levels of all blood cell types and a bone marrow biopsy, which reveals a decrease in the number of blood-forming cells. Treatment options for bone marrow failure depend on the underlying cause and may include blood transfusions, immunosuppressive therapy, or stem cell transplantation for severe cases. In conclusion, anemia of chronic disease and bone marrow failure are two significant causes of anemia that require careful diagnosis and management. ACD is primarily a result of chronic inflammation, while bone marrow failure stems from dysfunction within the marrow itself. Identifying and treating the underlying condition is essential for improving the anemia and preventing complications associated with these conditions. Role of inflammation and chronic infection. Inflammation and chronic infection play significant roles in the development of anemia of chronic disease, ACD, a common form of anemia seen in patients with long-term illnesses. Inflammatory cytokines and immune responses triggered by infection or inflammation disrupt normal iron metabolism and red blood cell production, leading to anemia. Understanding the mechanisms behind this process is essential for diagnosing and managing ACD in pediatric and adult patients. When the body encounters an infection or inflammatory condition, it activates the immune system to fight off pathogens and repair damaged tissue. During this response, immune cells release a variety of cytokines, such as interleukin 6, IL-6, tumor necrosis factor alpha, TNF-I, and interferons. These cytokines play a crucial role in regulating immune function and promoting inflammation. However, prolonged or excessive inflammation, as seen in chronic infections or autoimmune diseases, can interfere with normal hematopoiesis, blood cell production, leading to anemia. One of the key mechanisms by which inflammation contributes to anemia is the alteration of iron metabolism. In response to inflammatory cytokines, the liver increases the production of hepcidin, a hormone that regulates iron homeostasis. Hepcidin reduces iron absorption from the gut and inhibits the release of iron from storage sites, such as the liver and spleen. This reduction in circulating iron makes it less available for red blood cell production in the bone marrow, resulting in anemia despite adequate iron stores. In chronic infections, the body essentially sequesters iron to prevent pathogens from using it for their growth. But this also leads to a deficiency of iron for red blood cell production. Furthermore, chronic infection or inflammation can lead to bone marrow dysfunction. Inflammatory cytokines can suppress erythropoiesis, the process by which red blood cells are produced. This suppression occurs through direct effects on the bone marrow, as well as through changes in the levels of erythropoietin, a hormone that stimulates red blood cell production. In conditions like chronic kidney disease, where inflammation is a persistent problem, erythropoietin levels are often insufficient, exacerbating the anemia. The management of anemia associated with chronic infection and inflammation focuses on treating the underlying disease. Controlling the infection or reducing inflammation can help alleviate the anemia by normalizing iron metabolism and improving erythropoiesis. In some cases, iron supplementation, erythropoiesis-stimulating agents, or other supportive therapies may be necessary to address the anemia directly. In conclusion, inflammation and chronic infection significantly contribute to the development of anemia of chronic disease. The disruption of iron metabolism and suppression of red blood cell production are central to the pathophysiology of ACD. Proper diagnosis and management of the underlying inflammatory or infectious condition are critical in improving the anemia and overall health of affected individuals. Bone marrow disorders in children. Bone marrow disorders in children refer to a range of conditions in which the bone marrow, the primary site for blood cell production, fails to function properly. These disorders can result in a reduced number of red blood cells, white blood cells, or platelets, leading to various symptoms such as anemia, recurrent infections, and easy bruising or bleeding. Bone marrow disorders in pediatric patients can be acquired or inherited with a diverse set of underlying causes and varying severity. One of the most common bone marrow disorders in children is aplastic anemia, a condition in which the bone marrow becomes hypocellular, meaning it produces insufficient numbers of blood cells. This can be caused by autoimmune attacks on the bone marrow, viral infections, exposure to toxins, or as a side effect of certain medications. In severe cases, aplastic anemia can lead to pancytopenia, where all blood cell lines, red blood cells, white blood cells, and platelets are reduced, leading to life-threatening complications such as bleeding and infection. Aplastic anemia can be diagnosed through blood tests and a bone marrow biopsy. Treatment typically involves immunosuppressive therapy, bone marrow stimulation, or hematopoietic stem cell transplantation. Another important bone marrow disorder is myelodysplastic syndromes, MDS, a group of disorders caused by abnormal development of blood cells in the bone marrow. Children with MDS may experience anemia, infections, and bleeding, similar to those with aplastic anemia, but the underlying issue is the abnormal differentiation and maturation of blood cells. MDS can sometimes progress to acute leukemia, a type of cancer of the blood. Treatment options for MDS depend on the subtype of the disorder and may include chemotherapy, stem cell transplantation, or supportive care. Inherited bone marrow disorders, such as Fanconi anemia, Diamond-Blackfan anemia, and Shwachman-Diamond syndrome, are also important causes of bone marrow failure in children. These genetic conditions affect the bone marrow's ability to produce sufficient blood cells and may be associated with other congenital abnormalities or developmental delays. Diagnosis often involves genetic testing, and treatment may include blood transfusions, growth factors, or stem cell transplants, depending on the severity and progression of the disease. In conclusion, bone marrow disorders in children are a group of conditions that can significantly impact a child's health and quality of life. Timely diagnosis and appropriate treatment are essential to managing these disorders and preventing serious complications. Advances in medical research and treatment options continue to improve the prognosis for children with these conditions. Approach to pancytopenia and aplastic anemia. Pancytopenia and aplastic anemia are serious conditions characterized by a reduction in the number of all three types of blood cells: red blood cells, white blood cells, and platelets. These conditions can lead to symptoms such as fatigue, infections, easy bruising, and bleeding, and require prompt evaluation and management. Understanding the causes, diagnostic approach, and treatment options for pancytopenia and aplastic anemia is crucial for pediatricians and hematologists. Pancytopenia occurs when there is a significant decrease in all three blood cell lines. It can result from a variety of causes, including bone marrow disorders, autoimmune diseases, infections, or the effects of medications or toxins. In children, common causes of pancytopenia include aplastic anemia, myelodysplastic syndromes, leukemia, and certain viral infections such as parvovirus B19 or Epstein-Barr virus. The first step in the approach to pancytopenia is a thorough clinical evaluation, including a detailed medical history, physical examination, and laboratory tests to identify the underlying cause. Aplastic anemia is a type of pancytopenia where the bone marrow fails to produce enough blood cells, resulting in severe anemia, neutropenia, low white blood cells, and thrombocytopenia, low platelets. This condition can be acquired or inherited. The acquired form is often associated with autoimmune diseases, viral infections, or exposure to certain chemicals or medications. Inherited forms, such as Fanconi anemia, are caused by genetic mutations and present with more complex symptoms. Aplastic anemia is typically diagnosed through blood tests showing low levels of all three blood cell types, along with a bone marrow biopsy that reveals a hypocellular marrow with reduced blood-forming cells. The diagnostic approach to pancytopenia and aplastic anemia involves ruling out other causes of bone marrow failure, such as leukemia or myelodysplastic syndromes. In addition to routine blood tests and bone marrow biopsy, genetic testing may be required in cases of suspected inherited disorders. It is also essential to evaluate for autoimmune diseases, viral infections, and environmental exposures that could contribute to the condition. Treatment for pancytopenia and aplastic anemia depends on the underlying cause and the severity of the symptoms. In cases of acquired aplastic anemia, immunosuppressive therapy, such as antithymocyte globulin, ATG, and cyclosporine, may be used to stimulate the bone marrow. For children with severe cases, hematopoietic stem cell transplantation may be required. Supportive care, including blood transfusions and antibiotics to treat infections, is often necessary. In cases of inherited forms, such as Fanconi anemia, stem cell transplantation remains the mainstay of treatment. In conclusion, pancytopenia and aplastic anemia are serious hematologic conditions that require a comprehensive diagnostic approach. Early recognition and appropriate treatment are essential for improving outcomes in affected children. Chapter 8: Management and Follow-up. The management and follow-up of childhood anemia are crucial components in ensuring that affected children achieve optimal health outcomes and that the underlying causes of anemia are effectively addressed. Treatment strategies are tailored to the specific type of anemia, its severity, and the child's overall health. The approach often involves a combination of pharmacologic treatments, nutritional interventions, and ongoing monitoring. For most types of anemia, including iron deficiency anemia and anemia of chronic disease, the primary treatment focuses on correcting the underlying cause. In iron deficiency anemia, oral iron supplementation is the cornerstone of treatment. In cases of severe anemia, or when oral supplementation is not tolerated, intravenous iron may be used. Nutritional counseling is also important to ensure that the child receives an adequate diet rich in iron, vitamin B12, and folate. In anemia of chronic disease, managing the underlying inflammatory or infectious condition is key. This may involve treating infections, using anti-inflammatory medications, or managing chronic conditions like autoimmune diseases. For hemolytic anemias or inherited conditions such as sickle cell disease or thalassemia, the management approach varies. Sickle cell disease, for example, may require regular blood transfusions, pain management, and potentially hydroxyurea therapy to reduce complications like vaso-occlusive crises. Thalassemia often requires lifelong blood transfusions and chelation therapy to manage iron overload. Bone marrow or stem cell transplantation may be considered in severe cases of these conditions. When dealing with anemia resulting from bone marrow failure or aplastic anemia, the management may involve immunosuppressive therapy or hematopoietic stem cell transplantation. Treatment for inherited bone marrow disorders may require blood transfusions, growth factors, or even bone marrow transplant, depending on the severity of the disease. Follow-up care is a critical aspect of anemia management. Regular monitoring of blood counts helps assess the effectiveness of treatment and guide adjustments as necessary. For conditions requiring long-term therapy, such as sickle cell disease, thalassemia, or anemia of chronic disease, continuous follow-up ensures that potential complications, such as organ damage or infections, are detected early. In conclusion, the management of childhood anemia requires a multifaceted approach tailored to the underlying cause. Regular follow-up and monitoring are essential to ensure that treatment remains effective and to prevent potential long-term complications. Early and comprehensive care improves outcomes for children with anemia and promotes healthier, more active lives. Acute care versus long-term management. The distinction between acute care and long-term management in childhood anemia is essential for optimizing outcomes, as these two approaches address different aspects of the disease. Acute care focuses on immediate intervention to stabilize the child, while long-term management ensures sustained health and addresses underlying causes over time. Acute care in childhood anemia primarily involves addressing the immediate symptoms of anemia, such as fatigue, pallor, and more severe manifestations like tachycardia or respiratory distress. In cases of severe anemia, such as that seen in acute blood loss, hemolytic crises, or severe iron deficiency, the goal is to rapidly restore the child's blood volume and oxygen-carrying capacity. This often involves blood transfusions or intravenous fluids, along with medications such as iron supplements or erythropoiesis-stimulating agents, depending on the underlying etiology. Acute management aims to stabilize the child and prevent complications like organ damage or hypoxia. Once the child is stabilized, long-term management becomes a priority. Long-term management involves addressing the root causes of anemia, preventing recurrence, and ensuring the child's health is maintained over time. For instance, children with chronic conditions like sickle cell disease or thalassemia require continuous blood transfusions to prevent complications and manage iron overload. In cases of iron deficiency anemia, long-term iron supplementation and dietary changes are necessary to replenish iron stores and prevent relapse. Regular monitoring of blood counts, nutritional status, and organ function is also essential to manage chronic forms of anemia effectively. For children with inherited or chronic forms of anemia, such as hereditary spherocytosis or anemia of chronic disease, long-term management often includes ongoing therapies like folate supplementation, blood transfusions, or treatments for underlying conditions, such as anti-inflammatory medications or immunosuppressive therapy. Additionally, addressing potential complications such as growth delays, infections, or iron overload is an integral part of long-term care. In conclusion, acute care and long-term management in childhood anemia complement each other in a comprehensive approach to treatment. Acute care focuses on stabilizing the child and alleviating immediate symptoms, while long-term management ensures ongoing health and addresses the underlying causes of anemia to prevent recurrence and complications. Both are critical to improving the child's quality of life and ensuring optimal health outcomes. Role of multidisciplinary teams. The management of childhood anemia, especially in complex or severe cases, benefits significantly from the involvement of multidisciplinary teams. These teams, composed of healthcare professionals from various specialties, collaborate to provide comprehensive care that addresses not only the anemia itself, but also its underlying causes and associated complications. The role of these teams is crucial for ensuring the best possible outcomes for pediatric patients. A multidisciplinary team typically includes pediatric hematologists, who specialize in blood disorders, along with other specialists such as dietitians, pediatricians, immunologists, and social workers. The pediatric hematologist is central to diagnosing and treating the anemia, providing the necessary expertise in managing the various forms of anemia, from iron deficiency anemia to complex inherited disorders like sickle cell disease and thalassemia. These specialists work closely with other team members to design individualized treatment plans that are tailored to the child's specific needs. Dietitians play a critical role in the management of nutritional anemias, such as iron deficiency anemia or anemia due to vitamin B12 or folate deficiencies. They assess the child's nutritional intake and provide guidance on dietary modifications, ensuring the child receives the appropriate nutrients to correct and prevent future deficiencies. A well-balanced diet is essential in supporting overall health and in optimizing the child's ability to respond to treatment. In cases of anemia associated with chronic disease or immune-mediated conditions, immunologists or rheumatologists may be involved. These specialists help manage the underlying autoimmune or inflammatory conditions that contribute to anemia. They guide the use of medications like immunosuppressants or biologics that may be necessary to control the underlying disease process and improve anemia outcomes. Social workers and psychologists are also vital members of the multidisciplinary team, particularly when anemia is associated with chronic illness or long-term treatments, such as blood transfusions or stem cell transplantation. These professionals provide emotional support to the child and their family, helping them cope with the psychological stress that often accompanies chronic illness. They also assist with navigating healthcare systems, addressing financial concerns, and ensuring access to necessary resources. In conclusion, the role of multidisciplinary teams in the management of childhood anemia is indispensable. By pooling their expertise, these teams provide holistic care that addresses the physical, emotional, and social aspects of the child's health, ensuring the best possible outcomes and improving the quality of life for children with anemia. Monitoring growth, development, and treatment response. Monitoring the growth, development, and treatment response of children with anemia is an essential aspect of their ongoing care. Since anemia can affect various bodily functions, including energy levels, immune function, and organ development, it is crucial to track both the clinical progress of the child and their developmental milestones. Regular assessments help identify any delays or complications early, ensuring timely intervention and improving long-term outcomes. Growth monitoring is a primary concern in children with anemia, particularly when the condition is chronic or severe. Anemia can affect appetite and overall energy levels, which may in turn impact a child's growth trajectory. Therefore, regular measurement of height, weight, and body mass index, BMI, is necessary to assess if the child is growing at an appropriate rate. Growth charts specific to age and sex are used to compare a child's growth with established norms. If growth delays are identified, the healthcare team may adjust the treatment plan to address underlying nutritional deficiencies, optimize anemia management, or explore other contributing factors. Developmental monitoring is equally important, especially in children with severe or long-standing anemia. Anemia can affect cognitive and motor development, as the body's ability to deliver oxygen to the brain and other organs may be compromised. Regular developmental screenings allow healthcare providers to identify delays in milestones such as speech, motor skills, and social-emotional development. Early intervention is essential in addressing these concerns, with strategies such as physical therapy, speech therapy, or cognitive support being implemented as needed. Treatment response is another critical area of monitoring in pediatric anemia management. The primary goal of treatment is to correct the underlying cause of anemia and restore normal blood cell levels. Routine blood tests, including complete blood counts, CBC, reticulocyte counts, and iron studies, are essential for evaluating the effectiveness of treatment. For example, in cases of iron deficiency anemia, the child's hemoglobin levels, ferritin, and transferrin saturation are closely monitored to ensure that iron supplementation is achieving the desired effect. In cases of more complex or chronic anemias, such as a sickle cell disease or thalassemia, ongoing monitoring may include regular blood transfusions, hydroxyurea therapy, or iron chelation therapy. Response to treatment is also assessed through clinical observations, such as improvement in energy levels, reduction in the frequency of infections, or better management of pain or fatigue. In conclusion, consistent monitoring of growth, development, and treatment response is crucial for children with anemia. These assessments ensure that any delays or complications are identified early and that treatment is adjusted as needed, helping to optimize outcomes and improve the child's overall well-being. Conclusion. Childhood anemia is a complex and multifaceted condition that requires a thorough understanding of its various causes, clinical presentations, diagnostic approaches, and treatment options. From nutritional deficiencies to chronic diseases, hemolytic anemias, and genetic disorders, the underlying causes of anemia in children are diverse and often interrelated. Early detection, accurate diagnosis, and prompt intervention are critical for preventing long-term complications and ensuring the best possible outcomes for affected children. Throughout this handbook, we have explored the different types of anemia, including iron deficiency anemia, inherited blood disorders like sickle cell disease and thalassemia, and anemia resulting from chronic conditions or bone marrow failure. Each type requires a tailored approach with specific treatment protocols, nutritional interventions, and in some cases, ongoing management for chronic conditions. Importantly, effective treatment not only aims to resolve the anemia itself, but also addresses the root causes, such as nutritional deficiencies or immune-mediated disorders. The role of healthcare providers, particularly pediatricians, hematologists, dietitians, and multidisciplinary teams, is vital in providing comprehensive care. Collaborative care that incorporates expertise from various specialists ensures a holistic approach to managing anemia, addressing not just the physical aspects of the condition, but also the psychological and social needs of the child and family. Regular monitoring of growth, development, and treatment response is necessary to assess progress and identify potential complications early. Equally important is the recognition of the importance of prevention strategies, particularly in resource-limited settings where access to healthcare and proper nutrition may be challenging. Educating families about the importance of a balanced diet, proper nutrition, and regular health checkups is key to reducing the burden of anemia globally. Additionally, Promoting awareness about genetic conditions and providing access to genetic counseling can help in the early identification and management of inherited anemias. In conclusion, childhood anemia is a condition that demands a comprehensive, individualized approach to treatment and management. The collaborative efforts of a multidisciplinary team, ongoing monitoring, and targeted interventions can significantly improve the health outcomes and quality of life for children living with anemia. As we continue to advance in the understanding of anemia and its management, the prospects for children affected by this condition will continue to improve, ensuring a brighter, healthier future for those impacted.